Omar is one of the inductees for this evening, and he will be chairing this session with me. Thank you.
Good morning, my teachers and colleagues. It's a privilege to be moderator this session. We're having the scientific presentation. We received a total of 19 abstracts, 10 original researches, and then 9 case reports. But due to time constraint, we're not able to give everybody the opportunity to present. So we selected 4 for this presentation. 2 original researches and 2 case presentation. All the remaining submitted work have actually been published on the scientific proceedings, and then they'll also be displayed on the board. You can be able to see them appropriately. The 4 presentations we are going to listen to are as follows. We have the EGFR and HER2 expression in cervical cancer patients who attended the radiotherapy clinic, University College Hospital, Ibadan. And the presenter is Dr. A.A. Orekoya. She around, right? No, we are basing ourselves based on what is submitted here. Where is the presenter? All right, the second research we are going to discuss here is anthropometric indices associated with prostate cancer in Nigerian men. And the person to present is Dr. Kehinde Oluwatosin Adeyinka. Doctor, you're welcome. Then the 2 case reports we are going to have today is number 1 is locally advanced cervical cancer with precious pregnancy, a case report. And the presenter is Dr. Munir Sani. Doctor, you're welcome. And then the last presentation is financial toxicity in a case report on financial toxicity in a HER2 type breast cancer by Dr. Hannatu Ayuba. Where's Dr. Hannatu Ayuba? We want the presenters to be seated before we start as much as possible. So without wasting much time, just go to the rules. The rule is that you have 10 minutes, maximum of 10 minutes to present. You cannot exceed 10 minutes. However, you can choose to go below 10 minutes. When it's 5 minutes, you will be given a small warning. When it's 7 minutes, you'll be given a warning. And then when we hit finally, you just have to stop wherever you are. So the warnings are for you to be able to ensure that you utilize the time properly. You see that the conference is very tight and we cannot be able to afford to lose any minutes unnecessarily. So thank you very much. It's my pleasure to invite Dr. Kehinde Adeyinka for your presentation.
But we know the same. Okay. This is not mine. Sorry, that topic is not mine. Mm. Anthropometric index. Okay. Mhm. Good morning, everyone. All protocols duly observed. I'm Kende Adenka, and I'll be presenting my abstract titled Anthropometric Indices Associated with Prostate Cancer in Nigerian Men. First, I'd like to acknowledge that this project was conducted as part of a one-year clinical research and mentorship program in 2020-2021, organized by ACON under the leadership of Dr. Amaka Laoshibikon, and it was in collaboration with Princess Margaret Cancer Center, Toronto, and MD Anderson Cancer Center, Texas, funded by Global Access to Cancer Care. This study was it involved 16 authors, 12 of which were from 4 centers in Nigeria and 4 from other institutions outside. So we'll move straight to the so by way of introduction, prostate cancer, we all know, is a public health problem globally, the second most common cancer in men worldwide, and the 5th leading cause of cancer deaths in men. In Nigeria and many sub-Saharan African countries, it is the most common cancer and the leading cause of cancer deaths in men. But little is known about its etiology. There are few established risk factors, including age, race, particularly Black race, and family history of prostate cancer. Body fatness, which is the accumulation of fat in specific areas like the visceral, subcutaneous, hip, is a probable risk factor for prostate cancer, modifiable and measurable by anthropometric indices like the body mass index, waist circumference, hip circumference, with hip ratio. Anthropometric indices and prostate cancer has not been explored among Nigerian men, hence the study. The study intended to test the hypothesis that states that anthropometric indices are higher in prostate cancer patients compared to age-matched control. The study was a case control study carried out in 4 university hospitals, including University College Hospital, Lagos State University Teaching Hospital, LASUT, Lagos University Teaching Hospital, LUTH, and Obafemi Awolowo University Teaching Hospital. It was conducted over a period of 6 months during the program, the CRMP program. The cases were newly histologically diagnosed prostate cancer patients between the ages of 50 and 75 years, and they were recruited majorly from the urology clinic, some from the radiation oncology clinic. The cases were age matched, confirmed to have normal PSA because we ran PSA on all of them, and they were recruited from the general outpatient clinic of all the centers. In both groups, patients with weight loss in the past month and poor performance status equal greater or equal to 3, and uncontrolled comorbidities like hypertension, diabetes, dyslipidemia were excluded. The estimated sample size was 74 cases with age-matched control, making a total of 148 participants, and they were selected by consecutive sampling method. The allocation was for cases 20 to OAUTH, 20 to LUT, UCH and LASUT, and 15 to AUTH because of the location kind of remote. And for the control, 25 cases were allocated to UCH, LUT, and LASUT, and 20 to OATH, making 95. This was to give allowance for those that may have abnormal PSA. The data collected included the social demographics and patient history, particularly the lifestyle on exercise, diet, cigarette smoking, alcohol, and also the tumor characteristics in the cases, which included the PSA at presentation, the Gleason score, and the stage. At the time of interview, anthropometric measures were taken, the weight, height, body mass index, which was gotten from the weight and height, the waist circumference, hip circumference, and the waist hip ratio. The data we analyzed on SPSS and t-test was used to compare the anthropometrics between both groups, while chi-square was used to compare the social demographics and the patient history between both groups. The outcome of interest was the comparison of the social demographics and anthropometric between both groups, and the anthropometric indices in the case by the Gleason score or tumor grade. So the result we got at the end of the day, 73 cases were recruited. For control, we invited 95, but 18 of them had abnormal PSA greater than 4 nanogram per ml, leaving us with 75, and which were analyzed. The age range for the cases were 54 to 75 with a mean age of 65.60 years. For the control, the age range was 50 to 74 with a mean age of 60.09 years. And so when we compared both groups, the cases were more likely retired and unemployed, which supports that prostate cancer, that will support that advancing age is a risk for prostate cancer because most of those people are advanced in age. There were no difference in the other social demographics. And when we compare the patient history with them, the cases were more likely not to exercise, to smoke cigarette, to take alcohol, and to have a family history. And the tumor characteristics in the cases, all of them had adenocarcinoma. The mean PSA for the cases was 277.67 nanogram per ml, while for the control was 0.4. A large proportion of them had high-grade disease, 58.9%, and 81.1% of them presented with stage 3 and 4, with the largest proportion of stage being stage 4. Anthropometric indices between both groups, only the waist hip ratio was significantly different. It was higher in the cases. All other indices were not different. And when we compare by grade, there were no difference. Scale study for a more robust result, which will be well represented. 58.9% of high-grade disease in this study is in contrast with the pattern of disease grade among the white. And so there is need for molecular studies to explore genetic determinants of that. 81.1% of them presented at late stage with high proportion having stage 4. There is need for us to do community-based screening so as to reduce the incidence of late presentation, reduce the burden of prostate cancer. Thank you.
Thank you very much, Dr. Kende, for your presentation. You used 6 minutes, 30 seconds, so you're within time. The remaining 3 minutes, we would like to entertain maybe one on what she has.
make this conclusion for a population of 220 million people.
Okay, thank you very much, sir. The third question or comment.
Okay, so I think that Dr. Nwachukwu Emanuela, I think it's in relation to Dr. Bello's question. Yes, it was still looking at 75 people as an industry used to say that there's no relation. I think that's small enough. And I'm also looking at the fact that if most of the patients that you had prostate cancer are patients with advanced prostate cancer, would that be the reason why you did not find, or well, why you found some? Because I think it's best for us to look for people who you're screening as the people who will still be healthy enough to relate their waist-hip ratio to their development of prostate cancer than people who have been diagnosed and even diagnosed with 81% being stage 4 cases. Now, those are people who have had prostate cancer for longer than the control. So I don't think it was matched properly. That's what I'm thinking. But I don't know, maybe you could explain further.
Okay. Thank you very much for your questions and contributions. Dr. Kende, can you respond in 2 minutes?
Hello, okay. Thank you for those questions. The first question, if there was call for the lifestyle pattern, no. We only asked if they had regular exercise, at least 30 minutes, 3 to 4 times a week. And we asked if they smoked cigarettes or drank alcohol. So there was no scoring pattern for that. Now, for conclusion, if it's enough, my conclusion, if it's enough for the population size, the study was conducted over 6 months, and that was why I said one of these. What I said was there's need for a large-scale population. Large-scale study, which will give us a more robust result that is well representing. And then for the anthropometric measurements, one of the inclusion criteria were patients that are newly diagnosed. Some patients, though newly diagnosed, may not know until they start developing symptoms. And exclusion criteria were weight loss in the past month. So that we could get it could be more representing. Anyone with weight loss in the past month were excluded, and then newly histologically diagnosed patients were part of the inclusion criteria, so as to be able to get rid of any form of bias. I think I'm done with the question. Thank you.
Very much. Thank you very much, Dr. Kende. Thank you very much, Dr. Kende, for the thought-provoking presentation. And we hope that further studies will be made to answer some of these gaps we are noticing. Without wasting much time, I would like to invite the presenter for the second scientific research, which is EGFR and HER2 expression in cervical cancer patients who attend the therapy clinic in UCH Ibadan. You have 7 minutes to make your presentation and then 3 minutes to respond to comment. You're highly welcome.
Good morning, everyone. Standing on the all protocol. I'm Dr. Orekoya, and I'll be presenting EGFR and HER2 expression in cervical cancer patients who presented at the radiotherapy clinic UCH Ibadan from 2006 to 2015. So the study was conducted in UCH, but the authors are from 4 centers. By way of an introduction, cervical cancer is a leading cause of cancer-related deaths in developing countries. In Nigeria, cervical cancer is the second most common female cancer after breast cancer. There have been several studies trying to find molecular prognostic and predictive factors that may determine the survival of cervical patients. A majority of these studies have been done in Caucasians and Asians. Am I the one? Okay. It's going, okay. Majority of these studies have been done in Caucasians and Asians, but none done in indigenous Africans. So there's been no study to determine the relationship of EGFR, which is the epidermal growth factor receptor, also known as HER1, and HER2, human epidermal growth factor receptor 2, and survival and or response to chemoradiation in cervical cancer in indigenous Africans. The main objective of this study was to determine the prevalence of EGFR and HER2 protein expression in cervical cancers in Nigerian patients and to determine their impact on the overall survival of these patients. The study was a retrospective study in which clinical data and tissue blocks of patients who presented in the radiation oncology department, UCH, from 2006 to 2015 were retrieved. And these patients also had their histologies done in the pathology department of UCH. So the tissue blocks were retrieved and analyzed for EGFR and HER2 expression using immunohistochemistry. The data was analyzed using the SPSS software, and Kaplan-Meier and Cox regression analysis were done. The results were that EGFR was found to be expressed in 26.6% of the 124 cervical tissue samples tested. And majority of those who were EGFR positive were young. They also had squamous cell carcinoma histologies and presented with advanced disease. HER2 was expressed in only 2 samples, overexpressed in only 2 samples. So this is a diagram of the Kaplan-Meier curve showing the survival status of the cervical cancer patient. It was seen that those with EGFR negative who didn't express EGFR had longer survival than, which was statistically significant than those who were EGFR positive. The 5-year overall survival rate of the patients was 28.3%. So in conclusion, EGFR was overexpressed in 26.6% of the 124 patients and was significantly associated with poorer survival. Screening for EGFR should be considered in cervical cancer patients. Thank you.
Thank you very much, Doctor, for your presentation. We also want to entertain questions, comments on this presentation. Please, if you want to make any comments, please kindly indicate so that we will assign numbers. One, two, three. All right. Please, you will note maybe all the questions, then you respond to them at once. Yes. Okay, please start.
Oh, okay. Thank you very much, Doc. My name is Solomon Rotimi. That's a beautiful thing to know that a quarter of them express EGFR. The question is, what do we make of that? Do you see that as a potential target for therapy for those a quarter of such patients? And if that is so, do you see that as potential for us to improve the overall outcome? And really, what else? And if you can't answer this, that's fine. This second one. So, what do you think that EGFR does in the biology of cervical cancer?
Okay, thank you very much, Prof. The second, maybe come here.
Okay, thank you very much for your presentation. I just wanted clarification as to where the immunohistochemistry was done. Was it done locally at UCH Ibadan, or did you have to send the samples out? And do you think maybe the quality of tissue could have affected your results? Really, I agree with Prof that I think maybe we should look into targeting, EGFR in these patients if we're able to really get up to a quarter of them. Thank you. It was a very good research.
Thank you very much. The third,
Thank you very much, my fantastic research. I must applaud you. Very good job. My question is for the EGFR expression. Were you able to relate from your literature review? What was the expression in Caucasians and then compare to Africans, and then see possibly if you were able to check up any studies where anti-EGFR medications were used in Caucasians and possibly their response to the anti-EGFRs, and then possibly related to Africans, because like you said, one of the biggest issues is relating research done in Caucasians down to Africans here. Good job again, ma.
okay. Thank you very much for your questions and response. Please, you have the floor to.
Thank you very much for the questions. So the first question had to do with should we target EGFR since it was overexpressed in more than 25% of patients? I think it's an avenue for us to try to do larger prospective studies. Part of the problems I had while doing this study was because there were a lot of samples lost, and also some of the tissue blocks that we got couldn't be used for the study. So I'm thinking that if we have larger prospective studies, maybe multi-center, we'll be able to know truly the prevalence of EGFR expression in cervical cancer patients in Nigeria, and also see if it could be a target for using cetuximab and other drugs to see if patients will improve on this. Cervical patients who overexpress EGFR will have better survival. What does it do to the biology of cervical cancer? EGFR has been shown to increase the EGFR positive tumors have been shown histologically to be, and they are usually of higher grade. EGFR confers, I can't really explain the biochemical mechanisms, but it infers aggressiveness on tissues in cervical cancer and also in other cancers in other parts of the body. Where was IHC done? The immunohistochemistry was done at the IMRAT lab in Ibadan, and it was reviewed by 4 pathologists while I was doing it. The quality of the tissue, because it was a retrospective study, getting tissue blocks that were from 2006, yes, a lot of them were not good, but we were able to choose some tissue blocks that had been properly fixed and were good for the study. That was why the sample size was greatly reduced, because we're looking for good tissue blocks for the study. EGFR in Caucasians. The problem with EGFR overexpression is that there have been varying results. Some will say that it's not over. Several studies done, the expression of EGFR ranged from 6% to 100%. And that was because the scores used to determine if it was overexpressed was varied a lot. So I had to choose one that had been sort of standardized, which was the Stegner score. And that used both qualitative and quantitative means, checking how many percent of the cells were stained, and also the intensity of the cell of the staining to determine how many cells were to determine how many cells overexpress EGFR. And studies have been done to determine the expression of the response of cervical cancer patients who overexpress EGFR. The preclinical studies showed great response, but the clinical studies have not been too good. Thank you very much for the question.
Yeah, thank you very much, Doctor, for your presentation. This this particular research is trying to tell us that precision medicine is the way to go in oncology care, and we hope that further studies will be done to answer some of those gray areas or the shortcomings of the research. We are going to go to the third presentation, which is a case report by Dr. Munir Sani from ABUTH Zaria. The case report is locally advanced cervical cancer with precious pregnancy, a case report. Dr. Munir Sani, you have 7 minutes to make your presentation, and then we are going to listen to comment for the next 3 minutes. So
thank you, sir. Good morning, everyone. I'm Dr. Munir Sani from Ahmed Bello University Teaching Hospital, and permit me to stand on existing protocols. I'm here to present a case report on locally advanced cervical cancer with precious pregnancy that was managed in our center. Okay, thank you. Our patient is a 41-year-old Mrs. 41-year-old Yoruba Muslim banker, who was referred to our clinic with histologically confirmed squamous cell carcinoma by the gynae oncologist. Patient had a background history of secondary infertility and was attending fertility clinic. She was a para 1+0 and her last childbirth was 8 years ago. Review of system in the clinic was essentially normal. She's not a non-hypertensive, not a non-diabetic, and not a non-retroviral positive. So on examination in the clinic, her general condition was satisfactory with canopsy performance score of 90%. Pelvic examination done revealed a cervical mass involving the superior to third of the vagina with no parametrial involvement. Other systemic review were essentially normal. Imaging done include all abdominal pelvic ultrasound scan, which reveal a cervical mass measuring 5.0 by 3.0 centimeter, with no sciasis reported at this time. However, there were multiple intramural fibroids that was noted on the ultrasound scan. MRI of the abdomen and pelvis done revealed a cervical mass measuring 5.5 by 4.8 by 4.1 centimeter with parametrial upper to third of the vagina involvement and positive pelvic lymph nodes. Enlarged pelvic lymph node were seen. However, no para-aortic lymph nodes were seen. Also in the MRI, multiple uterine myomas were seen and endometrial collection was seen at the fundal region. However, the radiologist reported the findings as cervical cancer with pelvic lymph node involvement. Chest X-ray done was normal. Blood workup include full blood count and differential that revealed low PCB, which was optimized with blood transfusion. Other parameters were doing normal. Serum electrolyte, urea, and creatinine was normal. Liver function test was normal, and retroviral screen was non-reactive. So this is a copy of the MRI report. So based on the clinical findings and the radiologic investigation, we staged the patient as stage 3C1 according to figure 2018, which was defined as a histologically confirmed cervical cancer with pelvic lymph node metastasis. She was commenced on sequential chemoradiation, beginning with combination chemotherapy using IV cisplatin, 100 milligrams day 1, and IV paclitaxel, 220 milligrams day 1, to be repeated 3 weekly for 6 cycles. However, a week after she received the third cycle, patient complained of gradually increasing painless abdominal mass. When we examined her, we found a pelvic mass that was a size close to 18 week size, close to umbilicus. So at that time, we suspected that she's having a disease progression despite the chemotherapy she's having. So we did an ultrasound scan of the abdomen and pelvis at that time, and that revealed a live second trimester gestation at 18 weeks size, at an 18 week of age. So this is a picture of the printout of the radiograph. I can see, as you can see, there is a live intrauterine fetus with some cardiac activity. So based on this, MDT was convened, comprising of radiation and clinical oncologists, radiologists, obstetric and gynecologists, pathologists, and pediatrician. And after discussion, the MDT recommended 2 options, which were: 1, to terminate the pregnancy in view of the risk of carcinogenesis and death to the fetus, and to continue with her treatment. And the second option is to continue with the chemotherapy until the gestation is at 32 weeks, with the aim to deliver the baby at 36 weeks, or when the baby reaches at least 2 kilogram size. And the baby will be followed up for life. So based on this, patient opted to maintain her pregnancy. The fact that she has been looking for this pregnancy all this while attending fertility clinic. So while she opted to continue with her chemotherapy and while maintaining the pregnancy, to receive 4 more cycles. So based on this recent development, an informed consent was reobtained from the patient, and she was commenced on a focused antenatal care, a 3-weekly antenatal care, during which biophysical profile and anomaly evaluation were done on the fetus. Also, cervical integrity was assessed to see whether the patient can actually maintain the pregnancy up to 36 weeks by the ONG team. This is a copy of the informed consent that was received. She signed, and her husband, together with her husband. So patient had a classical cesarean section at 36 weeks gestational age, which was exactly 4 weeks after the stoppage of the chemotherapy. And she was delivered of a live male neonate measuring 2.4 kilograms weight, with ABGA score of 8 in first minute and 10 in fifth minute, with no physical anomaly at the time of delivery. Baby was admitted at the special care baby unit by the pediatrician and was observed and evaluated, and was later discharged 4 days after with no any symptoms. So the baby was exclusively breastfed for 6 weeks, and at 6 weeks, the patient was re-evaluated. She was found to be with no complaints, and her canopsy performance score was 90 to 100%, and there was obvious improved family bond between the patient and her husband. Normal hemogram, chest X-ray was done, was normal. Abdomen pelvic ultrasound revealed normal postpartum pelvic findings with absence of the cervical mass. Baby was growing well and was fully immunized for age. Patient was referred to NCI LUT for external beam radiotherapy to the pelvis. Thank you. I was told that my time is up. But she had an external beam 50 gray in 25 fractions, and high dose brachytherapy to the 2.8, a dose of 22 gray in 4 fractions. So she was expected to see us 6 weeks after completion of her treatment. And by way of summarizing, this is a case of locally advanced cervical cancer that occurred with precious pregnancy that was successfully managed. Cervical cancer in pregnancy is an uncommon presentation in our oncology clinic. And at the moment, there is no standard guidelines detailing the management. And our recommendations are to evaluate for pregnancy in every cancer, female cancer patients that are within reproductive age during and before the commencement of treatment. And as much as possible, multidisciplinary team meeting should be carried out before taking those decisions. Thank you very much.
Thank you very much, Dr. Munir Sani. You overshoot your 7 minutes by 1.5 minutes extra. So you are going to just entertain one question or comment so that we'll be able to make up for it. I will give the floor to somebody that has not asked any. Let's receive the first comment, and then if there's time, maybe we'll take another one.
Yes, so thank you very much for your presentation. There are a few questions I just want to some clarification on. When was the ultrasound done? What was the distance between when the ultrasound done and when pregnancy was confirmed at 18 weeks? How long was that duration? Because it could be that she wasn't even pregnant before you started treatment, and then she got pregnant before you started. So it's something that you should mention so that it doesn't look. And then the second one, I don't know the topic. I think every pregnancy is precious. So I don't think the word precious should be there. I think it should just be, in pregnancy. You still continue the same chemotherapy. Did you research to see how safe paclitaxel cisplatin will be, even after you had, confirmed that the woman was pregnant? Why did you still, continue with that same chemotherapy regimen? Thank you.
Quickly, Dr. Amadu.
Okay, thank you, Dr. Munir, for the presentation. I just wanted to say it's, one of your recommendations was multidisciplinary team approach. And I've seen that, you had other physicians contributed in the management and success. But I'm seeing here that everybody here referenced is just from radiotherapy and oncology department. So I don't know, does it comply with your recommendation? Thank you.
Okay, we'd like to take the online question so that you just comment briefly. The online question is that, was the patient trying to conceive actively prior to diagnosis, and why was no pregnancy test done? How in the world was pregnancy missed with ultrasound scan and MRI? Safety or specific chemo regimen used during the pregnancy? What is the safety of the specific chemotherapy regimen used during the pregnancy? All these questions, you have 1 minute to respond.
Well, that's too much. Okay. So the first question, concerning the dating of the pregnancy to the time of we did the ultrasound scan. Actually, the ultrasound scan and the MRI were done 2 weeks before commencement, 3 weeks before commencement of the chemotherapy. And this pregnancy was picked up at 18 weeks after she has received 3 cycles of the chemotherapy. So retrospectively, when you check that she started this chemotherapy when this pregnancy is 11 weeks. How the radiologist missed the pregnancy, we cannot know. But the fact that the MRI showed multiple fibroids in the uterus, and with those fundal collection, we thought that, okay, most likely that's the pregnancy that was missed to be reported by the radiologist. And the negative part from our own side is we didn't do pregnancy tests on this woman, even though she's within the reproductive age group. That's why what calls for the recommendation we gave. Then the question about the safety of the chemotherapy. Actually, there were the reports with respect to paclitaxel is there are no human reports, but animal studies revealed some toxicity to the fetus. However, cisplatin used to cross placenta and actually can cause hearing loss and intrauterine growth retardation. But actually, when we were doing the biophysical profile of the fetus, we saw that it is growing normally. So that was what calls for the continuation of the regimen that we started her on. And then the last question from the online that was saying how else we miss, because that was, we relied only on the MRI and the ultrasound scan to pick the pregnancy at least 11 weeks, but it was not reported. And we didn't do the pregnancy test on this patient.
So there's a question that your presentation that it was
Yes,
an MDT.
that's an oversight. We did not contacted them when compiling this report, but it is a correction that will be made. Thank you, ma'am.
All right. Thank you very much, Dr. Munir, for your presentation.
Thank you, sir.
Last presentation is a case report. Sorry, earlier I said the case report is on financial toxicity. Sorry, there was a mix-up. I was corrected. The case report is on enhancing symptom control with palliative therapy in a torrentially bleeding malignant wound. And the presenter is Dr. Ayuba Hannatu from National Hospital, Abuja. Dr. Ayuba, you have 7 minutes to make your presentation, and we'll have 3 minutes for comments and questions. Please and please don't overshoot your time. Thank you.
Good morning, senior esteemed colleagues and colleagues. I am Dr. Ayuba Hannatu Usman. I'll be presenting a case report on enhancing symptom control with palliative radiotherapy in a torrentially bleeding malignant wound. Dr. Umar, how do I navigate? Okay, thank you. Integration of supportive and palliative care with definitive oncology care unites the optimal treatment of the tumor and the patient who has the tumor. This patient-centered approach encourages improved symptom relief, good social function, quality of life, coping skills, and survival. Wound palliation care is a discipline in its early phases of evolution. It encompasses wound-related pain and symptom management. And malignant fungating wounds occur 5% worldwide and 10% locally. At presentation, our patient was a 46-year-old female with locally advanced left breast cancer, triple negative breast cancer, who was diagnosed in February 2021. She had a huge left axillary mass with a malignant fungating wound with symptoms of pain, exudate, malodor, and bleeding, which was rated high on the Toronto Symptom Assessment System for wounds. She underwent several chemotherapy regimens with poor response, exponential growth of mass, exacerbation of wound symptoms, and complaint of social isolation. She couldn't afford breaker testing, PD-L1 testing, luminal androgen receptor testing, no androgen deprivation therapy. She couldn't afford. There were torrential bleeding episodes which were experienced after and even during wound assessment and dressing sessions. The axillary mass and wound underwent 3 sessions of palliative hemostatic radiotherapy, first in November 2021, second in February 2022, and the 3rd session in June 2022. The axillary mass auto-amputated 2 months after the 3rd radiotherapy treatment with significant reduction of wound symptoms, less dressing frequency, and better quality of life. These are images of the wound while she was on systemic chemotherapy. This mass continued to increase exponentially and with torrential bleeding episodes that many times we had to be called in the oncology dressing room to see to pack in with the oncology nurses. So after palliative radiotherapy, we noticed shrinkage of the wound, reduction in symptoms, and after the 3rd session, the mass auto-amputated. The last image here shows after the amputation, cleaning at the oncology dressing room. So for follow-up, this patient has been referred to general surgeons for debridement, and she has been prescribed 6 cycles of adjuvant docetaxel, carboplatin, and Avastin with ongoing dressing, wound dressing, analgesia, and counseling sessions. For the challenges this patient had,
It was a malodorous fungating wound with pain and copious exudation, recurrent torrential bleeding episodes, frequent blood transfusions, need for daily wound dressing, which made her have to come to hospital via public transport every day. There was stigma and social isolation, financial toxicity of cancer care, paucity of advanced stratification of triple negative breast cancer, and this wound was inoperable. This mass was inoperable. So in conclusion, triple negative breast cancer is an aggressive type of tumor with worse prognosis, poor survival. Malignant fungating wounds are associated with a range of symptoms, and stigma and social isolation are common problems associated with malignant fungating wounds. So in recommendation, the MDT management with integration of supportive and palliative care with definitive oncology care should always come pari passu. There should be advanced biomarker testing and stratification for triple negative breast cancers in our centers. And this should include BRCA testing, PD-L1 testing, luminal androgen receptor testing, and other genetic tests. Then there should be chemosensitivity and resistance testing of tumors when patients present. However, these are all in the then multisectoral bridging of gap in provision of radiotherapy via innovative healthcare funding and oncology startups. There was no conflict, there's no conflict of interest regarding this report. Thank you for listening.
Thank you very much, Dr. Hannatu, for your presentation. You used 4 minutes, and at least we can be able to entertain questions. I can see my teacher's hands are raised. Apart from that, are there any other persons? Okay. 1, 2, 3. Okay.
Can I go ahead, sir?
Yes, sir. Yes, sir.
Thank you very much, Dr. Hannatu, for this amazing presentation. Couple of concerns and questions. One is, in a country of 220 million people with less than 10 radiotherapy equipments, what will you do if you find yourself with this kind of fungating and bleeding disease in an area where you don't have radiation therapy? Will you consider other definitive, systemic treatment like tranexamic acid? Will you also consider probably injecting things that we use, which is not well documented, like formaldehyde injection on the fungating mass? I know that it does happen in some rural centers. Will you agree to that, or you will not want to do something like that? The editor of the Lancet Oncology is here, mind you, so be careful how you answer this question. Dr. David is here, Professor David is the editor-in-chief of Lancet Oncology. We're happy to have you here. Thank you. Thank you.
Second question or comment?
For you.
Okay.
Thank you so much, Dr. Hannatu. Really, my own question is going to be around your choice of the use of Avastin in that very particular patient that came in with that torrential bleeding. And I'm just wondering, with a little that we know around the bleeding with Avastin, with all those friable vessels that you showed us, why that choice? What else could we have considered?
Okay. Okay. Quickly. The third comment. All right, Dr. Hannatu, quickly respond to the questions.
Thank you, sirs. Thank you, Maz, for the questions. Sir, regarding your question about why didn't we use other adjuvants like sclerosants, and all these were employed: tranexamic acid, adrenaline, formaldehyde packs were always used during the oncology dressing sessions. It was a nightmare whenever she's dressing. The oncology nurses are always calling and beckoning us to be on ground, and it always poured, no matter how the maneuvers. So in a country like Nigeria that has this gargantuan population with very abysmally few radiotherapy equipment for treatment, it's a nightmare managing such wounds that grow exponentially. So for such patients, we also thought of how about interventional radiology? Could there have been a form of embolism that could have been done? But then this patient has this very considerable financial toxicity. She even couldn't do many investigations that we had given her. Even the luminal androgen receptor that we hoped to assay in the tissue. And at one point, even the consultant wanted us to even commence on androgen deprivation therapy to see how she would fare. This patient couldn't afford it. So other innovative ways, we'll need more research in our centers, in our context, with our peculiarities and the deficiencies in radiotherapy. And then we hope that there'll be more startups, there'll be more innovative ways of funding, because even the radiotherapy this patient had to be under the Cancer Health Fund. We had to keep waiting for when her wallet to be funded before she commenced radiotherapy. And it was a big sigh of relief when she was approved and her wallet was funded. So for tranexamic acid, formaldehyde, all these were used, all these agents were used. And then for the next question, which talked about Avastin, why Avastin? We had tried so many chemotherapy regimen combinations for this patient, and with such a mass that grows by the second is so obvious. The consultant, Dr. Ibinoba, beckoned that it's better we use Avastin, even though we understand that it has a side effect of torrential bleeding too, due to the friable vessels, but the radiotherapy did a very good job, So we hope that with this combination, she will do better. And then even the Avastin is under the Cancer Health Fund, under the NHIA. It's affordable for her, and so that's why it's a good choice for her. Thank you. Thank you for the question.
There's another question online for you. Please tell us how order was managed and how much radiotherapy was given. Quickly.
The mal order was a big challenge for her. This patient many times used to cry whenever she comes for dressing. Somebody once even give a very bad comment in the bus. Whenever she enters, everybody alights, goes down. So the mal order was managed by oncology nurses. Many times they used metronidazole crushed tablets after cleaning exudates. We also even at one point used silver nitrate in solution for cleaning, but the wound is so big and silver nitrate is a little bit expensive. Even though we got some relief from the producer, they gave us free to help her. But then the flagyl tablets helped. But even with the radiotherapy, these symptoms kept going down, and then if the malodor was managed.
Dr. Nato, how much radiotherapy was given to the patient?
Patient had hemostatic radiotherapy, 15 gray in 3 fractions at 3 different.
All right. Thank you very much for the presentation and the response. It has been a wonderful time having all the presentation. And as I earlier said, there were 19 presentations. The remaining are in the abstract book of abstract and also displayed along the side. Thank you very much. I'll hand over the microphone to the co-author. Thank you very much.
Thank you very much, Dr. Umar. As Dr. Umar has said, the 2 article and case reports that were presented were the selected as the best articles and case reports. And now we would want to call Dr. Abdulrazak Oyeshegun, who is a BOT member, and he's the pioneer HOD of the Radiation and Clinical Oncology Department of National Hospital, Abuja, to come and present the award to the awardees. Thank you, Professor Dr. Shegun. Please, can the presenters just come forward, and so that when we call you,
Good morning, ladies and gentlemen. On behalf of ACON, I'll be making these presentations for the best research article. The presenter of the topic, EGFR and R2 new expression in cervical cancer patients who attended the therapy clinic, University College Hospital, Ibadan, 2006 to 2015. Congratulations on behalf of ACON. There's a small token to accompany it. Please accept it on behalf of ACON. Then the award certificate for the second best research article goes to anthropometric indices associated with prostate cancer in Nigerian men. The third award certificate is for the best case report for locally advanced cervical cancer with precious pregnancy. Presenter. Then the last but not the least, the award certificate for the second best case report. The case report on enhancing symptoms control and palliative radiotherapy in a torrentially bleeding malignant wound. The presenter that requested that the nurses that made this presentation possible should please come forward. Dr. Abdullahi.
thank you so much, Dr. Yeshegun, for the presentation, and congratulations to our awardees. The next session is going to be sponsored by Roche, and I'll be calling on Dr. Debo Omikunle to moderate this session. Dr. Debo, please. Please do not forget that the e-posters are outside. So during the break, you can just look at the other articles. They are there. And then they're also on our website. The book of abstracts is there. You can check on all the articles.
It's fine. Standing on the existing protocol, good morning, everybody. I would like to call on Gilbert Bewele, PJP from Rush, who is going to take the very next presentation on the role of atezolizumab in cancer immunotherapy with specifics on the use in HCC. Thank you.
Okay. All right. Good morning, distinguished ladies and gentlemen. I also stand on established protocols. My name is Gilbert Oberele, and as my colleague has introduced me, I'm a patient journey partner with Roche Nigeria. It gives me great pleasure to be here with you all this morning. My presentation today will be on cancer immunotherapy, and we'll be looking at the role of Tecentriq in the management of unresectable, first-line unresectable and advanced hepatocellular carcinoma. The objective of this presentation is really to get us all to appreciate the benefit of cancer immunotherapy and also to see the benefit of Tecentriq plus Avastin in managing HCC, which then leads you to offer Tecentriq plus Avastin to your first-line unresectable and advanced HCC patients in your clinic. So we'll look at the epidemiology of the disease, the treatment guidelines, mechanism of action, clinical evidence, what Tecentriq is, dosing and administration. We'll summarize and close. Today, liver cancer is the 6th most common cancer globally and the 3rd cause of cancer death worldwide. We also have a very high incidence of this disease in developing regions, and this is where Nigeria falls under. So it is a challenge to us here, and it's more common in the men than we see in the women. In our practice today, how do we stage for this disease? So we have the Child-Pugh score, which is widely used to assess liver function and is also included in other HCC staging systems, including the Barcelona Clinic Liver Cancer Staging System. Of course, we have the Barcelona Clinic Liver Cancer Staging System, which is the most commonly used here. And it makes use of this tumor stage, liver function, physical status, and cancer-related symptoms for staging. With this system of staging, we have 4 types of staging. So we have the BCLC stage A, which is early. We have the stage B, which is intermediate, stage C, which is advanced, and the end stage, which is stage G. Now, after staging, I want to ask ourselves, how do we manage patients in this group? We have the NCCN guidelines, which shows how the different treatment modalities that are available to treat patients with this disease across different stages. But I'm going to talk about the inoperable and the metastatic disease, which shows us that the preferred systemic therapy are the TKIs, and now Tecentriq plus Avastin, which is the standard of care today. When we also look at the ESMO guidelines as well, we also see that the BCLC stage C shows us that the TKIs are now Tecentriq plus Avastin is the standard of care for these patients in first line. We have the treatment. This just shows us the landscape of treating the disease over the last 10 years and more, where of course we had the TKIs which came into play, but now in 2020, Tecentriq and Avastin have been approved for use in this group of patients. In the past with the TKIs, we had patients stopping treatment because of the high occurrence of side effects. And so the treatment was interrupted and also discontinued. But with Tecentriq and Avastin, we offer clinical benefits, improved efficacy, simple dosing, and manageable and tolerable side effects for patients. Tecentriq plus Avastin helps the immune system, increases the immune system's potential to fight cancer. And it does this with its synergistic mechanism of action. So Tecentriq, Avastin at stage 2, when we look at the cancer immunity circle, in stage 2, Avastin promotes the dendritic cell maturation. And when we move to stage 3, Tecentriq helps to promote T cell activation. These T cells, once they're activated, are transported down to the tumor microenvironment. While it's being transported, Avastin comes to play again where it helps to normalize the tumor vasculature and prevent leakages. So it allows more T cells to go into the cancer immunity, the tumor microenvironment rather. Avastin again also would decrease the activities of immunosuppressive cells, while Tecentriq would restore anti-cancer immunity in the body. And this simple mechanism of action helps to improve the immune system and helps it to fight against cancer. Looking at this mechanism of action, the next question we want to ask ourselves is, what other evidence do we have to showcase the efficacy and the tolerable safety profile of this combination in our patients? We have the IMbrave 150 trial, which is the first cancer immunotherapy trial to establish superiority versus a TKI in first-line unresectable HCC. The IMbrave 150 trial is a pivotal phase 3 randomized multicenter trial of Tecentriq plus Avastin versus sorafenib in patients who had previously untreated hepatocellular carcinoma. Some of the key eligibility criteria here was that the patients enrolled were locally advanced or metastatic, and they should not have had any prior systemic therapy. The patients were randomized the ratio of 2:1, Tecentriq plus Avastin arm versus sorafenib. And the treatment was continued until loss of clinical benefit or unacceptable toxicity. We had two co-primary endpoints here. The first one was overall survival, and the second was progression-free survival. And we also had some other secondary efficacy endpoints, which are progression-free survival, objective response rate, the duration of response, and also patient-reported outcomes. I also want to point out that we had a total of 501 patients enrolled in this trial. However, amongst that group of patients that have been enrolled, we also had a cohort of patients whom we'll call the Chinese cohorts. And we're also looking at the result that was obtained from this group of patients away from the general results. And the reason we're doing this is because we want to highlight the benefits of surveillance in our HCC patients and also patient profiling, as well as the use of MDT approach in managing patients. So in terms of baseline characteristics, across both groups, the baseline characteristics were the same. When we look at the results obtained from this trial, we see a significant overall survival versus the TKI. We have a 34% reduced risk of death demonstrated with Tecentriq plus Avastin. And when we look at overall median overall survival in terms of months, we have 19.2 months versus 13.4 in the sorafenib arm. When we even take a dive into the subgroup of the Chinese cohort, we see a more improved overall survival. We have a 47% reduced risk of death demonstrated in the arm of Tecentriq plus Avastin. And when we look at the median overall survival in terms of months, we have 24.0 months in the Tecentriq plus Avastin arm versus 11.4 months in the sorafenib arm. Again, when we look at the progression-free survival, we still have fantastic results to show here. Tecentriq plus Avastin gave a 35% reduction in disease progression versus sorafenib. When we also look at the progression-free survival in terms of months, we have a median PFS of 6.9 in the Tecentriq plus Avastin arm and 4.3 in the sorafenib arm. Again, more fantastic results to showcase when we look at the overall response rate in the Tecentriq plus Avastin arm versus sorafenib. So we see that Tecentriq plus Avastin reduced tumor burden in 30% of patients versus 11% with sorafenib. So today in our practice, if we say that we use sorafenib and half of our patients are currently seeing some result or response with sorafenib, multiply that result by 3, and that's what you will get when your patients go on treatment with Tecentriq plus Avastin. If we also hone in into the complete response rate, we see that Tecentriq plus Avastin gave 8 times more complete response than we have with sorafenib in this group of patients. Again, when we look at the delay in deterioration of patient-reported quality of life, compared to sorafenib, Tecentriq plus Avastin gave 11.2 months versus 3.6. Basically, this is telling us that the patients who were in the arm of Tecentriq plus Avastin were able to have a better quality of life. They were able to stay up to almost a year before reporting any form of deterioration in the quality of life that they had once they started treatment with this medication. When we look at safety as well, we do not have any new or additional safety findings that are different from other Tecentriq trials that we've had in the past. Sorry. Yeah. We also see that the safety profile of Tecentriq is actually very tolerable, and patients who took the medication were treated for a longer duration and had manageable safety profile and experienced improved quality of life. Because we are talking about immunotherapy here, there might be concerns about immune-related adverse events. But when we looked at the trial, the immune adverse events that occurred were mostly grade 1 and grade 2, and were not so severe that patients had to discontinue treatment. And if we also look across body, it was also similar in the sorafenib arm. Remember, we are looking at a 2-in-1 ratio 2-in-1 trial. So it means that if we had similar numbers of patients in both arms, we would have more immune adverse events in the sorafenib arm than we would have had in the Tecentriq plus Avastin arm. So I'll just share with us more information about the medication. Tecentriq is a humanized engineered immunoglobulin I monoclonal antibody that directly and selectively targets PD-L1, and it contains atezolizumab. That's the active substance in it. Today, we have two forms of the medication in the market. We have the 840 milligram strength, and we also have the 1,200 milligram strength available for patients. Both Tecentriq and Avastin are given in combination, and they are administered every 3 weeks until unacceptable toxicity or loss of clinical benefits. We say that Tecentriq should be administered first, followed by Avastin. For your first infusion, you give the first infusion of Tecentriq over 60 minutes. If that is tolerated by the patient, then your subsequent infusions can be given over 30 minutes. Again, do not administer Tecentriq as an IV push or a bolus. Some other information that we need to know is that for children and adolescents who are below the age of 18, we do not advise that Tecentriq should be administered in this group of patients. For pregnancy and contraception, if a patient is pregnant when taking Tecentriq, that patient should inform her doctor, and it's at the doctor's discretion if the patient should stop taking Tecentriq while pregnant or continue treatment. Doctor has to weigh the risk and the benefits to the patient. Again, when it comes to breastfeeding, the doctor has to also make that choice to tell the patient whether to stop breastfeeding or continue breastfeeding as he or she sees fit. In summary, we've seen that from the IMbrave 150 trial, Tecentriq plus Avastin gives superior overall survival of 19.2 months versus 13.4 months when compared to a TKI. We also see that in the Chinese cohort as well, we have improved overall survival figures where we have 24.0 months with Tecentriq plus Avastin versus 11.4 with sorafenib. Again, we have a 47% reduction in risk of death when compared to sorafenib. Very good improved progression-free survival. And if in terms of the overall response rates, we see more than double of that recorded in Tecentriq plus Avastin arm. Again, manageable safety profile. And also to note that patients who went on treatment with Tecentriq plus Avastin had treatment for a longer duration, and they had improved quality of life, which I know is something we all desire for our patients. Distinguished ladies and gentlemen, I will end my presentation here to say that Tecentriq plus Avastin as standard of care provides strength for superior survival in patients with first-line, unresectable, and advanced HCC. So the next time your patient who has HCC comes into the clinic, let's do our best for that patient. Let's profile appropriately. Let's do the right surveillance and manage those patients with the multidisciplinary approach. Thank you.
Thank you so much, Gilbert, for that presentation. Perhaps one of the few things that is well stated in that presentation was the importance of surveillance when it comes to HCC. The Chinese cohort actually had a 24 months, right, in terms of overall survival, compared to the rest of the the ITT population that you said they had 19.2, and perhaps that can be an important information to leave here with, that we should be more proactive when it comes to surveillance with HCC. So at this point, Gilbert would like to answer some of the questions. It's so surprising that Mr. Tecentric HCC himself is the first hand. Yeah, Dr. Bilo. Any other hands so that we can have an idea of the number of people asking once and for all? Thank you. I think it's just Dr. Bilo. Thank you.
First, I want to sincerely thank you for launching Tecentric in Nigeria just a couple of weeks ago. It means that we are in the immunotherapy space already. Couple of things that more of a contribution before my question. Perhaps I don't think that the combination is yet a eureka. So it's not one treatment takes all. In other words, there should be certain exclusion criteria, which I do know that certain histological variants are not indicated. Patients that have also active hepatitis and all that, I think these are things that should be highlighted at the presentation. And so to my question now is there any study that have validated the treatment of hepatocellular carcinoma with Tecentric alone without, and what is the likely outcome? Thank you.
All right, thank you so much, Dr. Bello. Gilbert asked me to go ahead and just answer that on his behalf. So I became, all right, there's another question. So we can answer the two questions together. Please go ahead.
That was a wonderful presentation. I think about a week ago, I called pharmacist Finshaw, trying to know how Tecentric is used in hepatocellular carcinoma. But I'm happy today. I've gotten all I needed to get from this presentation. Even though we lost that patient after 3 days, after I called him, after 3 days, I want to know, please, how much is Tecentric? Cost effectiveness.
From here. Thank you, Doctor. Sorry, I do not hear your name.
I'm pharmacist Irumia Adam.
Pharmacist Adamon. It's a pleasure meeting you again. When it comes to cost effectiveness, I'm sure Dr. Bello and the rest of the people right here will tell you that you cannot equate anything to life. All right. Do not forget that. And because this is a scientific gathering, all right, things that has to do with access and the rest of them, you can always come to our stand to get all the necessary information. We'll quite appreciate that, right? Thank you so much. And regards Dr. Bello's question, yes, there are studies, okay, even showing the use of atezolizumab, not just in HCC as a single agent. A lot of them are still ongoing. Some of them are actually as a follow-up because of adverse events to other medications that are used in combination with atezo. And for example, you have perhaps discontinued Avastin because of this particular AE noted for Avastin. Some of these patients are allowed to go on monotherapy Tecentric. A lot of results are coming out gradually, all right? And I am sure Dr. Bello is only trying to showcase the fact that atezo monotherapy, it's a possibility. It's not really a question from him. Thank you.
We're good. All right. Thank you.
So we want to thank the Roche team, Dr. Debo Omikunle and pharmacist Gilbert for the beautiful presentation. We have the next presentation, which is going to be online by Dr. Jawa Zaba Muhammad. Dr. Jawa is one of the pioneer consultant in nuclear medicine in Nigeria, and he will be speaking on nuclear theranostics in oncology for the next 30 minutes. Is Dr. Jawa online?
Can you hear me?
Yes, we can hear you, Dr. Jawa. Good morning.
All right, good morning. And can you see my slides?
Yes, we can. Dr. Jawa, you have 30 minutes to give us your presentation. Thank you so much, and sorry for keeping you waiting online.
Right. Okay, let me begin. Good afternoon to you all. Well, good afternoon from here, Muscat. It is already afternoon. Begin this presentation by thanking the organizers of this conference for finding me worthy to present this paper, despite the fact that there are colleagues of mine who can probably do this presentation better than me. One of them is Dr. Tesi Amodo. I'm sure she would have presented this paper better, but I feel very honored to present this topic. So I'm going to be talking to you this afternoon on nuclear teratonics in oncology. My paper will basically address the following issues. We'll look at the basic principles of nuclear imaging and therapy. That is really just to prepare us in understanding what nuclear teratonics means and how nuclear teratonics is applied, particularly in oncology. I will look at the current used theranostics procedures in oncology. In between that, I'll be flipping through to show you images that we have done in our centers and some images that I obtained from my colleagues outside of Oman. We will look at the advantages and some of the limitations of teratonics, particularly when it comes to cancer care. And we can see what are the issues of combining teratonics with other diagnostic procedures and other therapeutics procedures that are available. And we will run up this presentation by looking at what the future holds for teratonics, particularly in cancer and in cancer management. So my task today really is just to introduce you to nuclear teratonics in oncology, and is to provide you with a guideline in recommending teratonics to your patients, and also to share with you some of our experiences in performing teratonics in oncology in an effective, efficient, and a safe manner. And at the end, which is for the betterment of our care, for better care that we provide to our patients. So to understand teratonics, it's very important to understand what nuclear technology and nuclear medicine entails. There are three important aspects that are important in nuclear medicine. We have the patient, the radiopharmaceutical, and the equipment. Now, the radiopharmaceutical composed mainly of the radioactive atom, which is an unstable atom that is chelated or is then coupled with a target molecule. And this combination is the radiopharmaceutical. And then we have a biological target, which is the patient. And within this patient biological targets, these biological targets can be cell surface receptors, can be transporters, can be protein or DNA. So this receptor are those compounds in the cancer cells or in the patients that are responsible for attaching those radiopharmaceuticals. And the targeting molecules can be peptides, can be peptide mimickers. We can have radionuclides, nucleotides, small molecules, and antibodies. So this is the basic principle of nuclear medicine technology, is that we get a radionuclide unstable atom, we chelate it to this targeting molecule and inject it to the patient, and we expect that those target molecules in the patient body will now absorb or will take up these materials. So in nuclear medicines, once we can be able to get a target agent that is specific for a biochemical target substance in the body, then we will be able to image that disease process. And in other hand, we can also give therapy depending on the uptake and the distribution in the imaging that I will be subsequently showing you. So this is the basic principle of the thing that we do. We inject the radiopharmaceutical into the patient. The patient becomes a source of radiation, and our equipment, which it can be a PET or a SPECT CT, is a detector. So this equipment detects the radiation that comes out from the patient, and an image is formed. So what we do in nuclear medicine basically is we are injecting the patient with a radioactive atom. The patient becomes a source of radiation, and we image the patient. So it means we are imaging our patients from inside out. And because of that, the images that we provide to you in nuclear medicine are functional images. Unlike radiology, CT scan, MRI, the images that you get are images obtained from outside in. So from outside in, that means the radiation passes through the patient and then you get an image behind. So those information that you get are mainly information on anatomy and morphology. But these days, the good news is that our equipments are hybrid systems. So you have a PET CT or a SPECT CT. The idea of this is to increase the sensitivity and specificity for diagnosis, particularly in nuclear technology. So what does teratonics mean? Teratonics just refers to pairing of a diagnostic biomarker with a therapeutic agent so that that is specific for a disease target. So that means that we will look at a specific targeting substance that we use for diagnosis, and we can use that in high quantity if it permits, if it's a significant uptake for diagnosis. So it means that we are killing two birds with one stone. So it means, what it basically means is that teratonics is a hybrid term that refers to the fusion of the two words. So if you look at this, so there are two words. They are the fusion of diagnostic and therapy. So we're trying to do two things at the same time. We're trying to image the patient and do therapy, and then we can then image again after the therapy. So you can have either imaging the patient first to do a diagnostic scan and look at the pattern of distribution, or you can go directly, depending on the type of radiopharmaceutical you have, you can give a diagnostic, you can do a therapeutic scan and image the patient later on. But the hallmark of teratonics is that you are trying to couple diagnosis and therapy at the same time and on the same patient. So this diagram looks very busy, but it's one of the most important, and it has summarized the entire process or in the entire principles that takes place in teratonics. So if you look on your left-hand side, this is the diagnosis, and on the right-hand side is therapy. But what we have that is common to the whole process is a specific targeting material. So the specific biological substance in the body can be a sodium receptor iodine that we have in thyroid cancer, can be somatostatin receptor or a PSMA for prostate, or non-efflupin transmitters that you get in neuroendocrine tumors. So for diagnostic, we use mostly substances that have low energy, like technetium-99, iodine-123, gallium-67, fluorine-18-19, and gallium-68. Those are gamma emitters, and they are gamma emitters, and therefore we can use them purely for diagnosis because they have a long range of path. Their path length is long, they have low energy, and then you can also use them to detect, to quantify, to predict the disease response, to predict toxicity, and of course to prognostify patients. On your right-hand side, if you look at the group of radiopharmaceuticals that we use, these are radiopharmaceuticals with short path length. They are mainly alpha or beta particles, and we know that alpha and beta particles have very short path length, and they have very high energy, so they can deposit their energy at the site of disease process. And the commonest one that we use, of course, that you know, is iodine-131, lutetium-177, yttrium-90, and samarium-125. There are some of the therapeutic agents, which are alpha particles, that you can also use them to image, but there are very few of them. Again, iodine-131, you can image, you can do both diagnostic and imaging. So there's a crisscross between some of the properties of the radiopharmaceutical or radioisotopes that we use for diagnosis with therapy. But the important therapy is that we try to induce a radiobiological effect. So it's similar to what you do in radiation therapy, but what we are doing is we're delivering an internal form of radiation. So it's also toxic, like your external beam radiation, and you see an immediate effect, particularly if you have imaged the patient earlier on. So this gives you the coupling of what we do, like I mentioned earlier, coupling of diagnosis and therapy using a radiopharmaceutical that is less toxic, that you can use it to quantify, you can predict the disease, you can disease response, you can predict toxicity, you can prognostify patient. And after that, you now use the same images at the same time to give a toxic dose that will be able to cause toxicity and cause ablation of the disease or destruction of the cancer cell or any other target cells that you would be required to do in that patient. So again, this tells you what we do is the patient, the biological substance is the most important. The imaging thing that we use in nuclear medicine currently is the positron emission tomography and the single photon emission tomography are the two most important equipments that are available in nuclear medicine. Again, we do imaging in majority of cases with the gamma particles, and then we do therapy with alpha particles or beta particles, as the case may be. So the idea and the aim of Teratonics is mainly to personalize medicine. It's also called a targeted medicine or a precision medicine. But in the end, the most important thing is to improve patient care and patient outcome at a less invasive and a more cost-effective manner. So the reason why we are doing Teratonics is to, at the end of the day, get a procedure that is precise, a procedure that is personalized to the patient. And all this, we hope that it will increase the patient outcome and at the most cost effective. But I will tell you that majority of the currently used agents for oncology are a little bit expensive. And I'll tell you in my subsequent slides how expensive those agents are. So this table tells you the most common Teratonics that is applied currently in nuclear medicine. So the first one is radioiodine 131. We know that the iodine is being used for cancer care. So if you look at the diagnostic material is 1,2,3 iodine, sodium iodide, and the therapeutic form of iodine is iodine 131 that is used in treating both benign and malignant thyroid disease. But today I'm going to be discussing with you thyroid cancers. And the target organ in those particulars is the sodium iodide symporter gene that is available on the cell membrane, particularly of thyroid cancers. We do 1,2,3 iodine MIBG, meta-iodobenzoyl guanidine, and the therapeutic form of it is iodine 131. And these are the non-epinephrine transmitters that you get, and they're mainly used for neuroblastoma, for pheochromocytoma, and medullary thyroid cancers. Sometimes there are some subunits of medullary thyroid cancers that specifically will take up MIBG, and that has been used for treatment. We have strontium for bone pain and bone metastasis, particularly bone pain palliation from patients with prostate cancers. And particular one that we use for is technetium 99M that is commonly used for bone scan and bone imaging. We have gallium-68 daughter-based radiopharmaceuticals. And the daughters, these are used, the targeting or the therapeutic agent that is used is lutetium-177 octreotide or yttrium octreotide, and these are the somatostatin receptor analogs, and they are mainly used in neuroendocrine tumors. I'm going to show you a few examples of some patients that were treated in our center. The other one that is used is in prostate cancer. We have gallium-68 PSMA. We also recently been using fluorine-18 PSMA, imaging them with PET-CT, but the therapeutic agents, there are two types of therapeutic agent. We have lutetium-177 PSMA and actinium-225 PSMA. And the receptors, obviously, we know the receptor for prostate cancer is the prostatic-specific membrane antigen. For hepatocellular cancer, we currently are using yttrium-90 hemispheres, and the agent that we use for the diagnosis is technetium MAA that we use as a testing dose before we then give a high dose. And this is particularly useful in patients with HCC, with cholangiocarcinoma, and with extensive liver metastasis or in liver cancers that are inoperable. Another agent that is used in lymphoma is the anti-CD20 IHC with the receptor of anti-CDC21. This has been employed mainly in patients with Hodgkin's disease. So if you look at this table, it just gives you an overview of the currently available theranostics in oncology, particularly looking at thyroid cancer, neuroendocrine tumors, prostate cancers, and hepatobiliary cancers. Sometimes we can use them for lymphomas. This is not widely available days, but there's a lot of research and work going on this anti-HD20 receptors. So in thyroid cancers, this is something that is very common. It's an old thing, it's like putting a new wine in an old bottle. But the main use of Teratonics and the use of nuclear medicine technology is in differentiated thyroid cancers. And we know that the mainstay for treating thyroid cancers is surgery, which can be total or near total thyroidectomy. The next is to do a iodine 131 therapy. And this is a post-therapy ablation. And the reason for this ablation is to destroy the remnant thyroid tissue so that you can increase your sensitivity of follow-up of patients. You can do hormonal therapy. You can do iodine 131 therapy for metastasis or for recurrent disease when you follow up the patients. And of course, there are other options for thyroid cancers like doing second surgery, radioiodine radiotherapy or some type of chemotherapy. So the main indication for radioiodine therapy in thyroid cancer, like I mentioned, is post-thyroidectomy ablation, is therapy for metastatic disease and therapy for recurrence of thyroid cancer. So I'll give you an example. This is a patient with a non-diagnosed histological diagnosis of a thyroid cancer. Patient had a partial thyroidectomy, but then an ablation needed to be done to ablate the residual or remnant thyroid tissue, and iodine 131 was administered. And you can see the intense uptake in the thyroid neck with no evidence of metastasis. Now, this patient came in subsequently for follow-up, and you can see that there is complete ablation of the thyroid with no evidence of remnant or metastasis to the patient. So at this stage, what we normally will do is to follow up the patient with a thyroid ultrasound and thyroglobulin as the tumor marker. The second case here is a patient with a thyroid cancer, but at this stage we went straight because there were, even at the time of surgery, there were evidences that this patient had metastatic disease from chest x-ray. So we gave a high dose of 200 millicurie of radioactive iodine at the therapeutic dose, and we obtained a whole body scan initially with a 5 millicurie just to do a test dose, and you can see the intense uptake in the neck, and you can see multiple metastases in the lymph node and multiple metastases in the lungs. So this patient received high dose radioiodine therapy, and you can see that there is significant uptake with what we call the star appearance. So again, this is combining diagnosis and therapy in this patient with a well-differentiated thyroid cancer. Another patient here is this one that has, you can see, is a patient with a recurrent thyroid disease. You can see that there is intense uptake in the lymph nodes of the neck and with multiple micrometastasis to the lungs. This patient at the initial stage, again, because there were significant evidences to show that there is widespread metastasis. In certain cases, we do not do a test dose, diagnostic dose. We go straight forward to give a high dose therapeutic dose, and afterwards we do an imaging. So you can see here with the significant uptake initially with the high dose. At this stage, the patient's TG was over 500. So we do 2 accumulative doses. So accumulatively, this patient received about 14.3 gigabecquerel of radioactive iodine. And 6 months later, you can see that there is a complete resolution of his disease. There's almost complete disappearance with no any evidence of disease. And then biochemically, you can see that the TG level has gone from 0. It has gone from the 5 to less than 1. So this is showing a complete metabolic or a complete response. So this is again another advantage of doing theranostic. You can diagnose the patient with a high dose therapy, and then you can do imaging subsequently for follow-up. The next thing that we do in nuclear medicine is treating bone pain. It's for bone pain palliation, and bone pain palliation is mainly for patients with skeletal metastasis from the non-primaries, and mostly in patients who are refractory to other forms of therapy. So, but before we do that, we find out which cancers will these patients benefit from. We prefer to use radionuclides. We prefer to use agent metastases that have more osteoblastic. So if you look at breast cancers, 70% of them, about 40% of them will have osteoblastic metastases, and in prostate, you can have osteoblastic metastasis about 80, in lung about 10. So you see that the advantages of palliative radiotherapy in patients with prostate will be much better compared to patients with breast cancer, lung cancer, and thyroid cancer. So you can see that the cases or the primary malignancies with pure osteolytic lesions usually did not respond very well to palliative radionuclide therapy. So the reason for doing palliative radionuclide therapy is essentially to reduce pain, to reduce complication of hypercalcemia, spinal cord compression, to reduce the chances of pathological fracture, and of course, marrow infiltration by the disease. So this is what we do. This is the common bone scan. This image was taken at National Hospital, Abuja. So it's an old image of one of your patients, I'm sure. You can see there's a patient with a breast cancer, and you can see that there are multiple skeletal metastases. So this is like a diagnostic test. And with this, we can then use a high radionuclide to administer to this patient for therapy. Another example is in patients who particularly are hormone refractory metastasis from prostate cancer. This is an example of an adult male in our clinic that we saw a few years ago. You can see that in 2019, this patient had multiple skeletal metastases. His PSA was about 530 at that point. And we went straight to give samarium 153, which is the most common radiopharmaceutical used for palliation and bone pain. And you can see in April, that's about 6-7 months after, you can see that there is almost a complete disappearance, and this patient's symptoms reduced significantly, and you can see a significant drop in the PSA of this patient. So again, this is combining therapy with imaging, and that's the whole story of Teratonics. Now, in neuroendocrine tumors, the most common malignancy that we employ is neuroblastoma. And neuroblastomas, we know that they are more common in children. We use iodine 131 for therapy and for diagnosis. The most important one is iodine 123 for imaging, but iodine 123 is extremely expensive. It has a better image quality than iodine 131, but then we can take advantage of the alpha gamma particles of iodine 131 to image. So we can do with iodine 131, we can both do a diagnostic and a therapeutic in this patient. So you can see this is a child with a diagnosis of a large neuroblastoma, you can see it here. And this patient had a high dose of MIBG, and on follow-up, you can see that there is a complete resolution of this lesion, with the patient going into a complete response, both biochemically and by imaging. Another patient here that we saw, you can see that this patient at the initial stage, we did an MIBG, but at this point we did a testing dose. We did a diagnostic, and what we give is a small dose, just a 1 millicurie of MIBG 131. And you can see that you can see the huge lesion in the mid-abdomen. Now, this patient received chemotherapy instead of MIBG. There are certain cases where chemotherapy will be employed and the MIBG scans will be used to follow up this patient. So at the end, patient received chemotherapy. Again, we re-imaged with MIBG 131, just 1 millicurie, and you can see that there is a significant reduction. So at this point, we will say that there is a partial response, but then a clinical decision was made to administer iodine 131 in a higher dose because there is an uptake even from the initial stage of the disease. So this patient had it, and you can see that there is a significant uptake, which is even much more. But the advantage sometimes of giving a higher dose is that you can even see other lesions that were not seen at the diagnostic scan. So you can see, in addition to the lesion here in the mid-abdomen that this patient had, there is also a smaller lesion in the iliac bone, of the left iliac bone. So one of the advantages of giving a high dose is that you can upstage disease. One of the disadvantages of giving low dose as a test dose is that you can miss certain lesions that are either small or that are situated in areas where there is intense excretion, like you can see of the urinary bladder. So again, this is to tell you how important it is sometimes to do an imaging first before you give a therapy, or you do a therapy before you give imaging, and vice versa, depending on the clinical setting. That's why it's a personalized care that we provide to our patients with Teratonics. Another example here is a 16-year-old female that we had with a large lesion here. Is a neuroendocrine tumor in her left chest. In these circumstances, what we did was, again, you can see we did a pre-treatment scan, and the patient received immediately a high dose of MIBG. And 1 year later, you can see that there is a complete resolution, both by imaging and by chemically. So again, you can do it either way. You can start with a high dose and then image subsequently, or you can do a low dose imaging procedure and then give a high dose subsequently. So another example here that I'm going to show you is the use of indium octreotide for diagnosis and use of gallium-68. We're trying to compare the two to see.
Can you hear me?
Yes, please.
Sorry,
Yes.
2 more minutes. Thank you.
Okay, so you can see that one of the advantages is that gallium is much more sensitive than octreotide. Gallium is much more sensitive than indium in this kind of patients. Now, again, this is an example of a patient in which we use lutetium to treat. I'll go straight to show you the ones that will interest you. Is a patient with prostate cancer. The most common teratonics that we do now is for patients with prostate cancer, and the imaging radiopharmaceutical is gallium-68 PSMA, which is highly sensitive for metastasis and recurrence of disease. And what we use for their therapy is we use lutetium-177 PSMA for therapy, and sometimes we can use actinium. And this is an example of a patient that we saw in our center. He had gallium-68. You can see that there are multiple metastases to the lymph nodes, to the liver, and to the lymph nodes the recurrence in the pelvic region. At this stage, the patient's PSA was more than 200. This patient received 3 cycles of lutetium PSMA, and 6 months later, you can see that there is a complete resolution of his disease. So again, lutetium is one of the things that we can use for multiple metastases and for patients who are hormone resistant or for patients who are refractory to other forms of therapy. Another example is a patient where you can see that there are multiple skeletal metastases, and after 3 courses of lutetium, there is a complete resolution of his disease. But I'll show you again that there are certain patients where, like for this patient, we saw this patient in November 2019. You can see a multiple skeletal metastasis, multiple lesions in almost all the organs. He received 3 doses of lutetium. At this stage, he had a complete metabolic response, but this patient PSMA started increasing. And then when we imaged, we saw that he had new lesions. So despite this fact that you give the patient go into remission, sometimes there is a chances that they may reoccur. And one of the advantages of doing gallium imaging for following up this patient is that you can quickly get these patients once they reoccur and repeat the cycle of therapy. But another promising radiopharmaceuticals that we have now is actinium. And actinium gives you a much more quicker response to patients, and the patients don't go into remission as early as patients who are on lutetium therapy. So actinium is one of these ones. This is an example of this is our first case of actinium that we did in our institution. You can see that this patient had widespread metastasis. There's multiple dots you can see. And this is he received 3 cycles of actinium, and you can see that there is a complete metabolic response. At this stage, his PSA was less than 1. So in liver cancer, I will not talk too much about it, but what we do is we do radioembolization. We do it in patients with multiple liver metastases or liver lesions that are inoperable. And we do them together with the interventional radiologist. What we do is we catheterize the patient because we know that these lesions, preferentially, the tumors in the liver are supplied by the hepatic artery. So we canalize the hepatic artery and we inject. First, we inject less dose. We do a testing dose with MAA. Then again, the advantage of MAA is it tells us the distribution. It also helps us to quantify if this is any shunt to any substance. And then we do our hemospares where we do the therapy, and then afterwards we do imaging. This is an example of a patient. You can see these are multiple liver lesions, but on follow-up, there is almost complete resolution of this lesion. Another example here is another MAA that we did for a patient. At imaging, you can see how intense uptake it is. And we do a post, normally we will do a post imaging to see how the response of these patients are. So you can see the response within 6 months, there is a huge multiple lesions in the liver. And this is 1 year after the therapy, you can see that there is a complete response to the disease. Sometimes what we do is we don't do imaging. We can also use CT or MRI to guide us in looking for resolution of the disease or when patients go into remission. So very quickly, the advantages of teratonics is usually for better patient selection because you are imaging the patient, so it gives you the capability to predict disease response. It also gives you the advantage for looking at toxicity because you are imaging the patient, you are looking at the distribution of uptake of this low dose that you give, so you can predict to a larger extent the response and the toxicity. And we are doing whole body imaging in patients. So whole body imaging permits us to image the patient entirely in anterior and posterior projection. And it also gives us an advantage of doing quantification. And quantification is usually a very powerful tool that we use in order to measure the disease burden in a patient. And it also guides us as to what dose and the dosage that we are going to give for the therapy. And ultimately, this will reduce the cost to the patient, and it will potentially avoid unnecessary treatment and unnecessary intervention in cases where teratonics can be employed. Now, unfortunately, despite all this beauty about teratonics, there are certain limitations about teratonics, and one of them is the specificity and sensitivity of nuclear technology. The problem is most of our equipment have an issue with size. So if a lesion is less than 7 millimeters, it is likely that these lesions will be missed. So size is a factor for us. And sometimes these tumors de-differentiate, particularly tumors that are well differentiated at the initial stage can undergo de-differentiation. And the most common cancer that we see in our environment that differentiate is a well-differentiated thyroid cancer. So you can have a well-differentiated thyroid cancer that concentrate iodine, but if eventually it de-differentiate by losing its sodium iodide importer gene. So this is a limiting factor. Now, currently, because teratonics is a little bit new in nuclear medicine, we don't have criteria for assessing response. Unlike other tumors like lymphoma, where you have criteria, you have the RECIST or the PASSIST protocol that you can use to say whether there is a complete response, partial response, stable disease, or progression of disease. At the moment, there is no clear cut and there is no sufficient studies to give this. So it is difficult to place patients whether they are complete response or partial response. But when they are complete response, you will know, you will see them on imaging and you see them on biochemical profile. But then this is not sufficient. We need to get an assessment response for each particular patient and each particular disease process. And one of the things is that teratonics is very complex and the process involves a lot of things and a lot of technology, a lot of regulations play a role. And one of the other issues currently is the cost. So these are some of the few limitations, but despite these limitations, there is a huge prospects for teratonics in the future because our equipments are evolving. The current equipments that are being made now can detect lesions as small as 2 millimeters. So there are ongoing research on new radiopharmaceuticals for several diseases. I told you earlier on, currently there are only 5 or 6 cancers that we can use nuclear teratonics for, but now there are emerging radiopharmaceuticals that are used for multiple myeloma, for insulinomas, for pancreatic cancers, and even for HER2 breast cancer. So the technology is evolving, and we hope that over time we will see this evolve. Like I told you, currently there is zirconium HER2 that is being used, and it's been tested in various places. This is an example of a patient that with HER2 targeted imaging. Again, there's evidence to show that this patient responds very well. So in future, we will be seeing not only that we will be imaging the cancer cells themselves, but we will be imaging tumor environments. We'll be imaging fibroblasts, we may be imaging and using teratonics in imaging macrophages and some other cells that are related environmentally, not only to the cancer cells. So this is what the future is. So the future in general will be teratonics in future, but there's also an emerging field of using of nanotechnology, which I will not go into details. But in the end, all this process will be married together to guide us in imaging and of course to guide therapy depending on the type of cancer. So the future of teratonics is quite bright, even though there are a lot of limitations like I've mentioned earlier on. So in summary, teratonics is essentially just coupling diagnosis and therapy. It is a tool that is mainly for specific targeting therapy in certain type of cancers that I've mentioned to you. It enables us to accurately select our patients because we are imaging them, we are seeing where the cancer is, we are seeing where the metastasis is, we are seeing uptake in normal and abnormal organs. So we are more accurate in our selection of patients. It helps us to predict response because predicting response, by the time you do your imaging and you see the uptake and you quantify the uptake, you can, to a larger extent, assess response and assess toxicity. In the end, what you will have is a better cure for this patient. Again, this is summary. So the summary of teratonics is that we are trying to kill 2 birds with 1 stone, maybe trying to kill 3 birds with 1 stone. We are doing diagnostic, we are doing treatment, and of course, we are also looking at other things related to the patient's disease. So in summary, teratonics is an emerging field in nuclear medicine, and it plays a significant role in cancer care. It is just like killing 2 birds with 1 stone. Thank you so much.
Thank you so much, Dr. Jawa. Dr. Jawa has just been able to take us through the fundamentals of nuclear medicine. He has told us what theranostic is, and the target actually is to, provide personalized treatment for patients. And we know that for us in oncology, that is the most important thing. You want to reduce toxicity as much as possible while you give the highest dose possible. And he has also talked about the advantages we gain from theranostic, and then the limitation, which of course we have the fact that it is complex, and then the criteria for assessing response is still not well understood. And he finally concluded by saying there's a huge prospect for theranostic. He has given us so many examples of tumors that can be treated with by using theranostic, which is applying both the therapeutic and the diagnostic portion of treatment. Right now, we will entertain questions. I think he has a question online. And then for the audience, we will take just 2 questions from the audience and then online. Okay. So 2 for the online. Please, can you give Dr. Bello the mic? Dr. Jama, please, can you still hear us?
Yes, I can hear you. Yes, I can hear. Yes.
Is Dr. Jawa still online? Okay. Dr. Jawa, you have some questions.
Yes, please.
Okay.
So thank you so much, Dr. Jha, for the brilliant presentation. When we invited you, we didn't expect anything less, and I think you have done justice to the topic. You were with us when we started at the National Hospital, and you started the first spec in Nigeria, actually, and we are still there, unfortunately, where you left us. How are you able to support your former department at the National Hospital to leapfrog forward to be able to do some of the brilliant things that you are doing in Sultan Qaboos Hospital in Oman?
Well,
The former
well, thank you,
minister
Dr. Bello.
now is here, so he's listening to you.
Well, thank you, Dr. Bello, for the compliments. Well, at the moment, the only thing I can do is to provide technical support to my colleagues in Abuja. They're still trying their best with the limited resources that we have, trying their best to provide quality nuclear medicine care to our patients. So I visit the department whenever I come home, and I try to, as much as possible, contribute to what I could with the limited resources, like I said. But resources has always been the issue, and some form of commitment is also another big issue. And those things are, I think, global. So, well, I'll just leave it at that, Dr. Bello.
Good morning, Dr. Jha. This is Dr. Ahmed. Before I ask my question, sir, I think I have an answer to Dr. Bello's question. One of the things Dr. Jawa is doing to help the department is by ensuring that the department is well staffed. And part of the reason why I am in the department at the moment, and I think it's a step forward. Thank you very much, sir, for this wonderful presentation. It's always a pleasure to listen to your presentation. I honestly don't get tired listening to you. My questions are as follows. Number one, sir, the imaging in prostate cancer, you've made mention of gallium-68 PSMA. What about technetium? In a country like Nigeria, where we only have one PET CT, I didn't hear you mentioning about the technetium PSMA. What is the studies showing concerning the sensitivity in comparison with the gallium? I just want to know what the data is saying. Second question, sir, is still about the therapy in prostate cancer. When the images you projected, we clearly show that there were a lot of uptake of PSMA in salivary glands. And that definitely means once we give lutetium, there would be significant uptake in the salivary gland. And one would definitely expect some side effects. I just want to know what you are doing to prevent the side effects to the salivary gland. I think I will leave it at that. Thank you very much, sir.
Okay, great. Yes, so the first question is regarding the use of technetium versus gallium-68 with PSMA labeling. There are quite a number of studies that have done to look at the two, and even in our department, we have tried labeling, but labeling PSMA with technetium is very tasking, and the sensitivity and of tagging is not really as good as what you expect. So if you compare them head by head, gallium provides you, it is more sensitive, The image qualities are better because again, we are using a PET CT. So these are the things. And obviously, because we have a PET CT in our department, we get the gallium-68 generator because we know it is quite sensitive. It detects more lesions and it is more useful, particularly in reoccurrence of disease. So you can use technetium, but again, the labeling procedures and the techniques is very cumbersome and the sensitivity is not as good. The second question regarding gallium-68 uptake in the salivary gland, yes, you can see that there's an intense uptake, but if you look at the half-life of gallium is quite low. In certain patients, all we do is to encourage them to salivate. One of the ways, just similar to what we do in radioiodine, is to encourage them to take sour drink so that it will encourage fast excretion, looking at the basic principle of radiation protection, or sometimes encourage them to chew bubble gum. Again, this is just to encourage salivary secretion. Again, there are a lot of studies that people have done to look at patients who have received gallium-68 therapy for imaging, particularly to see if there's any damage to the saliva, but there's no any significant damage to the salivary gland. So for gallium-68 particularly, it is not as worrisome. What will be more worrisome is when you are given a very high dose of lutetium. And again, there are certain mechanisms, like I said, it's the process of teratonics, of giving lutetium, giving high level of actinium. They are very tasking and there are so many protocols that we go that time will not permit me to discuss these things with you. But again, there are so many precautions that we take to reduce radiation to substances or to organs that normally will take up radiopharmaceuticals. One of them is the salivary gland and excretion in the urinary bladder and so on.
Thank you so much, Dr. Jawa. There are some questions for you online. I'll just, I don't know if you can access them so that you answer.
Yes. Now there's a question here of the interval between the cycles of lutetium. Well, the interval that we normally give is dependent at the moment, like I said, we don't have a clear guidelines as to what time would you repeat. So at the moment, what we're doing is we are using we do a multidisciplinary, for every patient, we do a multidisciplinary team meeting and see if this patient requires lutetium, if he's a candidate for lutetium. And when we give it, we do the imaging, post-imaging, we look at the biochemical profile, we look at the clinical situation of the patient, and that will decide whether we will repeat another dose. But optimally, the doses are usually given within 3 to 6 month interval, nothing less than that. So interval-wise for our own group of patients and most of the patients that are in the literature is between usually interval of 6 months. And the highest dose given usually is about 3 cycles. Maybe you want to know what the cost of each cycle is.
Thank you so much, Dr. Jawa, for the presentation. And I think we've had we should give him a round of applause.
Thank you.
So we will go on a recess now and come back after tea break to continue the session. Thank you. Tea break, tea break. Sorry, the tea break is just 10 minutes. Please just get your stuff and come back inside.
that mic for me. Check two. Check my one, two, 5, 6, 7, 8, 9, 10. Check two. Check my 1, 2, 5, 6, 7, 8, 9, 10. Ladies and gentlemen. So which one? Check. Row. Cut off.
You don't have any personal, any laser to point. No, it's okay.
And 2. Let me move this one. Check two. Check two. 1, 2. Check two. Check two. 1, 2. 1, 2. Number 3. Check two. 1, 2. Check two. 1, 2, 2. One, two. Check two.
Check 2, 1, 2. Two, 1, 2. 1, 2. Two, 1, 2. Check 2, 1, 2.
Therapy, immunotherapy, and immunotherapy. The unit is less than a year old, but it has treated a lot of patients with varying forms of cancers.
The University of Maiduguri Teaching Hospital Center of Excellence have undergone so many transformations under the leadership of Professor Ahmad Ahiju to provide quality and affordable healthcare services to the people. The institution has taken the bull by the horn by making a dashing entry into the cancer management space in Nigeria by establishing state-of-the-art cancer facility. The University of Maiduguri Teaching Hospital Cancer Center brings a new era of providing radiotherapy services. The center has successfully installed the Electra Infinity Linear Accelerator, an Electra Flexitron brachytherapy machine, a Varian Bravos brachytherapy machine, a 6-4 slice Canon CT stimulator, and a C-arm. Other facilities at the center include Electroversa HD linear accelerator awaiting installation. The center is designed to give comprehensive cancer care through provision of chemotherapy services, multidisciplinary clinics, and laboratory services. In this center is a clinic team comprising of clinical oncologists, medical physicists, therapy radiographers, and oncology nurses trained to provide better and oncology care. The center will key into research and capacity building by establishing partnership with the best oncology centers across the globe to solve healthcare problems. When commissioned, UMTH Cancer Center will play a pivotal role in providing accessible and quality healthcare for cancer patients, not only in Nigeria, but the whole of West Africa, as it is the first of its kind.
My name is Dr. Bolaji Latif Salako, consultant radiation and clinical oncologist, FMC Abeokuta. Our center is new and growing.
This is the Department of Radiation and Clinical Oncology, Federal Medical Center, Idiaba, Abeokuta. This is the radiotherapy bunker. You can see the work is in progress.
Cancer prevalence is on the rise in many African countries, while cancer deaths, especially for breast and cervical cancer, are dropping in high-income countries. They are on the rise in sub-Saharan Africa. Almost 50% of breast cancer patients in sub-Saharan Africa will succumb to the disease, compared to only 9% in the USA. Today, over 80% of the global death Cancer prevalence is on the rise in many African countries, while cancer deaths, especially for breast and cervical cancer, are dropping in high-income countries. They are on the rise in sub-Saharan Africa. Almost 50% of breast cancer patients in sub-Saharan Africa will succumb to the disease, compared to only 9% in the USA. Today, over 80% of the global deaths of cervical cancer occur in low resource settings. With the increasing number of lives lost due to cancer, Nigerian clinicians and experts are calling for improved cancer care in line with the global theme to close the care gap.
Cancer incidence is rising and often affects young people, especially women in their prime, and this causes huge socioeconomic loss to the nation. There are huge disparities with treatment outcome, with survival rates often depending on the side of the globe you live. This is a worrisome situation and really should not be. As clinicians with poor competency in treatment, this year's World Cancer Day activities, which is staying Close the Care Gap, really ignites in us a strong desire to improve treatment outcomes, and not just clinical outcomes, but also patient-reported outcomes. So really the question is, how do we close the care gap? What are the care gaps? With multidisciplinary team management being the standard of care, we proceeded to interview key opinion leaders who are actively involved in treating cancer patients. So take a listen.
Experts say the lack of data, misinformation, and the lack of awareness are some of the barriers to cancer care in the country.
Well, my name is Professor Innocent MNI. I'm the president of Nigerian Medical Association, as well as the Vice Chancellor of Federal University of Health Sciences. One of the things that we need to know is that we don't have sufficient statistics. A lot of work needed to be done on evidence, because you have to have evidence. Secondly, we know that people are not even aware. Many people are not aware, and they seek Babalawo, traditional healers, until it is very late before they come to the hospital. So the presentation is a big one. And we need to create more awareness among Nigerian people, because a lot of people are not aware. They may, because we are very superstitious. People who have cancers, if they come early, they may have been treated, but and they live longer life. But because of superstition, they will seek traditional or church healing, which obviously are the challenges that we face.
The unfortunate outcome of the prevalent misinformation and lack of cancer awareness in Nigeria is delayed care seeking and late diagnosis.
Many of our patients present late, very late. So that gap needs to be filled, how to get the patient early. That will tell a lot to the preventive activities you're doing, the activities to encourage early presentation, so that the patient might benefit. Otherwise, when you finish everything you do, they still end up dying. So if we have things to help to improve that early presentation, then those of them that come for treatment have better chance of survival.
I'm Professor Francis Luosini, consultant, prevention and clinical oncologist, and the chairman of the board of trustees of the Association of Clinical and Radiation Oncologists of Nigeria. I would like to suggest and recommend seriously that we also promote early diagnosis of cancer, and also make such procedure more accessible and affordable to our cancer patients. Also, after diagnosis has been established, I want us as much as possible to guarantee early treatment.
As pointed out by Professors Emmanuel and Durosimi Eti, many breast cancer patients present at stage 4 after trying alternative remedies without improvement. At this point, the cancer has spread to other parts of the body, and the chance of survival is approximately only 20%. Comparatively, the survival rate of women diagnosed early can be as high as 90%. In North America, thanks to screening, early detection, and improved treatments, breast cancer deaths are dropping. Increasing awareness, early detection, and treatment are paramount if Nigeria is to close the care gap. In addition to lack of adequate prevention and diagnostic measures, lack of resources, both human resources and infrastructure, continue to hamper efforts to close the care gap in Nigeria.
I am Dr. Bello Abubakar Mohammed, the Chief Consultant, Clinical and Radiation Oncologist at the National Hospital here in Abuja, Nigeria. I'm the immediate past president of the African Organization for Research and Training in Cancer, IOT. The two most important gaps that I have identified are in terms of equipment as well as capacity. Do realize that Nigeria will require a minimum of 3,000 radiation and clinical oncologists. We have less than 100 at this point. And in terms of treatment, radiotherapy equipment are really lacking. For a country like Nigeria with 200,000 population, we will require, by WHO standard, 200 radiotherapy equipment, and we have less than 10.
My name is Saba Isiaka Mobolaji, the lead radiation therapist at NSI Youth Cancer Center, Lagos, Nigeria. You should understand that among the World Health Organization, for each 1 million citizens, you're supposed to have one radiotherapy center. If Nigerian citizens is 150 million, you're supposed to have 150 radiotherapy equipment. But unfortunately, presently, we have only 5 radiotherapy centers that is working. For the whole population of the country, we have less than 100 oncologists. We have less than 25 certified radiation therapists. We have few physicians and we have few oncology nurses. For the federal government, state government, individual, let's try as much as possible to put resources together and have more of these centers.
The scarcity of equipment means that treatment is inaccessible to most, and when available, it can be very costly. For example, in Nigeria, radiation therapy can cost anywhere between hundreds of thousands to millions of naira per course. Additionally, without universal healthcare, most patients pay for their treatment out of pocket. Considering most Nigerians make less than 30,000 naira a month, the cost of
Settle down, please. Can we all settle down? We need to start the next session. Thank you. Please, can those outside come in? Let's start. We need to start the next session, please. Okay. Sorry, there's a bit of adjustment in our agenda. And so we'll be taking another presentation before the next session will be ready. We'll bring a presentation from the afternoon session. As we all know, precision medicine, personalized medicine is what we aim at in oncology. And to continue the nuclear medicine segment, we're going to call on Dr. Pedro. He's going to be presenting to us fundamentals of PET-CT imaging. Dr. Pedro, please. Dr. Pedro, you have 20 minutes for your presentation. You have 20 minutes for your presentation, and then we'll take questions. Thank you. We're running. Sorry.
Okay.
Yeah,
so,
so
I will try.
At 20 minutes, we'll give you 5 minutes more. So you take 5 minutes and then 5 minutes.
I'll try to push because I was thinking about 30, so I'll try not to go overboard.
Thank you.
Should I wait for a couple of minutes? So this is the left. At where? Okay. So very good morning. So the idea with this presentation, I'll try not to go overboard. The idea was just to give a general overview, short overview of PET imaging, but focusing also on the pitfalls, some of the pitfalls we might have with PET imaging. So first of all, it's a pleasure to be here. Thank you for welcoming me in Nigeria. This is my first time in the country, and I truly have seen that it's a beautiful country with beautiful people. So I hope to come back in the near future. Start? Okay. Okay, so classical medical imaging also always focused on form. With nuclear medicine and PET-CT, we can overcome some of the strengths and limitations of form, because treatment planning questions always remain about response to therapy, about tumor biology, and if it's too soon to see any changes regarding my therapy just with anatomical imaging. So PET-CT is where form meets function. The anatomical imaging will truly be overlaid with a functional and biological imaging. This would lead to more accurate biopsies, more accurate disease staging, more accurate treatment planning, and more accurate therapy response assessment. And all this with improved diagnostic confidence will have the ultimate target, of course, that is improved patient management. So this is just the basics for any nuclear medicine imaging. So we will have a radionuclide that is connected to a tracer. The radionuclide will give us the physical characteristics of the radiation that we are using, and the tracer will give the specificity for the organs that we want to study with SPECT and PET, but we will be focusing on PET. So the tracer is what will give the radio tracer its specificity for the organ in question. So we have an array of tracers that allow us to do an array of different studies, like bone studies, thyroid studies, basal ganglia, MIBG studies, cardiac studies, and it's all dependent on the tracer that you are using. So like it was said beautifully in the presentation before, we have two kinds of radiations that we can use in nuclear medicine. The low-level radiations, X-rays and especially gamma rays, and the high-level with alpha and beta radiations that can be used for therapy. So of course, nowadays we have diagnostic and therapeutic nuclear medicine. Theranostic. So in practice, you can treat what you see. So you have the diagnosis where you have a radionuclide linked to a low-level radiation, and in therapy, you have the tracer connected to high-level destructive radiation. Of course, the workhorse for all PET studies, oncological PET studies, in more than 90% of PET studies is FDG. So FDG is the binding of F18, the fluoride that gives off its PET radiation, and glucose. This will be uptake. This will be inserted into the cells in the GLUT transporters. And why does FDG accumulate in tumor cells? For two reasons, essentially, because in most tumors, not all, but most tumors, there is an overexpression of GLUT receptors. And unlike, let's say, normal FDG, once the FDG is phosphorylated inside of the cells, it will become trapped. So this is the rationale that over time, FDG will have a higher and higher activity in tumor cells. Regarding lesion detectability, what are the main factors? Why are you seeing or not seeing the lesions? Of course, glucose receptor density. If there are no glucose receptors in a cancer subtype, you will not be able to see the tumor. The volume, you must have enough receptors so that, or enough cells that you can see them with the PET scan. and the patient's metabolic status. The patient's metabolic status is, of course, one that can cause some pitfalls usually. Things to keep in mind, FDG is not specific for malignancy. Why? Because, of course, there are other cell types apart from tumor cells that also express or overexpress GLUT receptors, such as cells in atherosclerotic plaques and macrophages. So anything that is related to inflammation and infection and has a macrophagy infiltration can show up on the PET scan. So of course, not all that will shine is gold, let's say. So regarding pitfalls, what are the essentials? You have to know your tracer distribution. Different tracers, different distributions. There might be physiological uptake variants, like with hyperglycemia, or insulin administration, exercise, recent exercise, brown fat uptake, and tracer uptake in other non-oncological conditions like inflammation and infection, and iatrogenic like immunotherapy and pleural disease. Just two examples. So this is the typical normal distribution for FDG and PSMA. So you see immediately with FDG, there is a very high cortical brain uptake. This is like our quality control for FDG. If your patient is has just been scanned and you see there is not this high activity in the brain because something was wrong. Maybe there was hyperglycemia, maybe the patient's demographics, namely the weight, are entered incorrectly into the system. So, but you have to check what this is about. This is the quality control for FDG. It's the brain activity, or the most important one, let's say. For gallium PSMA, of course, we'll have a totally different distribution. Activities mainly in the salivary glands, in the kidneys, liver, spleen, and gastrointestinal and urinary excretion. Just to confound matters a little more, just quickly, just regarding the PSMA tracers using for prostate cancer, you know, the same tracer, but with the different radionuclide, gallium PSMA and fluor PSMA. Gallium PSMA has a kidney dominant expression and fluor PSMA a liver dominant expression. So if you are looking to stage locally or to restage locally, fluor PSMA might have some advantages over gallium PSMA because typically it has very low to none urinary excretion. This is just the insulin effect. So you see patient, this is the same patient, but on time point A, he had insulin just prior to the PET-CT administration. So to the PET-CT injection and the PET-CT scan study. So you see that all the activity is centered essentially on the muscle, and there are no physiological activity in the kidneys or in the liver. So you might think, okay, but I'm looking at a lung tumor. So maybe it's okay because there's no activity in the lung. Of course, no, because if you try to use this image to stage a tumor, you won't see the tumor. Why? Because of the sink effect, because of all the FDG that is in the muscles. There is, let's say, not enough FDG so you can see the tumor. So never accept a technically substandard study to base your clinical decisions. Always check that the study is up to par technically. Brown fat uptake. So this we see sometimes, especially in younger patients. This is a very typical distribution along the paravertebral and supraclavicular spaces bilaterally. And of course, what is important here is to check the CT scan so that this corresponds to areas of fat, of hypointensity in the CT scan. So by itself, it wouldn't be an indication to repeat the scan by itself, but if it's critical, like in a lymphoma patient, if you have doubts about a recurrence in let's say, a particular lymph node area, and the brown fat uptake is obscuring that, if it's critical, you can repeat the scan, and before the next scan, you try to administer a beta blocker. This might be helpful. Just two examples of iatrogenic conditions in immunotherapy-induced hypophysitis and colitis. So PET has the potential for quantitative measurements. Let's say you can measure the activity in a given voxel. You can say how much activity is there dependent on the patient weight and the voxels counted. And this is optimal, of course, for therapy response assessment. Also, the SUV of some tumors, of most tumors, like lung tumors and esophageal tumors, is in direct relation to the prognosis. So these are general indications for PET-CT in oncology. I will not go through them, like diagnosis, staging, response evaluation, restaging, and radiotherapy planning. So just out of curiosity, You can see that in this article, it's more than 20 years old, from 2000, they're already talking about the concept of biological target volume, and that PTV can be derived from biological imaging. And they were thinking or coining the terms dose painting and dose sculpting. So even more than 20 years ago, we were already aware that morphological imaging by itself could not be sufficient. So regarding the indications, especially when you have limited availability of the resources, it's very important to refer the right patients for imaging, namely PET-CT imaging. So it's, of course, essential to be familiar with the indications for PET-CT. The IEA Human Health Series since 2012 has tried to organize these indications. So you have on the top most of the tumors, or the most usual tumors where you are using FDG, and on the bottom you have the warning that, of course, many tumors are not FDG avid, like gastroenteropancreatic tumors. You can also okay, so you cut 10 minutes for my presentation. I will try to be fast, but not what's also agreed, but that's okay. So the NCCN guidelines, just to refer, this is this very good recent article from 2020 from Dr. Ghulam Sayed. It's a free article, and it will give you the full overview about not only the indications, the appropriate use of FDG PET, but also the limitations of the FDG PET study in most tumors. So if you are interested in the subject, this could be a good option. So this is just to refer, what will be the impact of PET-CT scan? So this is already also from 2008, this from the Americans. This is just from the National Oncological PET Registry. They asked clinicians what they thought that their strategy changed after the PET-CT. No change, minor change, major change. So from all the data gathered, there was a major change or important change in management in approximately 1/3 of the patients. So this is just about how powerful PET-CT can be when used in the appropriate indications. There are just some examples: an upstaging of a right lung tumor to N3. You can see homo and contralateral mediastinal lymph nodes. For radiotherapy planning, of course, you see this recurrence in the bronchial hilum in a left lung operated patient. And even with a contrast CT, you can have a very good delineation of the recurrence that, of course, you cannot do by morphological imaging alone. As we saw yesterday, this is an image from an ectalectasis. You can see clearly where the central tumor of the right of the left upper lobe is located, and additionally, you can see a 4L homolateral lymph node. So this is, of course, very important for radiotherapy planning. It is essential because if you look at the upper row of anatomical imaging, you can see no difference, no objective differences in density regarding the CT imaging. Response in Hodgkin's lymphoma. So I will just go through quickly with the PSMA. That's just, of course, based on the incidence. It's another tracer that you'll be using a lot. So of course, all the different expression of PSMA in different cells, it's not specific for the prostate, as we know. PSMA's expression is related to the tumor aggressiveness, is related to the Gleason score. It's heterogeneous, so inside the same tumor, you have different grades of PSMA expression. And like FDG, there are a lot of pitfalls regarding PSMA. Why? Because there is also neovasculature in other cancers, and there are PSMA receptors. PSMA can have uptake in celiac and the cervical ganglions, in the stellate ganglions. One of the clues is the uptake is usually less intense and near the paravertebral space than the PSMA positive lymph nodes itself. Metastatic renal carcinoma, another cause for false positives, hepatocellular carcinoma, extensively proven prostate cancer metastasis, and histologically proven lung cancer metastasis. So it's metabolically, they're exactly the same. So just be mindful of these pitfalls. And when you are imaging with PSMA, there can be another tumor in hiding, namely another lung tumor. If you're having a good response to therapy and there is one lesion that is not responding, so maybe think about a different tumor type. Granulomatosis, spondylophytes, hemangiomas, even Paget's disease can have low-level uptake. For clinical applications, of course, primary staging of high-risk patients and biochemical recurrences. What do the NCCN guidelines tell us? This PSMA is formally used for very high, and unfavorable intermediate patient groups. And regarding this note about bone and soft tissue imaging, the committee has said that PSMA has a higher sensitivity and specificity than conventional methods and can be used instead of the conventional methods in these patients. So instead of the bone scan and the CT scan, PSMA is the new standard for conventional imaging for prostate cancer staging patients. So if you're staging a prostate cancer with intermediate, high, or very high level, you just need the MRI for a local staging, and for the N and M staging, you can use the PSMA. You don't need any more imaging. So just to finish, almost finishing, because I had a trunk in my presentation time. So this is the kind of lesions that we can see with PSMA PET. You see a lesion, a metastatic lesion on the bone marrow. There is no correspondence on the CT. And now that the lesion is getting better, you can see a foci of sclerosis on the CT, but the PSMA is negative. Also dependent on the size, like we said earlier, smaller lesions, smaller lymph node lesions will not be seen by PSMA up to 4.5 millimeters in size. For biochemical recurrence, don't look only at the absolute PSA value, but also the velocity of the PSA duplication. This is very important. This is just to show that PET detectability, PET positive studies are directly related to the Gleason score and also to the PSA level. So after a level of 0.2 or 0.5 in biochemical recurrence, you can use a PSA scan because up to 60% of the studies will be positive. So for very low, 5 minutes, okay. So for very low levels of PSA in recurrent, biochemically recurrent patients, especially if the PSA velocity is, the PSA doubling time is low, you should use the PSA, the PSMA study, because it can show early or oligometastatic recurrence. So this was referred by in the last presentation regarding, of course, PSMA has a formal role in staging and restaging in biochemical recurrence, but not in therapy response. So therapy response, it's still not a formal indication for PSMA to be used. It may be appropriate in this clinical scenario, according to the committee. Very quickly, pitfalls in therapy response assessment. Flare phenomenon. You can have patients that are get better clinically and biochemically, but the image can be paradoxically worse. Why? Because there are lesions in the bone marrow, like we saw, that are getting more sclerosis, but they have less tumor cells. The PSA level is getting lower. This we can see with the bone scan. One common cause of the flare phenomenon in PSMA studies, it's the initiation of androgen depriving therapy. Androgen depriving therapy, the beginning of androgen depriving therapy can have a flare effect on the PSMA, on the receptor expression, and you can have a paradoxically worse scan, but the patient is in fact responding to treatment. So what do we take from this? That if you are using the PSMA PET to assess therapy response to ADT, wait at least 1 to 2 months before performing the scan. Earlier than that, you can have misleading results. Also for brain metastasis, you can see there is like a flare phenomenon on the occipital bone after 3 months, and after 12 months, the uptake has decreased. So always be aware of this flare phenomenon in metastatic prostate cancer patients, especially after the beginning of a new treatment. So just to finish, it's just one, this is a very, very quick talk just about the brain tracers, this about the MICURE Center. Just be aware that they will be introducing in the near future the FLT and the FDOPA. So just remember of the huge limitations there are for FDG in scanning brain patients just because of the background activity. These tracers can be used to grade the lesions, of course, to direct biopsy, for radiotherapy planning, for responsive therapy, and in the differential diagnosis of radionecrosis and recurrence when you have a doubtful MRI study. So just think of these tracers that apparently will be available in Nigeria in a very near future, and don't rely on FDG for brain imaging, except for very aggressive tumors. So this is an example. And you can see you can have a different biological tumor volume than the GTV. So this will help you in radiotherapy planning. So this was all I had. Thank you.
Thank you, Dr. Derek. He is a consultant nuclear medicine specialist from the Neurospinal Hospital, Dubai. And he has just taken us through the fundamentals of nuclear medicine again. And he has shown us the oncological applications of using PET-CT in oncology. He has also shown us some perils and pitfalls when interpreting PET-CT. Most importantly, he has discussed the timing for sending patients after treatment for PET-CT, especially the gallium-68 PSMA scan. Clinicians should ensure they wait for at least 2 months so that you can prevent the flare phenomenon and prevent false negative or false positive results as it may be. We'll take some questions, 2 questions from the audience, and then if there's anyone online for him, and then we'll close the session. Thank you. Okay, Dr. Ahmed, please. Please, can you give him the mic?
Thank you very much, Dr. Pedro, for this wonderful presentation. My question is your experience. I don't know whether you showed us images on fluorine 18 PSMA and then gallium 68 PSMA. From your experience, which one would you prefer to use? And then the second is actually a comment, not a question, is about tumor biology. Not all prostate cancers actually can be seen very well with PSMAs. We know if the prostate cancers have gone undifferentiated, or if they have neuroendocrine transformation, we need to use the FDG, fluorine FDG for that. And then for the neuroendocrine differentiation, we might have to consider using DOTA. Thank you very much. Someone has asked, my name is Dr. Ahmed again from National Hospital. Thank you.
Okay, thank you for the questions. Yes, regarding F18 PSMA and gallium PSMA, I'm most familiar with gallium PSMA. We're just starting using F18 PSMA now that I moved to Dubai, but I think both are good options. Regarding F18 PSMA, the clear advantage, like I said, it's about local imaging because the bladder can be a confounding factor in local staging or local restaging. You might have to give some furosemide or even to place a Foley catheter if you have any doubts regarding bladder activity versus prostate bed activity or prostatic activity. The main drawback with F18 PSMA, I haven't seen it yet, but there are some reports that it can have some false positive bone lesions. So you just have to be mindful. If you have a patient that's done a study with F18 PSMA and the only cause for the patient to start a new treatment or to take a clinical decision is a single bone lesion, just be mindful of that. Okay, it may have some faint uptake in the bone marrow that can be confounded with a bone metastasis for F18 PSMA. Regarding the other question was about, sorry? About the differentiation. Yes, of course. So this is like for many tumors that we have seen this, for thyroid tumors, for neuroendocrine tumors, that they differentiate, become more aggressive, are starting to express other receptors like glucose receptors. And yes, you are entirely right. Of course, you will not use these in the first line of prostate cancer. First line imaging is PSMA, but it's totally, of course, logical to use DOTA-8 or even FDG in these patients in metastatic castrate-resistant prostate cancer patients, and the tumor, of course, in many cases, it will differentiate. But you will see this, even if you are doing like radionuclide therapy or whatever, that you don't have any uptake, but still biochemically and clinically, the patient is getting worse. And of course, in those patients, you should consider formally to get another tracer, but only on these cases, never has a front line because namely FDG, you may be tempted to use FDG, but the amount of false negatives in prostate cancer is, of course, totally unacceptable for staging.
Thank you for your presentation. My name is Professor Tajuddin Olasinde from Ahmadu Bello University Teaching Hospital, Zaria. The 2 months that you are suggesting for us to wait. Now, let me take you back to another tumor. Let's say I've treated the case of follicular lymphoma, and I want to check post-therapy. What has happened? Can't I ask this patient to go for PET-CT in 3 weeks using FDG? Then for the prostate, in our environment, we can have an aggressive tumor, especially in the Black population. So 2 months, I'm afraid you are thinking of the flaring effect, and at the same time, if it's a tumor that is aggressive and you have poor response, don't you think that tumor will have been progressing before waiting for 2 months? I want you to respond to that. Look at the 2 scenarios.
Sorry, if I understood this question, it's about a patient that is has an aggressive tumor and it's PSMA negative. If it's a prostate cancer first line, you always have to do it's to use PSMA. Of course, if you have a negative PSMA in the context of biochemical recurrence, you can use FDG, almost immediately, just to document it's an aggressive tumor and where the tumor burden is located. Okay, so you have these formal indications for PSMA in biochemical recurrence, and like I said, it could be as low as a PSA level of 0.2. So use the PSMA on these patients, and immediately after you can use the FDG. The timings I talked about, it's in PSMA positive PET studies while evaluating response to treatment. If you scan the patient too early, you might get, in a lot of cases, misleading results. I don't know if I answered your question. Maybe I didn't understand it fully.
Okay, he asked another question on follicular lymphoma. He said if you treat
lymphoma, sorry, I was sorry.
Yeah. Okay, so he's asking if you can, if he can send a patient for a PET-CT scan after like 3 weeks after treating lymphoma, since it's very
lymphoma. Yes, sorry, I didn't get the initial part of a question. Of course, in lymphoma, for chemotherapy, recommended waiting time is 2 weeks. After 2 weeks, you can rescan the patients, and then a lot of patients in lymphoma, of course, you are scanning not after 4 or 6 cycles, you are scanning after 2 or 3 cycles just to see an early response to treatment. So after 2 weeks, you can rescan a lymphoma patient after chemo.
I have a question here.
Okay.
Dr. Berro, thank you very much for this wonderful lecture. About the PET scan is really very important images in the staging and therapy management. In my field, I struggle a lot with having, the radiation necrosis versus the progression of the tumor in the brain. So we know that this is kind of a new PET scan with the DOPA, FDG, whatever, fluorescence. That's help, to differentiate between the necrosis and the tumor. My other questions is, does PET scan helps also to with the diagnosis of this low-grade gliomas versus high-grade glioma, especially in the area biopsy cannot be done or no any surgeon can go there because of the location?
Thank you. Yes, these PET tracers, not FDG. Well, FDG you can use for more aggressive tumors like GBM. But if you look at these tracers, yes, they can give you an idea about the glioma grading and like I showed, about where to biopsy. If you have a lesion, heterogeneous lesion on the MRI, you should try to biopsy wherever the most intense activity is in the PET study. Just do a fusion study. For the brain, it's easy because there will be no organs moving. So it can be helpful in that way, yes, and also for tumor grading. F-DOPA and FLT.
Okay, so thank you, Dr. Pedro, for the presentation and for answering the questions. I just want to add to what Professor Olasinde asked. There's for lymphoma, there's the concept of interim PET. So it's the interim PET will help you to decide whether you want to continue the treatment, whether you need to even add more, because remember, it's a very responsive, very sensitive tumor. And so after 2 or 3 cycles, you can do an interim PET to decide whether you need to even add additional chemotherapy for the patient. And then what he was talking about, the scan after treatment, I think basically it's normally after you have completed your treatment to follow up your patients. And if you want to determine treatment response, if you do it too early, before at least 2 months, then there might be flare reaction that will be reported wrongly as an exacerbation of the treatment or non-response of the treatment. And it might just be flare response of the tumor to the chemotherapy that has been given. So that's why it's important you wait for at least 2 months for the reactions to have subsided, and then you can now scan the patient. Thank you. Dr. Pedro, thank you so much for this session. We appreciate that. Thank you. And so we had a little bit of change in our agenda, but now I'll be calling on Dr. Amaka Lashebikong for the next session, the Lancet Oncology session. Thank you.
Very good morning. I think by now we're saturated with all the sciences and all the breakthroughs and all the, well, what we call in the, what we call the jargons that have been so said and so eloquently delivered. I want to welcome all of us here, and we're going to do a little bit of difference. So we're going to be talking to ourselves, by ourselves, for ourselves, so that we can actually forge on with what is happening. At this moment, can I please ask that, because we're going to have a new session, can I ask that we be upstanding while together we would sing proudly the first stanza of the national anthem? May I please request that? First stanza of the national anthem. Thank you very much. We'll do this after the count of 3. 1, 2, 3. Arise, O compatriots, Nigeria's call obey, to serve our fatherland. Peace and unity. Please be seated. I'm excited to be part of the 5th Annual General Meeting and Scientific Conference of ACON. And at this moment, I would just quickly like to, I know everyone here is important to be part of this, particularly to this session, where the Lancet Oncology Commission report will be launched in Nigeria. Before I go further to give you an insight into why this session is so important, let me just quickly recognize that we have with us Honorable Dr. Yusuf Tanko Sununu, who is the chair of the House of Representatives on Health and has been very, very active. Thank you very much, sir, for being part of this. And we need that, representation from government, very importantly from the legislature. And thank you for all that you're doing concerning cancers and other health-related problems. Thank you so much, sir. Well, I'd also like to recognize, when I see him, I get very excited from not talking about heights, but talking about the fact that it's not how tall, but how well. Please welcome warmly with me our immediate past Honorable Minister of Health, Professor Isaac Adewale, who has been my mentor and a great support of me since I started as a rookie health correspondent. I'd also like to recognize a wonderful woman. We have met before and we're meeting again today, and she hasn't changed a bit. Jennifer Dent, President, CEO, Vow Ventures for Global Health. Thank you. I'd like quickly also to recognize Mrs. Kemi Eriganomma. I hope I got that name right. Chief Operating Officer, Genrook Laboratories Limited. You're welcome. That we're here today, I'd like also to quickly recognize the senior special assistant to the Minister of the Federal Capital Territory on Health and Hospitals. I call him he for she, Dr. Ejike Oji. You're welcome. Also like to recognize that we have the BOT chair. Prof to me is a father. Prof has ensured that there's sustainability with ACON. Please welcome warmly with me, Professor Durosimi Eti. Sir, you're welcome. Thank you. I also have with me here, yes, thank you. I also have with me here the Professor of Professors, I call her. And I've told her she has to do a book for us on staying young forever. Welcome with me, Professor Ifeoma Okoye. For us, is Breasts Without Sports. That's it. Director of the UN and very many things showcasing the strength of women. My brother is here too, and when I got into the hall this morning and I saw the way everything has gone, I know that you cannot have the chairman LOC and have anything less. And the conversations around the scientific presentation has been robust since I got in this morning. I'd also like to give special recognition to the chairman LOC, Dr. Bello Abubakar Mohammed. I know that everyone here is important. I have my oxygen, I call him my oxygen, Dr. Lauyu, where are you? The secretary, so that I do not leave anyone behind. But I'm sure that all of us here today are important and part of the move, which actually has drawn me to be part of this launch of changing the narrative. And I quickly like to just ask, us to reflect on this and, what the commission themselves have written. I'm not rewriting. And that for me is the engine and the oxygen we need today. We've had too many reports, too many words, too many good intentions, too many families torn apart, including me, and too many excruciating, painful deaths to see yet more delays in taking collective action to accelerate cancer control. I would like to add treatment prevention in sub-Saharan Africa has become a must do. And I'm sure that this is the spirit in which we all have gathered this morning. I have here something that I would say this is the 5th launch of this particular report is been launched in Ghana, in the US, in Sweden, in Tanzania, and today we are witnessing here in Nigeria. The Lancet Oncology Commission report for Sub-Saharan Africa is a major report to inform the world and indeed policymakers about the state of cancer in Sub-Saharan Africa and indeed Nigeria. So before we continue, I would, yes, I have some new names coming in. I'd like to recognize Dr. Uche Nwoku, the Director, National Cancer Control at the Federal Ministry of Health. Where are you, Director? You're welcome, sir. Also like to recognize my own doctor. You can see that I needed help climbing the steps, but I'm doing good. Dr. Gwedengbe, Chief Executive Officer, Cedar Crest Hospital. You're welcome. Oxygen? You see, he came. We also have from the FCMB, the bank, Mr. Kaigo David, right? Yes, you're also welcome. Very important. We need to recognize those bankers that will help move these action towards forward. My name is Mojima Konchola, and I'm very pleased to be part of this today. When you work with a woman, you have to get it right. When I was invited to be part of the moderator for this event, I can tell you that my phones have not stopped ringing. And when you are working with Amaka Lashibikon, letting me know that outside the fact that she's a doctor, she's also wife of Yoruba. So, but the good thing is that we're working towards action and less words. It is on this premise that I'd like to invite her, the president, to please give us a welcome address. Dr. Amaka Lashibikon.
Good afternoon, distinguished ladies and gentlemen. I'd like to stand on existing protocol that has already been laid by our dear Auntie Moji, as she's fondly called, in the oncology sector. But even as I stand on existing protocol, I'd like to, in just 1 minute, because I'm mindful of time, especially recognize the presence of the Honorable Dr. Yusuf Tanko Sununu. Thank you so much for coming. The former Minister of Health, Professor Isaac Adewale. Thank you, sir. The Special Assistant to the Minister of the Federal Capital Territory, Dr. AGK Oji. My very own boss, founder, CEO of Rest Without Sports. If I don't do this, I won't have a place to go back to. Professor Ifoma Okoye, thank you so much for making time to be with us. And of course, the BOT chairman for all the support he has given to the association, Professor Durosimieti. Last but certainly not the least, my boss from way back, the CEO, Cedar Crest Hospitals, Dr. Felix Ogedengbe, or as we fondly call him, Captain Ogedengbe. Thank you so much for joining us. Thank you so much, everyone who is seated here. You are all very special to us. We sent out this invitation because we know that it's a matter of national concern that we are talking about here. We've spent yesterday and the better part of today talking about various issues that helps us to redefine cancer care as we know it here in Nigeria. We are all very aware of the statistics of cancer in Nigeria, with 72,000 deaths recorded annually and over 100,000 new cases, which we know is actually does not paint the true picture. It is time for us to collectively look for long-lasting, sustainable solutions that can change the present narrative that we find ourselves in today as regards oncology care. And to this end, when the opportunity came for us to be able to launch the Lancet Commission Oncology Report on Sub-Saharan Africa in Nigeria, I seized it with 2 hands because I knew it will help us to jumpstart the process of moving cancer care to the front burner and ultimately finding long-lasting solutions to improve the present narrative. Again, in the interest of time, I will not say too much, but to welcome all our esteemed guests who have traveled far and near, to all our international partners who have made it here. Thank you so much for coming. I know how exhausted you have been going around preaching the gospel, but thank you for your tireless commitment. And once again, I welcome you here. To all our guests, thank you. Thank you so much for coming.
Thank you very much, Dr. Amaka. May I please quickly call on Professor Ngwa? Yes. Please let's welcome him warmly. I know this outfit from South Africa.
Good morning. So all protocol respected, I really want to say that we are very honored to be here today for the launch of the Lancet Oncology Commission report for Sub-Saharan Africa. Like Amaka said, we have had 5 launches so far. The first one was done in Ghana with the government of Ghana. Was with honored, we had the First Lady who was there and really committed to really driving this in Ghana. After that, we had a big launch in Washington, DC. And we actually had very strong commitment from the White House. And we're actually looking to engage with Africa in partnership to really address the cancer crisis we're going to talk about today. Then following that, we had a launch in Europe to build collaborations there. We had the First Lady of Rwanda who was there, and one of the models for eliminating cervical cancer. And that in this report that we're going to talk about today, we actually think it's also a commitment that is really critical for Nigeria to be on that pathway. Then finally, we just flew in from Tanzania, where we did this with the government of Tanzania, and also very strong commitment there. And so today, it's actually doing it here in Nigeria is special for me because I think this is home. As you can see, the way I'm dressed, I'm actually from Cameroon, very nearby. When I arrived at the airport, the person checking my passport looked at my name and said, "Hey, you're my brother and sister." And I said, "Yes, I am." But I'm really, this is really close to my heart that I can be here. And I really want to thank ACON for taking the opportunity, like Amaka said, to do this. I would like to also say, let's really appreciate Professor David Collingridge, who is here, the editor of the Lancet Oncology. He has been, coming many miles across Africa because he realizes the importance of this initiative. And so, he really wants to see impact happen after this. So I really think that that's really important that he's here to recognize him. Okay, so just to kind of wrap up, I want to say that today's launch event, we expect that we are going to talk a little bit about, there are 54 commissioners. I want to recognize those 54 commissioners who were part of this Lancet Oncology Commission. At least 50% of those were from Africa. And I'm just one of the chairs. I want to recognize the other 2 chairs, Professor David Kerr from Oxford University and Dr. Beatrice Adai, who is in Ghana. And today, I just want to say on behalf of those commissioners that, we really think that this is something that we should not, just another report that you're going to put on your shelves. This is something that you would see that all of us can be part of making action to implement change. So thank you very much. I'm going to now welcome Professor David Collingridge. Oh, you are going to do that.
Thank you. Thank you very much. I think he deserves a very loud round of applause. Dr. Ngwa is the Director of Global Health Catalyst, one of the chairs of the Lancet Oncology Commission. Another round of applause for him. Very soon, we are going to have the spirit of Lancet Oncology Commission, Professor David Collingridge, who will speak to us. But before then, just let me quickly recognize a few names. Board of Trustees of ACON. I know that we have Ms. Dr. Ibinoba Festus is here with us. You're welcome, sir. Dr. Aliu Malami, you're welcome. Professor Ade Nipekun Adeniyi Abidemi, you're also welcome. Professor Sunday Adewuyi, you're welcome. Dr. Kenneth Chima Nwanko, is also here with us. Dr. Oyeshegun Adisa Razak, a member, and Professor T.A. Ola Sinde, you're all very, very welcome. Quickly, please, let's also recognize that we have representing one of the very serious advocates and working in several states, representing Her Excellency Betty Anyao Akeredolu, First Lady on those states, is Ifeoluwa Awojelu. You are also very welcome, representative of Her Excellency. We are moving on now, and I'd like to invite Professor David Collinridge, Editor-in-Chief, the Lancet Oncology, to speak to us. Prof, let's welcome him warmly. Thank you.
Good morning, everyone. Dear distinguished colleagues, friends, it's great pleasure that I'm standing here today, and I'd like to thank ARCON for this opportunity for us to present this report on cancer control in sub-Saharan Africa. Following many years of discussion and increasing concern about this issue in multiple academic fora, this project formally started in June 2019. It started as a holistic exercise to take a view of the cancer challenges facing the African continent as non-communicable diseases start to overwhelm healthcare systems. As you're all well aware, the Sub-Sahara comprises 46 countries and a total population exceeding 1 billion people. This continent has long suffered high morbidity and mortality driven by infectious diseases, malnutrition, and poor maternal and child health. But it's also now being affected by the growing incidence of cancer and other NCDs. This double burden of disease is a consequence of lifestyle and behavioral changes, a shift in the patient population demographics to an aging population, etiologies caused by globalization, infection, and environmental factors. The health of the people in this part of the world, where fragile health systems are underfinanced, under-resourced, and understaffed, needs to be of global concern and needs to change. Cancer incidence in sub-Saharan Africa is estimated to have doubled over the past 30 years. And without effective interventions now, the number of cancer deaths in this part of the world is expected to exceed more than 1 million by 2030. That's a startling number. That's 7 years' time. In May this year, the Lancet Oncology published the report that you all have in front of you today. This commission, alongside 2 research articles and a series of commentaries on cancer control in sub-Saharan Africa, highlights the region's rapidly rising cancer burden, the major challenges that exist, and the key actions that need to be taken urgently to address this escalating emergency. This morning's symposium, you will hear from commissioners who oversaw this project, which included, as Dr. Ngwas just said, over 50 renowned international experts, many of whom were from the African continent. You will have an opportunity to question these experts about the cancer epidemic we face and the solutions they have proposed. And you will hear a number of recommendations for action that should be prioritized and implemented as a matter of urgency, including establishing and maintaining robust cancer registries, creating effective cancer control plans, incorporating cancer care into universal healthcare, early cancer screening and detection, incorporating palliative care into the cancer care pathway, building and training the oncology workforce, boosting cancer research, and increasing the use of telemedicine and other new technologies. This report further emphasizes the need and the importance of implementation research in clinical care pathways and enhanced service delivery. And finally, in terms of financing, the commissioners suggest that financing should be initially prioritized for the most cost-effective measures, as we've heard a little bit about this morning in some of the case report presentations. Cost-effective measures such as vaccines for preventable cancers, more affordable treatments that affect the greatest clinical cost-benefit ratios. And they recommend that transparent and dedicated revenue streams should be established with the input from international collaborators as needed to finance these specific measures. Now, although each nation across Africa will need to adapt these recommendations to suit their specific situation, with political determination and a coordinated approach across this region and the world, improved cancer care is achievable. So I'd like to thank you all for this opportunity this morning and for attending the event. And we will, I think, move straight into the sessions, or would
Yeah, we'll just take one or two interventions and then, yeah, okay. Thank you very much. Thank you. Okay, we would, yes, he's already seated, but I'd just like to digress a little. I'd like to call the chairman LOC, Dr. Bello, to just give us a quick round, should I say quick wrap on this side of the official launch? Yes.
So thank you very much. It's an honor and privilege to stand here before you at the Lancet Commission, the Lancet launch of the Lancet Commission on Oncology for Sub-Saharan Africa. I also happen to be the immediate past president of the African Organization for Research and Training in Cancer, IOTIC, and over 50% of the commissioners actually are members of IOTIC, and I know that IOTIC has contributed immensely in the development of this document. Professor Isaac Adewale, also a past IOTIC president, was also part of the development of this document. It's a very important document, and we are super proud that we are given the platform to have it launched here in Nigeria. So thank you very much. It's a great honor, and I want to sincerely thank the LOC for creating the platform that this can be launched. So thank you.
Thank you very much. The seriousness with which this is attached to. Again, I'd like to bring to fore and introduce Dr. Nwankwo, and apologize for the way your name was spelled, which made it a little bit difficult getting the pronunciation right. But then we're here together and we'll work together to change the narrative and make it active for the betterment of our society. I hand over the microphone now to Professor, who is going to moderate the next session. I'll be sitting by if he, yes. Professor David had already spoken to us, Colin Ridge, who is the Lancet Oncology Editor-in-Chief, yes. Okay, oh, sure, before we go, it's so important, sorry, if you just allow me to bring this on. Thank you for my oxygen, who is here. I'd like to recognize that we have Dr. Samuel Otene here, Chairman, NMA National Committee on Cancer, who is representing Dr. Uche Roland Ojima, who is the NMA President. You're welcome. Thank you. Yeah, you have.
Thank you very much. So we have two distinguished speakers this morning who are going to take us through the report. And first, to talk about the report in totality, and then our second speaker will talk about the action. So first up is Professor Will Ngwa from Johns Hopkins University in Baltimore and Director of the Global Health Catalyst. Will, over to you. Thank you.
Thank you. Can I put on my slides, please? All right, so no, the other ones, the other slides. Okay, so I'm going to start by giving a little bit of introduction about this Lancet Oncology Commission, and then that'll be followed by some really important highlights as I walk you through the commission report itself. So the commission itself was really created to really inquire into the state of cancer in sub-Saharan Africa. Like I mentioned before, it involved over 50% of the people from Africa. I would say that we really made sure that women, we had at least 50% women in the commission report as well. As you see that one of the findings is that cancer actually kills more women in Africa. It's one of those continents that has the highest death in women, not men. So it was really important to have that. So like Professor David mentioned, the cancer situation in Africa is really an emergency. So if you look at those slides, you'll see that basically due to COVID-19, which has really made things worse, we found out that from this report, the cancer cases are gonna double within the next 10 to 20 years. And actually we're gonna have about 1 million deaths by 2030. So that's in 7 years, which means we really have to do something about that. This picture we got from as a picture of a breast cancer patient. It represents the situation, you know, in Africa where you always have late diagnosis. Okay, and that really means that about 70% of the cases of cancer lead to death, and that has really encouraged the perception that cancer equal to death. Okay, so if you really want to change the narrative, it means that we have to diagnose early. And so that really means that we have to create a lot of education and awareness. I would say that, you know, here in Nigeria, there are a lot of people who are doing that effort for us. A lot of the first ladies are very involved in education and awareness, which I think is really fantastic. And so it's critical that we increase that. Now, in this picture, I want to show you the data on the estimates that we made. What are the leading cancers that create death here? So as you can see, cervical cancer is the top cancer in women. That is followed by breast cancer. While breast cancer has the highest number of incidents, it actually causes less death than cervical cancer, which is totally eliminated. You can eliminate cervical cancer. And then if you're a man, don't get comfortable because most men die of prostate cancer. That's one of the leading cancer causes of cancer death, followed by liver cancer, colorectal cancer, and leukemia. And so, like I mentioned before, you can see that the top cancers are from women, which means that, and we know that women are the engine of Africa's society, which means that we really have to do more here. So we have to fight for our women. This slide basically tells you that cancer is not only a healthcare problem. It is also an economic problem. Okay, so if you look at the slides, this is just representative data of some countries. For Nigeria, you can see that the staggering cost of cancer, this is more than $5 billion per year. If you look at patients living with cancer, their survivor when they die, how much loss is that for the country? It's over $5 billion per year. So if you are thinking about prioritizing action against healthcare, you have to think about cancer. It's really important. So this commission had 8 sections. I want to quickly go over that and just highlight key points. The first one was on registries, data, records, and reporting. So even the cancer cases that we've talked about are underreported because most countries in Africa do not have cancer registries, which means that you can really define a cancer control plan without those accurate results. So what this commission recommends, as you see, Professor Isaac will talk about those recommendations, is that we really need to increase our cancer registry efforts. The second section of the commission talked about prevention, education, and awareness. And I want to highlight some statistics here. So if you actually look at that graph, you will see that you may ask, why is it that cancer is rising in Africa? Why? Why? There are a number of risk factors that this commission talks about. Number one, people are living longer. So as you survive malaria, HIV, AIDS, tuberculosis, and all the other things, cancer becomes, starts to show up. But one factor that, other factors include our diets, like obesity. So I know that in Africa, sometimes we think that, we need to enjoy the Western eating burgers. It's a nice thing, adopting Western lifestyles, but that's actually contributing to the risk factors of cancer. I also want to highlight one thing. So if you look at the data, out of the 2,000 languages in Africa, most of them do not have a word for cancer. If you don't have a word for cancer, it means that you can't even begin to think about how to address it. So that's really important that we create a lot of awareness and education around this. Okay, the third section of the report looked at early diagnosis, screening, and treatment. The map that you see there is one of just shows you the radiotherapy availability across Africa. You can see that all the red means that these are countries where there is no radiation therapy. And so if you think about this conference, the ACON conference, you can think about the fact that in these countries, if you have cancer, you don't have access to treatment because about 70% of cancer cases in Africa are treated with radiation therapy. So that means that we really have to change the trajectory in investing more in treatment and early diagnosis. I also want to show this graph because this is one of the things that the commission found that was really, really striking, which is that there's a lot of treatment abandonment. When you start to treat cancer patients, then suddenly they don't come back. And so this is something that we have to address. We see that especially even for children, pediatric cancers, where in Kenya, over 50% of children who are being treated with cancer don't continue the treatment. So abandonment means that most likely the patients are going to die of the cancer. In Nigeria, breast cancer abandonment is really high for treatment, to treat cancer, for breast cancer. And so this is something that we really have to create a lot of awareness around and try to mitigate as well. The fourth section of the commission looked at palliative care. And when we think about palliative care, people usually think about people who are dying already. So you're just managing their pain. But actually palliative care is something that has to start from the very beginning through the continuum of care. Even when you are going to be cured, things like pain management, making sure that the patient is treated with dignity, that's really, really important. And if you see in these graphs, you see that Nigeria is one of the top countries where they really need more palliative care. You can see the graph. It's one of the longest, tallest one there. So that's something that you really have to create action around. Number 5, the section number 5 covered pediatric oncology, which I think is really heartbreaking if you think about children. So in Africa, let me just tell you an example. If out of every 5 kids who are diagnosed with cancer, 4 of them die in Africa. If you compare that with the United States, just 1 out of 5. Okay, so it really means that our children are suffering, and these are our future. So it really means that we have to change that. And so one of the recommendations really focuses on making sure that pediatric oncology is covered through all the cancer care continuum. In this graph, you actually see that their projection is that by 2050, almost 50% of the global cancer burden will be in children younger than 15 years. And that will be in Africa, right here. Okay, which means that we in Africa will probably be losing a big part of our future if we don't address this with our kids. The sixth section of the report covered research, which is something that we always don't prioritize. It's really important that we do the studies to kind of come up with innovative treatments and approaches to be able to treat, including clinical trials, which I know ACON members are very keen to be part of that. And so if you cannot be part of the research, we cannot be able to develop new technologies or treatments that we can give access to our patients. And so one of the things that the Commission really highlights is that we need to be able to do assessments to see where, and that assessment involves research to see what are our priorities. And then we have to really act on them and invest and add money to research and innovation. The second to the last section of the report covers the workforce, oncology. When I walked in today, I saw the advert that was playing on ACON, and they were saying that there are less than 100 clinical oncologists in Nigeria. Okay, if you think about the population of Nigeria, what is it now? 250. That is really huge underestimate. You really need to train more clinical oncologists. And so that's one of the big problems that we have in Africa, is that the workforce is not developed. And if you don't have the workforce, you cannot, that's part of the healthcare system, you cannot even afford to address this crisis. So that's really important. And then the last part of the commission was focused on the healthcare systems, so universal health coverage. And you can see the triangle, the pyramid that we have there. We think that you really have to engage at the beginning, traditional medicine. I just want to highlight that. The first person that cancer patients go to are usually, and we have to really think about who the primary care person is. It can be your pastor, right? It could be a traditional doctor in the village. It really means that we have to engage this. We know that about over 50% of population in Africa actually use phytomedicines, traditional medicine. Some estimates put it at 80%. So we cannot only focus on conventional medicine. We really have to engage this healthcare system and make sure that, if patients present to these primary care providers, maybe there's an opportunity for them to either refer them to the conventional treatment, or we actually really need to also recognize that maybe we need to do some more research on some of the traditional medicines to kind of scale that, generate some more science around that. And so I think that as we think about the healthcare system, one of the key things that this recommendation, this report highlights is that, and I would say this is Afrocentric. So it's one thing to kind of say, okay, develop commission reports about universal health coverage and things like that. But I think this is one of the areas where this is really Afrocentric. It's something that we really have to do that here in Africa. And then finally, I want to talk about the fact that universal health coverage is really important. In this commission report, we found that there are just few countries in Africa that have that. Rwanda, for example, allows you, if you're a cancer patient, 90% of your costs are paid for. Kenya is doing really good as well. I'm not so sure what the situation here in Nigeria is, but this is something that we really have to take seriously in order to be able to strengthen the healthcare system. So I'd like to end to really just mention that, cancer is killing now in 2021 more than COVID-19 did. Okay, in sub-Saharan Africa, the estimates show that the cancer killed over about 600,000 people in 2021. That was more than how many people died of COVID-19. And so why do I say that? I say that to say that we must put the same kind of urgency that we put into COVID-19 into addressing the cancer crisis in Africa. If we don't do that, then we are really not prioritizing correctly. So I want to end by saying that, the time to act is now, And so we will look at what the calls to action for this commission report are next. Thank you very much for your attention.
Thank you very much, Will, for that very thorough but quick sort of gallop through a very large report. It's a pleasure now to introduce Professor Isaac Adewale, former Minister of Health and co-commissioner of this report, to the stage, who's going to talk to us about the call for action.
It's my distinct pleasure to be here this afternoon. And I want to thank the BOT, the local organizing committee, and the president of VACON for giving us the platform to present the commission report. And as stated by David and Will, there were 54 commissioners and is led by 3, David of Oxford, Will of US, and Beatrice of Ghana. Half of the membership reside in Africa, half are women, and 4 of them are Nigerians. And I want to use this opportunity to thank Honorable Sununu Tanko, who is from Kebbi, Yauri constituency, for the excellent job that he has done in this field. Particularly, Will, I hope you're listening. He has ensured that we have a cancer health fund in Nigeria, which is being piloted in 6 of our tertiary health institutions. And I think at the last count, each cancer patient is being supported with at least 1 million naira to start with for their treatment. Mr. President also signed the National Health Insurance Authority Bill. And that insurance bill guarantees access to all Nigerians for health insurance. And one of the key issues that will be covered is cancer screening, covered by the health insurance. So as we move on, Nigeria actually is on the path to becoming the first country in Africa that will have nationwide screening covered by insurance. And to me, this is good progress, and we need to build on it. In terms of previous speakers have spoken about the cancer challenge in Africa, and that if we do nothing, we are likely to double the cancer mortality. And many of us believe that the actual figures could be higher because we do not have accurate counts of the number of cancer cases that we have in Nigeria and in Africa. What we have are estimates, and many of them are estimates projected from cancer registries that cover only about 2% of the population. So the recount might be higher. And as stated by Will, the cancer explosion is attributable to multiple factors: infection, the HIV. Even though HIV now is under control, the implication is grievous. People will now live longer. And when you live longer, the chances that you develop a cancer rises. cancer actually is related to age. People in my part to the world say you want to get older and age, but you don't want the infirmities that go with age. And you have to pick one. Either you live longer and manage the infirmity, just as I had to manage my climbing up. And Moji needed oxygen to climb the stairs. I think that is the effect of age. But you're managing it well. And then the changing dynamics, behavioral changes, lifestyle. We move from one air-conditioned vehicle to an air-conditioned house, an air-conditioned office, and then the environment, as well as genetics. We've been told about the commission, the methodology, and unfortunately, because of COVID, that's also good for our sponsors. All our meetings were virtual because we couldn't afford to do face-to-face. The commission highlighted case studies, did landscaping, and looked into successful models, including the NSA Luth Cancer Center featured in the document. To me, that's actually a good case of public-private partnership. With about $11 million, Luth has one of the most modern cancer centers you can have in Africa. And then the recommendations, as well as the call for urgent action. I do not want to go through the sections again. This was actually done by Will, 9 sections. Essentially, I'm going to start by offering appreciation. Today, all of us are actually evangelists. We are cancer advocates in Nigeria. We will use advocates rather than call ourselves lobbyists. In US, it is normal to call yourself a lobbyist. In Nigeria, we are advocates. Muji is one of us. We are health advocates and we are evangelists. And today we are preaching more to the converted because we also want to turn the converted also to evangelists. And what we are saying is that, oh, government has done well because we have to start from that premise. Honorable Minister of Finance, you've done well. Honorable Minister of Health, you've done well, but please, you need to do more. And to me, that's the way to get things done. We are not going to start by saying you've not done anything. When you say that, you are not going to get help. So please, whenever you meet them, tell them they're doing well, but that they can do better. And then we need more than political commitment. We need political action. Because people talk about, oh, there must be political will. I think will not do it any longer. Not this will, we're sitting here, but we need political commitment and action. We need to tell people that it is not expenditure. When you put money in health, it's actually an investment and there will be returns. So there will be return on investments, there will be political dividends. People who benefit from this are likely to support you. Honorable Tanko Sununu, I must congratulate you for winning your case today. And one of the reasons why he won is because people identify with what he's been able to do for them in the constituency. So build us a cancer center, put equipment there, the people will support you. And then we need to strengthen the health system. We need to equip, we need to recruit, we need to train, and actually we need to retain and address pathways to reduce miss and late diagnosis. A colleague of mine in WHO Afro said there are 3 characteristics of cancer in Africa. And he said, number 1 is late presentation. He said, number 2 is late presentation. Number 3 is late presentation. We need to change that. And my side is off. And then strategies for work reception. And the objective is actually to emphasize this urgency. Let us do something quickly. And then we are appealing to public officials that matter. We're appealing to executives, legislative bodies, people like Honorable Tanko Sununu and his colleagues, public and private sector organizations like Shell and so on. We're lucky in Nigeria. Shell actually supplied the electron machine in National Hospital, and we can ask them to do more. And then the goal is to reduce by a third premature mortality from NCDs, of which cancer is one of them, through prevention and treatment. And as stated by Will, these are the actions that we will want to see done urgently under the call for action. Number one has to do with precision cancer control plan. Develop and update national cancer control plans and provide sustained financing to ensure their implementation. And we are asking that we should move from cancer control desk to a cancer control unit or an office or a department. A desk is insufficient to manage the challenge that we're likely to face. And then the cancer control plan should have clear goals outlining strategies. And then the metrics will be implementation of the National Cancer Control Plan with plans for M&E. Number two is to improve data acquisition and cancer registration. I would love to see Honorable Tanko Sonono that cancer should become compulsorily registrable so that either cancer as an incidence or cancer as a mortality, let us ensure that they are registered. And then we need to include childhood cancers and monitor progress, and we need more of national cancer registries. And then designing healthcare systems that promote equity of access. This is important. Will spoke about the need to implement universal health coverage and expand universal health coverage, incorporating cancer care into essential benefits packages and national health insurance systems to reduce out-of-pocket expenditure or abandonment. People abandon care, so we don't want that to happen. And then we want countries in sub-Saharan Africa to incorporate cancer care into UHC. Action 4 is to increasing cure and improving care. We need to pilot cancer screening and detection strategies and ensure that we have point of care diagnostics so that allied health professionals and all those who are involved with cancer care can make their diagnosis on the spot. And also shorten the interval between diagnosis and treatment. And the metrics is to decrease the number of patients with late presentation, move them from stage 4 to stages 1 and 2, where we can actually achieve cure. And then effective palliation, as stated by Will, we need to see palliation differently from what we are used to. Palliation has to do with comfort, has to do with relief, has to do with planning, including compassionate disclosure of diagnosis. So palliation is more than just giving painkiller to somebody with a terminal cancer. No, it should start from the beginning. So we need to ensure that we strengthen palliative care units and ensure that they offer services through the entire spectrum, from diagnosis even unto death. And then action 6 is building and maintaining the workforce. We need to recruit, we need to train, we need to retain. And that will include ensuring cooperation, improving conditions of services, paying them mentor, increasing the pool, and reducing the push, which is a tall order, but we must keep on trying. And the metrics will include established cancer training program, oncology training program in each country or across countries. And action 7 is innovation and research. We need to establish National Cancer Research Institute, and I'm happy one is in the making. Honorable Tanko Sonono, I'm sure there is a bill before you on establishing a National Cancer Research Institute. When will that be passed, or has it been passed? Please get it done for us. Then you will have fulfilled action 7. And then action 8 is to identify barriers to implementation and test strategies for adoption, scale up and recommend approaches that can substantially increase access to cancer prevention and treatment, increasing survival. And this will include digital solutions, telehealth, using telephones. In fact, you'll be shocked that almost everybody now has a mobile phone. In Zambia, field workers can actually use their cell phone to take photographs of lesion and send it to the National Cancer Center of Excellence in Lusaka. That actually shortens the time interval between diagnosis and treatment. And so there's a lot that we can do. And we can do teleradiology, we can do teleconferences, you can stay in Nigeria and Currently, the International Gynecological Cancer Society is working on the ECHO program, currently holding in Ibadan and Enugu. And we sit down once a month to look at cancer cases. We share experiences and so on and so forth. So these are things that can actually assist in the implementation of Action 8. I think that is the last. I want to thank you for this opportunity, and hoping that mostly the converted here will become converters and help us to convert other people and ensure that something is done. To do nothing will be criminal, but please do something. And no matter what you do, a little help here will make a huge difference. Thank you so much.
Many thanks, Isaac, for that very nice summary of the call for action. So that brings our session to an end, but I would like to implore, you've all got a copy of that commission in front of you, that report. Please go away, read it, digest the words, but words mean nothing without action. So as we've heard this morning, when you leave here, let's hope we have a room full of evangelists who are going to put those words into action. So thank you very much for your attention. If you'd like to give our two speakers a round of applause. And with that, I'll call this session to an end. Thank you.
Together. Yes, okay. Thank you very much. Those two interventions were very important. Thank you again. And by show of hands in endorsement, let's see all the evangelists that have been converted here this morning by show of hand. Okay. Not very convincing, but oh, very good. Oh, thank you. I actually was targeting Honorable Sununu, and I got what I wanted. As we transit to the next phase of this gathering, which is going to be moderated by both of us. We have been talking, as you, if some of you noticed, we're going to be looking at a very important part of it. That is, we're looking at in terms of actually advancing those highlights that Professor Adewale mentioned too. Those highlights have become an imperative for us to move from this hall and be fulfilled that ACON at 5 has been able to start the right thing that should be done, matching words with action. And so before we go into the main action in terms of bringing that forth, may I, on behalf of all of us, invite the Chair Board of Trustees, Professor Duro Simieti, that has been pushing this I'd like us to welcome him warmly. And he'll just give us a bit of evangelism, the sermon according to Akon. Take it easy, sir. All right. You're welcome, sir.
Yeah. Well, good morning, everyone. May I really thank you for this unique opportunity to put in a short comment on what's going on. I'd like to assure members of the Lancet Oncology Commission on Cancer in Sub-Saharan Africa that we at ACON, we are firmly behind you. We are real evangelists, and we shall also get you more evangelists, as many as you like. We assure you that we shall put in everything within our power to ensure the success of this long-awaited activity. Again, from ACON, apart from promoting early diagnosis or prevention through screening and early diagnosis and early treatment in controlling cancer, we also like to add preempting cancer itself to the beginning of that chain of reaction, so that we know that at the end of it all, when we all work and join hands together, we find that it is not only cheaper, but even better to get cancer early and to treat it so that Nigeria and indeed the whole world could move forward. So once again, welcome to this meeting. And on behalf of ACON, we hope we have a very, very successful deliberation at this meeting today. Thank you very much.
We gradually, if you check your agenda, we are moving on to speaking to the people in government that will give us enough oxygen to continue to evangelize. And it is on this premise, I'd like to call on the Senior Special Assistant to the Honorable Minister of the FCT, Dr. Ejike Oji, who would also lend his voice, and hope that this voice will be loud enough to change the narrative in the Federal Capital Territory.
Please permit me to greet my sister Moji, who've been in trenches for the past 30 years. Good afternoon, ladies and gentlemen. May I offer my respects to all the dignitaries already highlighted in this meeting. I'm Dr. Ejike Oji, the Senior Special Assistant to the FCT Minister on Health and Hospital Management. I would like to tell my story, and I'm sure it's the story of so many people in the hall today. In 1992, I lost my mother to cancer of the breast. Then I was working at the Deutsche Klinik Food Diagnostic in Germany, one of the best diagnostic facilities in Europe. By the time she got there, she was already on stage 4. 10 days later, she died when I brought her home. In 2018, I lost one of my elder sisters too, to cancer. Even though I had told my sisters, 5 of them, you have 25% chance of having cancer of the breast. So please make sure you check every day. Check with your doctors. My sister had a lump and she hid it from everybody for 8 months. By the time we found out, she was on stage 3. We managed to do a lot for her, but she died 5 years later. By then, we had spent more than 12 million naira. So this story, I'm sure, is the story of almost everybody in this room. If I do a cursory, should I say, check-in, I say, can you tell me if you haven't lost anybody to cancer? Raise your hands. I'm sure everybody will not raise his or her hands in this room. So this means cancer advocacy and early detection is the key. Not even treatment, really. A lot can be prevented before it becomes catastrophic. For some of us in public health, we know that the most catastrophic medical expenditure is around cancer. So based on this, the FCT administration, a consortium here in Abuja, started the City Cancer Challenge Initiative. And then they met all these five pillars, except the last one, which is leadership in governments, and then oncology managers. So we actually scored 80/100, but we need 100% to be signed on as a cancer city challenge. When the FCT minister got to know about it, he swung into action. Within 2 weeks, we were able to give the Geneva-based organization that FCT is truly interested in providing that political leadership. He set up a cancer unit within his office. He created a budget line item for cancer to be able to support whatever that is going to come. and then finally, and said, I will be the focal person to drive it. And ladies and gentlemen, that's why I'm in this room today, to tell my own story, and then also to tell you the city of Abuja is more than ready to transform cancer advocacy, diagnostic, and treatments across Nigeria using FCT as a pilot city. So there's good political will. And in this room, I saw my good brother, Dr. Nkwoku Chechukwu, who is the focal person in the non-communicable disease unit at the Federal Ministry of Health. And he's also told me that the Honorable Minister of Health is so sworn to this. So ladies and gentlemen, please pray for us. Abuja is going to be the next city cancer challenge city come October when they will vote. I bring you warm greetings from the Federal Minister of FCT, Honorable Musa Bello, and all the medical team in FCT. Thank you. I'm glad to see my good brother, Professor Adeole. Thank you, sir.
Thank you very much, Dr. Ejike, especially that we have a face to the truism of the prevalence of cancer. I stand here today also having lost my best friends to cancer, having lost my auntie to cancer. And so it becomes a must for us all to stand up to fight cancer together. At this point, I'd like to actually celebrate while I invite him to the microphone, because politicians, like we know, sometimes don't actually do what they say. And you can see I'm picking my words. But I know that as we move forward to 2023, we are going to be asking the politicians. We have platforms that are ready. We'll ask deliberately, what are your plans for health? And you need to come out. And I can say this on behalf of the Nigerian media, that we're going to be tracking and ensuring that those promises that you make at electioneering campaign, which kicks off today in Nigeria, will be that which you will deliver to us. The dividends of democracy must be seen in health. Health must become an investment. And moving forward, when you invest in health, you will have healthy people who can drive the development agenda faster than we are today. So it is on this promise of hope that our politicians would understand the operations and systems of healthcare delivery service and bring in our double jeopardy as a country, having to cope with not just non-communicable still, but communicable diseases and cancers, as well as other things that I would like to invite one that has stood firm with his words. And Professor Adewale had acknowledged him earlier. So with hope in mind, please invite with me the chair of the Health Committee at the House of Representatives, Honorable Comrade Tanko Sununu. Thank you.
The former Minister of Health, my mentor in the professional calling, and also in the politics of Nigerian Medical Association, a past Secretary General of Nigerian Medical Association, also a mentor with whom I've concluded and decided to join politics. It happens when some of the elders of Nigerian Medical Association, as then rounding off Secretary General of Nigerian Medical Association, met me in Wuse Season 4 and requested that I have the potentials to be a politician, being close to the politicians. And I told them that really, I may like to do, but I don't have the resources, and politics requires resources. And I met the minister who promised to support me, and I was supported. And to be frank,
All of you here are witness that Nigerian doctors supported me to become a member of House of Representatives, and I remain grateful for that. I have my shortcomings. I may fail your demand, but please do forgive. I'm growing. When I reach the level of my mentor, I will do better than what I'm doing. Well, actually, I must thank the organizers of this program for inviting me to be here. But I think why we are getting it wrong always is on issue of mobilization of stakeholders. If you mobilize stakeholders, you make them to know their relevance, they will always be here when you invite them. It is sorry to say that at level of executive, level of legislature, the representation for the data we have had for a research that talked about us is really below average. And therefore we need to improve on our mobilization. Actually, for me, it was lately, that conclusion on the venue and where is it happening, how it's going to happen, that came to my notice. This, if we improve, because if we talk to ourselves, we can hardly pass the knowledge. But let them be the majority here, so that the few can talk to them. It makes a lot of impact. Nevertheless, so much has been done to ensure that health is given the desired push it requires. And this may be from the role of our elders. Specifically on cancer, we do know that we have had a lot of effort. Prof has made issue of cancer registry. My committee had to deliberate with a bill on cancer registry in Nigeria. But crisis and misunderstanding between stakeholders vis-a-vis those who are operating in the field and the executive in the ministry will not allow that bill to see the light of the day. And I think there is need for us to go and revisit it and come with a united position so that we can look at the advantages. Because as it is now, what we have currently in the ministry cannot and will not stand to serve this country well. And therefore, we need an effective legislation to do that. We look at it closely. Yes, we have triad that are with us, and we are getting an addition to that. The triad of disease, poverty, and illiteracy. Infectious diseases are so common. And now non-communicable diseases are common, of which cancer is a major that is showing its ugly head, and so many compounding and other factors of increasing age of survival has been mentioned even in the report. So how do you go about it? And then we mentioned also we have Bati. And I think that is the logic. When Her Excellency, the wife of the Kebbi State governor, and also her husband, the governor of Kebbi State, made an advocacy visit to the National Assembly, my office and that of the Senate, on the need to create a cancer fund in our budget as a line. And we look at it closely, and that today we have billions in that fund, and I'm happy that my mentor has mentioned that the utilization has so far started. We have already reached them, and we are going to oversight that fund very soon. And this is very, very vital, and we have gone out this year. We have also tried in our own effort to see how we can improve on research. This we have done through the review of National Health Act 2040, and in that aspect of basic healthcare provision fund, which is at least 1% of consolidated revenue fund. At the 9th Assembly, we ensure of implementation, and in the last budget, we ensured that exactly 1% was given, unlike the previous one. And in our recommendation right now is to ensure that we have at least 2%. And out of the gateway, we have increased and suggested that it should be a gateway for research and documentation, because we believe it's only through research that we can move this country forward. But also, as part of legislative activity, ensure that we have reviewed, that have also been mentioned, to transform the National Health Insurance Scheme to National Health Insurance Authority with all the new recommendations that have so far been assented by Mr. President, making health mandatory for everybody, defining the package of basic health care that each individual Nigerian should demand and should be able to have it. And not only that, increasing the scope of the coverage of national health insurance to increase even the cancer screening and what we have to do. And we are also looking at the possibility, we have not only looking at, we have also suggested so many outlets that partners, that are so many here, can partner with National Health Insurance Scheme. And even you as an individual can walk into National Health Insurance and say that I'm going to take care of screening of 5,000 people. Pay the money, state, decide you want them to apply, it will be your pledge or anywhere. The National Health Insurance Scheme has been empowered to carry that. And I think this is a good way of creating and broadening the partnership between National Health Insurance Authority and other governmental and non-governmental organizations. Tomorrow is yet another day. We are talking about prevention. Prevention must be backed by basic knowledge of how it is acquired, how it is transmitted, how it can be treated, and how you can prevent it. And we thought in our logical way, cancer is a serious burden, as we mentioned, and we need to empower our community with basic knowledge. And therefore, I took it personally upon myself to sponsor a bill for an act to mandate the teaching of skills to prevent the cancer of cervix in breast compulsory in our secondary schools in Nigeria. And I use this opportunity to invite the relevant stakeholders to come and give us support. Yes, I do know that people will say you cannot teach what you don't have. We don't have the capacity. But as ambassadors and combatants that we have so far promised to do, all of us can volunteer to use at least 1 or 2 hours to go to nearby secondary school to teach basic prevention of cancer of cervix, basic prevention of cancer of the breast. This is irrespective of whether you are a male or this. I assure you that a child that is knowledgeable enough to know the symptom, a male child, when he sees a small lump protruding on the breast of the mother, I guess my mommy, I was just told this is part of the sign of cancer. Please, can you go to the hospital and see a doctor? So we cannot underrate the impact of that bill, and I hope you all supported us. Ms. Moji, you have this. I want to challenge you that you can go to my constituency. I assure you, we have succeeded in reducing maternal mortality to the barest level. One of the issues that I noticed as a legislator and also as a physician as gynecology is the issue of type 3 delay that has cost life of so many and which is not supposed to be in a normal setting. If a family can overcome the decision to convince the elders to go to hospital, overcome the difficulty in transporting the patient to the hospital, then we should not present them with delay in making decision to intervene and do that. It's unacceptable and should not be encouraged. And that's why since I came, I made cesarean section in my constituency free of charge. And as today, we have operated over 1,600 women without them paying a penny. And in the last review of the maternal health, it was shown that my constituency that I used to be leading is the least. And findings are that the intervention through constituency project in my constituency has done so much. And as of today, we are going to also scientifically document it. We have already secured the ethical clearance from the Ministry of Health to study the impact of that intervention. And also I have the same intervention in diabetic patient. I've enrolled since I came 486 diabetic patients in my constituency. And so far, so good. They have been trained on early signs, how to get to hospital, how to monitor their blood sugar at home, what to do when they have symptoms. And thank be to God, for, almost 95% of them have been compliant and they are this. So I do believe that it is also right time for us to do. We can do a lot, but we must also come out, shape our head by ourselves. Yes, policy is very vital. You can have all the documents. You can have all the documents. Very beautiful. A simple KIV is enough to left that policy document for more than 5 years before it can be reviewed. And what is the implication? So we have to come in, join the politics, while others are doing the clinical services, we are also promoting the policy. It is the policy that will drive the clinical services. If we allow the clinical services to drive policy, then we cannot go anywhere. We cannot go anywhere. So we must do it ourselves, and we must come out to do it. This grad, I want to assure you that I've seen so much about the report, and there are areas that intervention can be done, and some areas may require legislative actions, which is clear, and Professor has made it clear that we require some legislative. I assure you that I will make myself available to the Commission, to ACON, to IOTIC, to sponsor any bill that we think can promote the document that we have so far launched here. That I will do. Not only that, I want to also call on us to please respect public hearing. This is where policymakers make decisions that are this. We tend to underrate what we are going to see. You see, whether we like it or we don't like it, the view of the chairman of the Lancet Commission on Cancer is not likely to be the view of the governor of Central Bank. It's not. But we need to align, harmonize, so that we can convince the central governor. For example, I'm just using an example, that there is need to take an intervention to cancer care. When you allow him to decide on his own, profit may overshadow the benefit you want to achieve. And therefore, please, I know clinical care is very, very vital. But once there is a bill that has to do with your own profession, that has to do with your own calling, please, as much as possible, give time. Get representatives to be there. Simple statement, your explanation can add a lot of value. You can correct misconceptions and misinterpretations of the aim of that bill by your explanation, and you prevent harm and damage to the society. And that's why public hearing is a very important aspect of lawmaking. With this, I want to thank the organizers of this program, and also please permit me, after my little talk, to please leave so that I can prepare for our public hearing tomorrow. There are a lot of administrative activities toward the public hearing that are lying down in my office, but I thought it is must for me to be here so that I can be part of this success story. And I have no regret, but only that I'm saddened that the time frame given, can we really achieve it? But let us be hopeful. Once there is hope, we progress and we reach our target. Thank you very much.
Thank you very much. Can we please put our hands together one more time? Very important that we have dynamic legislators who would live up to their promise and ensure to create a better life for Nigerians. Yes, one thing he said, which I'd like to be one of our watchword, is that political will do well to move the clinical services forward. And speaking to partnership, I'd like to recognize that we have with us a wonderful woman, Claire Omoshaye for JNCI. Yes, she's been here. I was wondering, and that applause is not loud enough. Yes. And they're, of course, representing what we can do by ourselves to ourselves in the community. Thank you very much, Claire, for all that you do all the time. We also have here from the Nigerian Sovereign Investment Authority, Tolulokpe Adewale, who is the Medical Director and Chief Operating Officer. Thank you very much for being part of us. Thank you. A couple of announcements before we go to the next activity. Well, because the Honorable is leaving, we'll have to do a quick group photograph. He would leave us. He did announce that. We'll do the group photograph. And then we are going to listen to messages. What? Okay, so when he comes to the, when we have the group photograph, I'll just been informed that Honorable would also leave us with a note just before he leaves, or he wants to come over now. Okay, I'll give him a second to do that. And
sorry, I'm coming back. With permission of our Director General Campaign Organization for President-elect, Union of International Cancer Control, Dr. Zainab Bagudu Shinkafi, the chair lady of Kebbi State, I wish to use this medium to please solicit the support of members on Lancet Commission for Cancer and also all other cancer-related institutions to please support our candidate. I've just mentioned one role she has played. She and her husband are responsible for getting us the budget line on cancer fund. And I also believe that we are doing a lot together to ensure that we have a lot of legislation that will back this. Together with OCI Foundation, Medicaid Foundation, and other organizations, we work together to ensure that the bill that we are going to have for public hearing tomorrow comes to being. I think it's in an international gathering like this, it is always good to solicit support. The minister has done wonderful. In October, we are going to receive another world president, or the president of our World Medical Association, which is also his own project that he has delivered. And we do hope, sir, the same October, we are also going to deliver the president-elect of the World International Union International Cancer Control. I thank you very much for also giving me this rare opportunity to come back. And I think we have to showcase Nigeria. We must also have to showcase Africa. And I forgot to extend my appreciation to my class rep, Dr. Jawa, that made the presentation when I came in. He has been a very close friend and also our leader as a class rep for all years we've stayed in medical school. And I wish him happy stay where he is. And I'm happy he's contributing a lot to move oncology, radiological oncology forward in Nigeria. Thank you very much.
yeah, thank you very much. I think, Honorable, you should wait. I think it's even more important that we lend our support to Dr. Zainab Bagudu Shinkafi Bagudu. One, she's a woman, and Professor said to us, Professor Will said to us that the high burden of prevalence of cancer is heavy with women. So when you give a woman to do it, we do it better. I can say that, and we do it the best with the men, of course. So together, we hope that she would emerge, our president at UICC, pushing the agenda of Africa and concerns about cancers forward. We would listen to her after this group photograph because the Honorable has to leave us. So may I invite those of us on the high table on the first row, please, to come up for the group photograph alongside the president, alongside Dr. Ejike Orji, the LOC chairperson. Yes, please. Can we please quickly do one together here? Yeah, quickly. And please come with a copy of the Lancet report. Please come with a copy so we can showcase it for photo ops for members of the Nigerian media. Thank you. You needed oxygen as well. Yes, the oxygen is very needed. Yes. Thank you, Dr. Will. Please. I think I'd like to invite members of the BOT, please, of ARCON to be part of these photo ops, please. Thank you very much.
You are very big or you are very tall, stay behind.
Let us go behind. Let us go behind. Sorry. Go behind.
Oh yeah, yes. You have to come.
Okay, sorry, let me go to the back. No, stay where you are. Stay where you are. It's fine. This together.
Thank you. Thank you. Thank you very much. Thank you very much. We may go back to our seats. I would like us to know that we have with us the President, Africa Radiation Oncology Group, led by Professor Olasande. You are welcome. Thank you very much. Good. At this moment, I'd like to invite the President-elect, I would dare to say, of UICC, Her Excellency, the First Lady of Kebbi State, and of course, the mover in terms of all intervention that is needed for cancer with her Medicaid outreach that she does and have been doing and will continue to do as even president, inshallah. Let me invite to the microphone, she's coming on virtually, Dr. Zainab Bagudu Shinkafi. Please welcome her warmly. Let's give her the spirit of the Nigerian that she can do and she will deliver. Thank you. Dr. Zainab, you have the floor.
A very good afternoon. Thank you for that very warm introduction, Antimoji. It's a pleasure to be speaking to you. I see so many familiar faces and I do feel I feel very bad that I'm not there, actually, not slightly bad. Unfortunately, I have to attend the Pediatric Oncology Congress in Barcelona. So right now I'm speaking in the middle of a meeting. I'd like to congratulate the organizers, as well as all the researchers, advocates, professionals, everybody that has contributed to this Lancet Commission that seeks to define the problems of cancer in sub-Saharan Africa. And also not just stop at defining the problems, but also preferring solutions to how we can overcome the issue and improve cancer control. It's a very, very well-written paper. I've read it from back to front, and I think that even the non-professionals stand to gain a lot. The key thing that we need to do, in my opinion, is to increase advocacy and increase the political will that we need to see from governments across Africa. Yes, we have issues with security, we have funding issues, but if the political class and the government make it a priority, then we will be able to gather more control. To get this better control and to increase awareness, to improve access to treatment, at the bottom of it all, the elephant in the room that we all don't like to talk about is funding. There must be improved funding to cancer. That's the only way we're going to be able to do it, whether it's from partners, other governments, in-house, private sector. We must talk about more collaborations and innovative ways of funding. So to me, this is the crux of the matter, health financing that we need to find a solution to. I'm glad to see people like my son, Dr. Sununu, has been addressing this audience, and the making the money sits with people like him. Once they appropriate it and they agree, then we can create more budget lines and increase funding for cancer control. So thank you so much for the opportunity. I really appreciate it, and I congratulate everybody once again. ACON, Dr. Lashebikon has been splendid, and we would like to see more of these kind of engagements coming from very credible journals like The Lancet in Nigeria, in Africa, in sub-Saharan Africa. And Timoji, thank you for the free campaign. And I hope that all the UICC members in the audience or those that have connections are working hard to ensure that we become, it's not me, I'm not going to be the president-elect, it's going to be an African agenda. For the first time in 85 years, we are seeking to have somebody from Africa lead the UICC. So thank you for the support that I have received from everyone. I appreciate it. Jennifer, Professor Okoye, Claire, I see you all. Thank you so much. God bless.
Thank you very much. And thanks for the commitment. We would wrap up this session. So I'll bring on Professor David Coleridge to please wrap this session up so that we can start at the next session.
Well, thank you very much. And it leaves me the last task really of this session, which is to extend all of our thanks to Her Excellency, the First Lady of Nigeria, all our honorable speakers this morning, the gracious hospitality of ARCON for giving us this platform, and our Madam Chairman, who's done a fantastic job this morning. And I think the best words I can say just to end this session is from the quote on the booklet. We heard it very early on this morning, but as the quote says, we have seen too many words, too many reports, too many good intentions, too many families torn apart, and too many excruciatingly painful deaths to see yet more delays in taking collective action. So the time for action is now. Thank you very much.
Right. Thank you very much. The crux of the matter is what is going to occupy the next session, and it's going to be on health financing, and moderating this appropriately is Dr. Lumide Okunla from the World Bank. May I please invite Dr. Okunla to the microphone? Thank you. And with that bag, okay, I thought you were bringing that bag along to the podium with lots of goodies, I pray. Thank you. All right.
Thank you very much.
Yeah.
Good afternoon, everyone. It's a pleasure to be here to moderate this next panel. And I think a good way to start will be to acknowledge the work that the likes of Minister Adewale, please a round of applause for him, Honorable Tanko Sununu, First Lady of Kebbi. If you're Nigerian and you've lived in Nigeria this past few years and you've seen how the needle has moved on the policy front, then you will indeed agree with me that what they have done to help us in this sector has truly, truly been significant. So perhaps if we summarize a few things that has been said earlier this morning, you know, in fact, the numbers that I have for cancer in Nigeria seems to be a lot more modest from the figures quoted by some of the commissioners from the Lancet Commission. Bottom line is that you got 750,000 new cases every year being diagnosed in the country, a figure that will rise to almost 1.5 million. Half of these people, upon diagnosis, would end up dying. And I think one figure in cancer circles that you probably will be very familiar with is the 580 cancer disequilibrium. In other words, only 5% of all the resources available is for 80% of those who suffer the consequences of cancer. So we have a panel to help unpack this gross inequity. We will go through what we are doing to help ourselves in terms of policy, in terms of financing, in terms of collaboration and partnerships, to how we're also operationalizing this. So the organizers have given me 6 or so excellent individuals to discuss this. This is going to be a very short panel. We're going to be extremely focused. So may I call on Dr. Uche Nwoku from the Federal Ministry of Health, Akaego Nwachukwu David from the FCMB Bank, Kolako Fakunda wearing 2 hats, Roche and Healthcare Federation of Nigeria. There is also Dr. Kofi Abubakar from the NHIS, representing the CEO of the NHIA. I can't see Kolako. I do also have Dr. Fejiro Chinye Nwoko from the Nigeria Solidarity Support Fund. Kolako, can you come with a chair, please? And I have used my own powers as moderator to bring upon someone who I think is very important to join this panel. And that's Dr. Tolu Adewale from the National Sovereign Investment Fund. Is Dr. Fejiro here? Okay, good. So as you can see, this is a very distinguished panel. And where else to start but to also mention that, I like to say this all the time, no country in the world can achieve universal health coverage without public financing. The amount of money a country devotes to its health care determines whether its citizens would access care or not. You probably should not be too surprised that Nigeria spends 0.6% equivalent of its GDP on healthcare. Considering the size of the country, this is about the lowest in the world. You cannot get what you do not have. Nigeria is spending too little. And that's why my first question or reflection will be to the Federal Ministry of Health. First place to take off is public financing. Nigeria is not giving enough attention to cancer care. by way of the amount of financing available. What are the steps being taken to address this? Dr. Uche. I think that works. Yeah. Okay. Excuse me, please. It will be appreciated if there's a lot of noise coming from the back. Thank you.
Thank you, Olumide, and good afternoon, everyone. I think it's nice to be here and to share with us what the government of Nigeria is doing as far as healthcare financing is concerned with respect to cancer control in Nigeria. I'm going to start by saying thanks to those who also championed what we call the Cancer Health Fund in Nigeria, which Olumide here, also one of those who actually led the fight. And then the health chair on healthcare services who just stepped out. Nigeria, with the help of partners, started what we call the Cancer Health Fund, realizing the fact that cancer care is very expensive and an average Nigerian can't afford to provide care for himself. And also given the fact that there are other healthcare initiatives, other private sector driven initiatives being championed in the oncology space. Unfortunately, majority of our cancer patients pay out of pocket, okay, which is very damning. So in other words, most patients, when they're diagnosed of cancer, just think that the death sentence because they can't afford to pay for their services. So that is how government initiated what they call Cancer Health Fund. And we thank the government for also having sustained this budget line in the last 2 years. And today, the fund is up and running. It's being piloted in some hospitals, about 6 of them. And over 1,000 patients have been enrolled in the have successfully registered to participate in the fund.
Okay.
Yes, so
perhaps you also want to take a step back to tell us some of the salient features in the
operation
cancer prevention policy.
Now,
of the government. Yeah.
Yeah. So this is also the Cancer Health Fund is a fallout of the 5-year National Cancer Control Plan being implemented by the government, 2018 to 2022, and the plan is actually expiring this year and is already being reviewed. And government also took steps to identify priority areas of action, which include prevention, diagnosis, treatment, data management, supply chain management, governance and finance. So
Okay.
this health fund came from this priority area of action of that plan.
Okay.
Yes.
Thank you very much. I'll just move very quickly to the representative of the CEO, National Health Insurance Authority, a very valuable member of this panel. And I say valuable because, like many speakers before me have said, now Nigeria has a law that makes health insurance mandatory. But what does that mean for the average Nigerian? It means that if you cannot pay those insurance premiums from your pocket, somebody will cover you. And Nigeria has a number of funding streams to take care of that. One is the Basic Healthcare Provision Fund. The second is a Vulnerable Group Fund, which is a key provision in the NHIA Act. So, Dr. Kofi, my question to you is this. Nigeria has a benefit package, first, defined in the National Health Act, the basic minimum package of health services, Section 3.3 of the National Health Act. You have the benefit package defined by the NHIA, currently operational. Cancer care and prevention is very thin on those packages. What does the NHIA, or how does the NHIA see this?
Okay, thank you very much, Olumide. First of all, let me reinforce one very important variable that has been mentioned here, and that is the fact that we have all agreed to the fact that the most sustainable way of financing healthcare is through a health insurance. The second variable that have also been clearly enunciated here is the massive reforms that are happening in the health sector in Nigeria. This is a patriotic moment for Nigeria, I have to say, because a lot of legislations have been rolled out that have clearly spelled out how Nigeria intends to achieve universal health coverage. And the National Health Act is there. Also the revised NHIA Act that you are mentioning, which was signed by the president a few months ago, is a classical demonstration of how this country wants to move towards UHC. The act has clearly spelled out the role of the NHIA, the mandatoriness of health insurance, as well as the vulnerable group fund. Now, not only has the act spelled out that this vulnerable group fund is a fund that is going to cover vulnerable Nigerians, who majority of them actually are the people that we're talking about today. Because from the presentation made by on the commission, I saw that vulnerable individuals actually form part of majority of people who suffer from this cancer care and who actually suffer the morbidity and the mortality. Now, the act also intends to harmonize the various packages of services that are provided at all levels. I think let's not even discount the state social health insurance agencies who are doing fantastic work covering state citizens in all the 37 states. As at yesterday, when I looked at the data, over 7 million Nigerians have been covered across all the various states of the country. So this is happening in less than 2 to 3 years that the state health insurance have been rolled out. So an opportunity is happening in the health insurance space to really cover Nigerians with health insurance. Now, the benefit package that we have, as you know, benefit package is a promise. If you say this is a package, it means you must have the resources to cover those services. So in the NHIA, I know, as the Professor Adeole has said, we have made efforts to cover some key services, preventive services in the benefit package, for healthcare services. But more importantly, where we do not have the resources to cover those services, the NHIA has gone ahead to involve the private sector into the equation. And I'm happy Roach is here with us. The NHIA has developed what is called the NHIA Medicine Supply Initiative and gone into partnership with the private sector to cover cancer patients on 50, 30, 20 basis. So Roach writes off the 50% of the cost. NHIA pays 30% of the cost and the patient pays 20% out of pocket. So this kind of private sector innovations are what we are looking for. And this is a currently ongoing program across 7 selected sites in the country. And the first patient has already gotten his care in Enugu in I think in August. Roach will shed more light on this. So yes, NHIS is thinking outside the box to see how we can expand the benefit package to cover people within the limited resources available at our disposal. Thank you. Yeah.
I'm not sure. Well, okay. So, but I'll still stay with you, Dr. Kofi. So you mentioned that Nigeria has adopted health insurance as the main instrument for health finance reform.
Yeah.
But at the same time, you have a country that is still channeling funds through the traditional health system. So you're still allocating monies to teaching hospitals. You're still allocating money to hospitals rather than buy a package of service. Is this a sort of frustration for policymakers on the health insurance front? So because you have a lot of passive purchasing happening rather than strategic purchasing that you have just.
I think what I need to say is that we have all agreed that our own healthcare system needs some form of re-engineering. And this re-engineering needs to be gradual, and not that drastic per se. There are challenges, of course, with the payment systems and the financing systems that we follow, but I'm happy to say we are moving gradually towards a step where we can actually correct these things. The appeal I will make is let there be more synergy, more collaboration and more working together so that we can all collectively design a system that's best fit for Nigeria.
Thank you, Dr. Kofi. It's important for stakeholders to understand this particular conversation. one of the key action in the commission's report is let's move towards universal health coverage through health insurance. Universal health coverage can be achieved through even the Ministry of Health traditional approach. But if a country has decided, I want to use the insurance as my purchasing framework, then you need to do it. Right now, less than 10% of funding in Nigeria, as little as it is channeled through the health insurance mechanism. And until we do that, our people will not get care. A second key point I really would like to emphasize, unfortunately, Honorable Sununu has left. Nigeria has introduced taxes on sugar sweetened beverages. It is very low. There's enough headroom to increase those taxes, but it also provides for additional financing to come from the health sector. So as we move on with this panel, Dr. Kofi had mentioned the kind of public-private collaboration that necessarily needs to happen. And I think one example that Nigeria can really point out is what the Nigeria Sovereign Investment Fund has done at the Lagos University Teaching Hospital. And Dr. Adewale, what has that experience been in addressing the supply side of the equation? As at the time the NSIA Luz project came online, there were less than 2 working radiotherapy facilities in a country of over 200 million people. What are your reflections?
Thank you. Thank you so much, Olumide. And I'll just speak. Please, can you hear me?
Yes.
Okay. So at the NSIA, basically, we make interventional investments, meaning that we expect commercial returns on every investment we make. The role we play is basically to catalyze and to stimulate the industry or a sector. And that is what has happened with the NSIA Lute Cancer Center. And I tell people, when you make supply available, one of the things of it is that you're going to create demand. So we made the supply available, and what we've done is that we've created demand. And the demand that has happened right now is, and I'll tell you in 2 different terms, both in financial and in impact. Between June 2019 and August 2022, the center has attended to about close to 7,000 individual unique patients. January this year, we're going to write a letter to the president to update on what we've done so far. And we did a little analysis to say, look, this patient, as of then, we have treated about 5,000 patients. And what we saw was that if they were to go to Ghana, what would they have cost? Or if they were to go to India, what would they have cost? Just the cost of treatment alone. And we saw that for that time, it would have been $100 million that would have had to leave the CBN. Imagine what the pressure of additional $100 million demand will have done on the Naira. So looking at impact on the financial side, maybe by now we'll be talking about dollar being 900 or whatever it is. But the other side of it is that how many of them will have been able to go to pay $8,000? So there will have been increased mortality. And because of the demonstration of what we have seen, when we put our money where our mouth is, today, I think there are about 7 or 8 functional linear accelerators in the country. And the center is still full. In Lagos alone, there's another center, which is called the Maserut Cancer Center. And people were telling us that they said, no, we've not even scratched the surface, because there are people who are here who need care. We charge about, at the center, we charge about 30% of what it will cost to go to Ghana. And we deliver superior and excellent service because we've gone there, we've looked around. And this is what we are saying. And what we've seen, there is another Asilpo that is up. Maiduguri is coming on stream. Sokoto is coming on stream. We have been able to create that nexus to let people know that there is actually demand, and people have paid out of pocket. So, but the thing I will say is this: it takes an average of 2 months between diagnosis and for people to go and raise the cash to come back for treatment.
Okay, so just to, and I'd like the audience to really do appreciate the way this conversation is structured. So, and that's why we have the NHIA on the demand side, guaranteeing that there's a basic package of services which is inclusive of oncology services, both preventative measures and treatment. But then if you reassure that on the demand side, this person is covered, irrespective of ability to pay, is there capability and availability on the supply side of the needed treatment? And I think what Dr. Adewale has shown is that NSIA has been able to leverage its resources to demonstrate what is feasible in that end. And that's even mostly from the equipment and facility perspective. I'll then move on to on the chemotherapy side of things. Again, Dr. Kofi had explained the kind of collaboration that happens with a pharmaceutical organization like Roche. Kolako, can you do a deep dive into that relationship with NHIA? Are you doing it because of return? Are you doing it because of a corporate goal? Because otherwise we want people in this room, pharmaceutical organizations who are involved in this sector, to do almost the same thing that Dr. Kofi has described.
Thank you very much. I think, so my being here today is not just to represent Roche, but really I represent the Healthcare Federation of Nigeria, representing the private healthcare sector. And for me, I think what we're doing with the NHIA as Roche is not really for business. It's more about creating access for patients and impacting lives. And like you rightly mentioned, when you were asking Dr. Kofi questions, it's about how do we drive strategic purchasing of healthcare services. And I'd like to refer to something in this report that says that in 2020, Nigeria established a cancer health fund to assist patients on low incomes in paying for cancer care. It has the ultimate goal to be incorporated into the National Health Insurance Scheme. So I think looking at the efforts that the private sector is already making, Roche inclusive, it's about changing the dynamics and changing how the healthcare system in Nigeria is currently managed. If we continue to run the way we have run for the past decades, and we expect changes and new things to happen, we will just be deceiving ourselves.
And
we
can you
need
also
to
tell
make some
me
changes.
The role of HFN in the CHF?
So the HFN, we advocated, right, as private sector advocated for the creation of the Cancer Health Fund. And we cannot speak about the Cancer Health Fund without recognizing two senators. One is Senator Teju Osho. The second is Senator Olori Egbe. And then we have Honorable Sununu, who also made strong inputs into the Cancer Health Fund. When the journey started way back in 2017, it took a lot of work, a lot of effort, a lot of investment from the private sector. Somebody had to pay for the business case on the Cancer Health Fund. There has to be a design on that CHF. There had to be a design governance model. And all of this was driven by the private sector, which was led, of course, by the Healthcare Federation of Nigeria, who created the platform for everyone to come together. And the idea really behind the Cancer Health Fund was to try and see if we can pilot something, a new way of thinking, a new way of purchasing healthcare services. And we looked at cancer care. It has been mentioned by stakeholders earlier that it is a catastrophic expenditure. So we know that people are really unable to pay out of pocket for cancer care.
Okay.
Now, so we wanted to see, are we able to drive strategic purchasing for cancer services and also attract private sector funding into that pool?
Indeed, that was the original thinking behind the Cancer Health Fund. Let me recognize Claire Omashaye, who was President, Healthcare Federation of Nigeria at that time. Please, Claire, a round of applause for her. And also Professor Duro Simieti, who was the President of SARE Fund at the meeting where the Cancer Health Fund was actually initiated and designed. Thank you very much, sir. So may I quickly then go to Mrs. Akego Nwachukwu. So NHIA is saying on the demand side, I will aggregate people, we will pay for their premiums. Those who cannot afford to pay will be covered. On the supply side, you have the likes of NSIA and a number of facilities that are already coming up, able to deliver the services. But someone needs to fund some of those investments. Not everybody has access to cheap cash like NSIA. And you spent almost 4 hours here. I've been looking at you. And in this room, there are quite a number of doctors who are entrepreneurial. They don't want to leave. And someone pulls you aside, can I have a minute with you? And gives you a business case with what you have had here today. I don't want to call them out, but I know people I've met here. They're going to give a business case. Can you fund me? Yes or no?
Yes.
Okay.
Let me start by saying thank you for inviting FCMB, my bank and I, to this forum. I will just give an example. I've listened to most of our presenters talk, and I'm not a doctor. I only talk numbers. That's all I know how to do. Okay, so I'll say this. I will give an example of probably most of us that live in Abuja know this hospital. The name of the hospital is Kelina, Dr. Ukelina. The bank have supported this laser surgical machine. We actually purchased that this year. So I'm not talking about maybe 2 years ago or 10 years ago. He has opened another center in Lagos, in Adeola.
But what are the things
Adeoku
you want? What do you want them to give you?
Let me be done.
Okay.
What I need, what we actually financed him for was equipment leasing. We use those equipment as collateral. So I'm not asking you to get me some other form of collateral. I'm asking you to, we'll get you an equipment, make sure it's running, and we'll recover our money with the services that equipment will render. It's easy, it's flexible, because this particular one I'm talking about is for 10 years with a 1-year moratorium. What it means is that for 1 year, you're not paying for principal, you're just servicing your interest. So it's just an example. We financed, I heard Dr. Adeola talking about, what was it called? Linear acceleration centers, right?
Yeah.
Okay, we are financing another entrepreneur to do a PPP with University of Nigeria Teaching Hospital in Enugu. The cost of they are upgrading the radiotherapy center in UNTH. So we are financing them to buy a linear accelerator and run that center on a PPP arrangement. So
thank you.
That's FCMB.
Thank you very much. So let's just go back to the numbers that have been shared. So in other words, if we say we're having almost less than just under 1 million new cases that means the numbers are there. It means that business, sadly, makes sense from the financial perspective. But what we care about is, what about those who are unable to pay the $8,000 that Dr. Adewale has said? And that's where NHIA comes in. And the government of Nigeria has signed a law that I will pay for services. So it seems that the dynamics seems to be favorable for you to support entrepreneurs there. And that should provide support for our citizens. Thank you. So I believe that as the CEO of the Nigerian Solidarity Support Fund, do you also play on the infrastructure supply side of the equation or on the demand side?
The demand side.
Oh, great. So can you just give us an insight into how you work?
Okay, great. Good morning, everyone, and apologies for coming in late. So the Nigeria Solidarity Support Fund is a fund organization, an independent, non-governmental organization that mobilizes funds from different partners and donors, indigenous mostly, to support the work, the health system strengthening work in Nigeria. We do that by, in the spirit of additionality, adding to what is done by the government agencies. And our focus is a universal health coverage, by which we promote health for all. And so our advocacy or our fund is geared towards providing access to quality healthcare and quality medicines and vaccines for all Nigeria, with special focus on vulnerable. So by the vulnerable will mean that people who are not able to pay for care. So that's what we do as NSSF.
Okay, thank you very much. Before we close this panel, Dr. Oche, there's a big policy question, big policy question. So we have cancer patients who are not getting enough pain relief drugs. And this is a policy issue. Rightly so, because of the laws and restrictions that are used to address substance abuse control. What's the federal ministry doing about this?
Yeah, thank you, Olumide. I think that's an area the government has also taken critical steps to address. I remember about 5 to 10 years ago, an issue of access to morphine and other pain relief medicines. But today, Nigeria has developed a policy document on palliative care, which has to make it compulsory for health workers to have access. And on the cancer control program, we also partner with other drug manufacturers to make access to cancer treatment. Now we're integrating access to pain management into that particular program. The American Cancer Society is supporting Nigeria to have access to morphine. So that policy has been addressed. And as we speak, we're integrating the two programs to ensure that while patients have access to treat cancer medicines, they have access to pain management as well.
Okay, I would suggest this is an area you probably work with the HFN in terms of getting the necessary regulatory authorities to probably relax some of the restrictions and put in the necessary controls to ensure that those who need it get it.
Yeah, so as part of that program, we also working with other government agencies who also have regulation on all of this, including NAFDAC. Okay. As a matter of fact, so for all the drug manufacturers who are on the program, we request NAFDAC to give them import permits, so they have access to bring in the product as long as they meet the required standard. Okay, so HFN is also a critical partner in what we do, and we collaborate with them too.
Thank you very much. Dr. Kofi, last question for you. So the only way we can guarantee that patients have drugs is through, a policy, and that could be the use of essential medicines list. You have the higher up the WHO essential medicine list, and for you as a strategic purchaser with the weight and also to determine what the guidelines and SOPs are. What's the direction of travel into developing guidelines and SOPs, which also focuses on low branded generics to make sure that people are able to access care beyond what you're doing with Roche?
Okay, thank you very much. This is a very important question. And the discussions with Roche is just one component of the broader NHIS medicine supply initiative, as we call it. The NHI medicine supply initiative is a reform among the series of reforms that are currently ongoing in the NHIS. This is meant to ensure that we pull in private sector players, pharmaceutical manufacturers to come together and locally manufacture NHIA branded drugs. The thinking here, I'm not an economist, that if we have an economy, because of economy of scale, we can be able to bring down cost of services provided, and then we will leverage on the existing drug supply system in the country and working together with other stakeholders that are in the drug space to push these drugs down our NHIA accredited healthcare facilities. Now, this also includes the BHCPF accredited healthcare facilities, and the state social health insurance agencies are part and parcel of this process. So you can see the quantum of services that this will happen. So this will end in the short and the long term, bring down the cost of services. But the most important is to ensure that we can guarantee quality of drugs that are going to be provided in this initiative. Let me just lastly say that there is no better moment to collaborate with the NHIA than now, because under the leadership of the NHIS, a lot of reforms are currently ongoing. And we are also thinking of organizing a national health insurance summit that will bring in all players in the health sector and even outside the health sector and health sector related stakeholders to really showcase these reforms and appreciate the president for his assent to the NHIA Act, which I feel, my own opinion, is actually a life-changing legislation that will really guarantee the healthcare of all Nigerians. Thank you.
Thank you, Dr. Kofi. Yeah. I share your sentiments, but as I said earlier, until Nigeria decides to pick one of the pathways, beautiful, yeah. You have a pathway where we send money to hospitals. We don't know what is being done there, yeah. Rather than send it through you, where we know that we know the beneficiary and we know the package that they are benefiting from. And just to also add that Nigeria needs to begin to take advantage of even new initiatives like TRIPS, the trade-related aspect of intellectual property, that would actually make some of those proprietary drugs available for Nigeria. That's true. Dr. Adewale, last question for you. You have that model where you directly invest. Are you able to partner with someone to say, look, I'm going to buy 1,000 breast cancer treatments from a private provider, 20,000 cervical cancer treatments, just a new model, thinking out of the box way, rather than you doing this on your own?
So thank you so much. So number one, we are expected to make commercial returns. So we do not sit on the demand side of the equation. We sit on the supply side to ensure there is adequate supply. We are collaborating and speaking to different foundations, like the Dangote Foundation, on how they can procure outcomes. And I think that is the way, the direction the NHIA area should go. It should be procuring outcomes. Even the Federal Ministry of Health should be procuring outcomes instead of investing in infrastructure. The people that can in the private sector, funds, DFIs, can do the investment in the infrastructure. The procurement of outcomes, which is what will change the entire dynamics of the healthcare. It will liberalize healthcare. I have 10 billion for the budget in 2023. Use it to procure outcomes at an agreed rate from the teaching hospitals. You will see what the productivity will be like from primary healthcare up to the tertiary and even to the private sector. In Turkey, I was in Turkey in June with Claire and a few other people. And in Turkey today, if you have cancer, irrespective of whether you have insurance or not, the government pays. The government procures outcome. And what has happened? There's been proliferation. The private sector has invested in that place and ensure that there is service liberalization and people get better outcomes. Today, Turkey has one of the best.
Thank you very much, Dr. Adiwa. The point well made. Kolanko Fakunda, is the private sector happy with the current policy environment? From an HFN perspective.
So from an HFN perspective, our responsibility is to continue to advocate for improvements in policy and policy reforms. We know that Nigeria has very fantastic policy documents, but with the implementation of these documents is where we have a challenge. And I'd also like to use this opportunity to lend my voice to what Dr. Adewale just said. That was the crux of the design of the Cancer Health Fund, to see how do we change the operations of the healthcare system from the government procuring equipment, rather using your money to buy outcomes, strategically purchase services and allow the private sector drive that investment, like the PPPs that we have here and there. Those will really, really change the cancer ecosystem and help us strengthen that health system that we need in Nigeria.
Thank you very much. This is AKGO, FCMB, last word, because you're going to get a lot of requests as soon as you leave this stage. Yes.
Okay, on behalf of FCMB, my bank and I only say that we are here to support healthcare. We have a lot of intervention funds coming from the government to support healthcare. So what we do is just to be a bridge between government and the people. So we are here to serve you. Thank you.
Hold on. Do you still have the concessionary financing, RSSF, and a few other concessionary financing for healthcare from CBN with you?
Yes, absolutely.
How many healthcare loans did you give under the RSSF? These are loans these are single-digit loans. Is it still available?
It is. It's so okay. There's so many of them because it ranges from 500,000 to 5 billion. So you can't even.
You know why I'm asking you this? You're my most important guest on this panel. You know why? See all of these brilliant physicians, surgeons, they have applied to go to Saudi Arabia, the UK, the US. They're leaving if we don't keep them. And one of the ways to keep them is to make this kind of things available. That is the way we can keep them here. So I'm happy to hear you say this.
That's why I used a cottage hospital as an example. It's available.
But these are super specialists, but no problem.
Okay.
Madam, NSSF, last word from you.
Prior to now, donor aid, especially foreign donor aid, has driven health investments in Nigeria. And that has skewed the purchase or the focus or the intervention to disease area that is identified by the donor countries or the donor agencies. We need to move to Nigeria donating to Nigerians. And that's where we would be able to focus on what is important to us versus what is important in the global stage. I will say this, that we also need to move from unilateral interventions to more systemic interventions, because we know that even to the prevention of cancer, there are infections that lead to cancer. There are nutritional issues that lead to cancer. And if we promote general primary health care, we will be able to prevent a good percentage of cancers from actually materializing. So I would say that the development space as a fund, we need to be able to fund ourselves and rely more on Nigerian funding so that we can prioritize our own healthcare needs, and the focus should be more broad system health strengthening. And that's why we're very passionate about the health insurance, because that provides a platform for everyone to get both preventive health and curative health. Thank you.
Thank you very much. So, ladies and gentlemen, we started this panel by emphasizing, and I would like to reiterate, no country in the world has achieved universal health coverage without spending its own money. Two indicators that you will know: how much public financing when you compare to GDP, 0.6, very low. How much money is allotted to health within general government expenditures, between 4 to 5%, very low. Compare that to the Abuja declaration of 15%. But yes, government could say, look, we don't have enough money. There's no fiscal space for that money. And that's why you also need to be involved in that discussion for fiscal space. How? Number one, let's advocate for pro-health taxes, tobacco, alcohol, sugar-sweetened beverages. It's good that it's been introduced, but there's enough headroom for government to even get more. And the second part of that equation is it needs to be earmarked for health. Philippines have done this and they've used it to achieve universal health coverage. But then it's not just enough asking for more money for the health sector. We need to be strategic and efficient in the way we use that money. And that's why the reform around health insurance is very important. Why? You define the benefit package. How much does it cost? And who is it that is going to benefit? So you can tie the package to the beneficiary, unlike the current arrangement where 80% of money is simply dumped on hospitals. They go on strike. We don't know who they treat. People even pay from pocket. So we need to bring all of this together. And we've so much heard how the private sector in different ways can help provide care. We see the NSIA model. We've heard of the contracting for outcomes model. Ladies and gentlemen, I think we are in a unique opportunity to move this policy agenda forward. And I think all of this, in one way or the other, has been captured in the Lancet Commission report. Thank you, ladies and gentlemen. I appreciate it. Thank you. Sorry for
the photographer should please approach the panel. We'd like to have picture. President, Chairman BOT, please, you can join us, sir. Official photographer, please, where are you? LOC. Official photographer, where are you? Where is the photographer? No, man.
Thank you. Thank you very much. Thank you. Yeah. Okay. All right, we'll continue with the next session quickly. And let's please appreciate this last session, which is very crucial to the dreams and aspirations of getting patients and, of course, the community well informed of moving forward in terms of attaining universal health coverage, including with cancers. Now, I'd like to invite the president, BVGA, our own Jennifer Dent, who is going to moderate the next session, to come over to the microphone. Can we please welcome her very, very warmly? Thank you.
Okay, good afternoon. It's just been a fantastic morning and session. I want to start by just congratulating Dr. Lasabikian of Archon, Dr. Bello for organizing this Archon meeting, which is obviously very impressive and brought together fantastic group of oncology leaders in Nigeria. And also Dr. David Collingridge, Dr. Will Ngwa for bringing the Lancet Commission finally to Nigeria. I think Nigeria should have been first to host because I don't think you can be anywhere on the continent without starting in Nigeria. But I'm very excited to be here today to close out the Lancet Commission event with the private sector. I'd like to ask our technical team to please pull up the video by Michelle Irwi from Takeda. We also have two panelists, two international leaders in cancer from industry that will be joining us, Jessica Purcell from Takeda and Josette Gamudu representing Merck. So if you could pull up those two participants who are currently on the Zoom, that would be terrific. And I'd like to call the other panelists. You know who you are, Aiki, Hamid, Ansu, Claire. Let's bring up all of the panelists that are here with us. We've got just a fantastic group. And just briefly, I just want to introduce BioVentures for Global Health, the organization that I represent that has been working in Nigeria in the infectious disease space for many, many years, and also in the oncology, in the cancer space, since for about 7 years now, when we launched our African Access Initiative program. And the African Access Initiative is focused on bringing the private sector and different sectors together to improve cancer patient outcomes. And I loved what Dr. Tolu said in the last session, let's invest in procuring patient outcomes because patients can advocate and influence government leaders and change policy. So I want to jump into our session now. And if we have the video, we have a short introduction from the head of Global Access to Medicines from Takeda Pharmaceuticals headquarters in Singapore, Michelle Irwi. If we have that video, we will just start with a short introduction from Michelle. But I'll start by introducing our panelists that are here with us today, all representing really critical companies in the fight against cancer in Nigeria and across sub-Saharan Africa. And I just want to highlight
the Against Cancer Initiative. I'd like to extend.
Wrong video. I'd also like to thank Her Excellency, Dr. Zainab Bagudu, for championing the cause of cancer and engaging across sectors as well. I'd like to, maybe I'll start from the far end. I think probably everyone in this room knows Ladi Hamid, who's the GM of Nigeria, the General Manager of Nigeria, a champion in cancer care and an important leader with Roche Pharmaceuticals. Next to Hamid is Aiki Ufuani, who's representing, I mean, we're seeing Janssen Oncology, pretty high level here, who's representing Johnson & Johnson companies. Aiki is the head of government affairs and public policy at Johnson & Johnson, and he covers West Africa. Next to Aiki, we've got Claire Omasii, who represents, you can see JNCI over here, and also representing Electa. Again, we heard about the critical importance of radiation oncology and treatment, and Claire represents Electa here. We also have Ansu Dukare who is the managing director of radiation oncology for Varian, covering East Africa, including Nigeria and Ghana. So welcome to the panelists and the private sector leaders on the stage. So we also have Michelle Irwi, as I mentioned. Do we have the video? Michelle Irwi from Takeda. We did talk about it earlier, and you gentlemen did have the video from Michelle, who's based in Singapore. Here's Michelle.
Takeda's flagship blueprint for innovative healthcare access is based on a simple but powerful insight. A medicine is only as good as the system that delivers it. It's not enough to produce life-saving treatments and vaccines. We need to ensure they reach those who need them most. And to do this, we need to address local barriers to access. For this reason, Takeda partners with external NGOs on programs to provide local solutions that address local needs. Takeda's partnership with BioVentures for Global Health is one such program. Working together, our aim is to improve outcomes for people living with cancer in Nigeria by identifying and addressing barriers to access across the country's healthcare system. We achieve this by considering the patient's holistic journey, from disease prevention to screening, diagnosis, treatment, through to ongoing patient support, to pinpoint where there are barriers that prevent people from getting the care they need. Importantly, we do this by bringing together a host of additional partners who have the knowledge, skills, and in-country expertise to develop sustainable solutions and build much-needed capacity. Since 2021, Takeda and BioVentures Global Health's partnership in Nigeria have trained more than 1,100 healthcare professionals. What's more, through our partnership with BioVentures Global Health, we are also empowering regional NGOs to raise awareness through patient materials and radio announcements, which have already reached approximately 16% of the population. Furthermore, over the past few years, across sub-Saharan Africa, Takeda's collaboration blueprint programs have resulted in more than 240,000 health screenings and more than 26,000 patients being referred to care. There is always more we can do. That's why I am encouraged to see the Lancet Oncology Commission's call to action to tackle the growing cancer crisis in sub-Saharan Africa. Takeda is actively involved in mobilizing access in several areas, from helping to design for more inclusive healthcare systems, working to improve screening and care, building capacity, and prioritizing additional innovation and research. At Takeda, patients are at the center of everything we do. We are incredibly grateful for the deep collaboration and lasting commitments of our partners. Together, we are creating customized regional programs that apply a holistic and African-determined approach that move us closer to greater access, equity, and inclusion. Through our partnership with BioVentures for Global Health and the Blueprint for Innovative Healthcare Access programs, Takeda is committed to improving both medicines and the systems that deliver it.
So thank you to Michelle. Takeda is one of our partners, as you heard, and they are actually planning, they're expanding their footprint across sub-Saharan Africa, and they're very focused on doing more here in Nigeria. So you'll be hearing more and seeing more from Takeda. And I'd like to start at the far end. Hamid, as all of you know, I think Roche has been a very active company in Nigeria. And I can say I know firsthand that the CEO of Roche, Severin Schwan, visited Nigeria several years ago with Hamid, and you can't get a much higher commitment than that as one of the large companies. So Hamid, I'm wondering if you could tell us about some of Roche's current activities in Nigeria that align with and support achieving the 8 objectives or calls to action coming out of this Lancet Commission report?
Thank you very much. I hope you can hear me. And thank you for acknowledging the work we have done and presence in Nigeria for the past couple of years. Roche has been in Nigeria for about more than 10 years and working with a lot of the stakeholders here. I think firstly, one should acknowledge the work done by the Lancet Commission. Very detailed, very granular. It brings back to me a lot of the experiences we had when we work in hospitals about the challenges you see of data capturing, not having adequate data. And that is something we need to double click on. If we don't have data today, how do we then decide to plan for the next 5-10 years? Talking about Roche activities in Nigeria, I think our partnership today is mainly with the Federal Ministry of Health. And one thing we have done is work with them in creating the Cancer Control Plan 2018 to 2022, which has expired. And we are now reviewing the current Cancer Control Plan. And we're extremely passionate about implementing that plan. We've already gone ahead to do 1 or 2 things, also with the Federal Ministry of Health, and I'll share those examples now. One is with Ventana machine placement. Ventana is for immunohistochemistry testing. We have tried this in the past. We're working with the Ministry of Health to look at how do we place this in key hospitals to ensure that proper histopathologic diagnosis and immunohistochemistry is done so that cancer patients get accurate diagnosis before treatment occurs. I think another key example of what we are trying to do also with the ministry is ensure that we have MDTs appropriately in place before diagnosis, treatment plans, and treatment is commenced for patients. Today, we don't have excellence in one person, it's in the teams that work to care for the patients. And I think if we do this type of things, then the outcomes for the patients that we all desire will significantly get better. I think those are 2 key activities we've already jump-started and we're already doing today with the ministries. Yeah.
Thank you, Hamid. And I'm glad you brought up the importance of the Ventana machine and IHC, because we heard yesterday from the chief medical directors and from the representatives that accurate, proper diagnosis is critical, particularly in the oncology space. So having a company like Roche that has both the diagnostics and the medicines for certain cancers, I think is so important to changing landscape. Ike, I'd like to call on you because representing Johnson & Johnson, I mean, J&J is probably the largest international pharmaceutical company in the world and plays an important role across different divisions. So from diagnosis to surgery to medicines, could you tell us maybe a little bit about how you're really driving research and you see research as a key component? Because I know through our collaboration, Roche is committed to building capacity in clinical trial capacity for oncology clinical trials and sees the importance of advancing research in cancer in Nigeria and across sub-Saharan Africa.
So thank you very much, Jennifer. I think more than anything, I don't want to talk about the size of Johnson & Johnson relative to healthcare. I think I'll focus more on the work that we do in the public health space related to research, like you have mentioned. So we have a concept in J&J that we tag from lab to last mile. What is pretty much means is we're very much involved from the research and development stage up until when you make our products available to the patients who need them. To make this happen, what we have is a dedicated global public health organization, in addition to, of course, all of our commercial businesses. And this organization is structured in such a way that we have different arms who have different responsibilities. So, for example, we have the research and development team, which focuses on ensuring that we have the right, kind of clinical activities to focus on, clinical trials to focus on, they have the right kind of research activities to dwell on. And then, of course, we have the market strategy organization, of course, which then aims to see how they can commercialize whatever research innovations that have been achieved by the R&D organization. Now, one other very critical arm of the global public health organization that we have at J&J is the Access Strategy and Impact Organization. Those are focused on ensuring that our innovative medication is made accessible to people in low and middle income countries like these parts of the world where we are in. And what is also critical to note for the purpose of this audience is in terms of the therapeutic areas that we're involved in HIV, TB, recently, more recently into COVID vaccines, a bit of Ebola vaccines and dengue as well. But for key therapeutic areas that we feel are very, very important for us to fund research activities, oncology and mental health, we try and ensure that we shape we enrich the activities of research in different areas in low and middle income countries. J&J is investing heavily in research and development on the ground, on the continent, and of course, that's why it's invaluable to work with partners like you in the work that we do. And I'm sure that as we go along in the conversation, I'll talk some more about the work that we do on the ground. Yeah.
Perfect. Thanks very much, Ike. And we're missing a couple of participants, both of the Mercs. So we need from the global country or the country leader for Merck, Charles Ajibo. Could you join the panel? And also, do we have Josette Gamudu from MSD up on the screen, please? So Claire, moving to you, you've been a leader across the healthcare sector in Nigeria, working in Nigeria tirelessly for a number of years. Could you share how you are working just through Electa, your other partner organizations, to improve cancer patient outcomes and achieve some of the objectives?
Thank you very much for that question. Good afternoon, ladies and gentlemen. I mean, for us at JNC International, the call for action started 19 years ago. I spent quite a lot of time in the healthcare space, in the pharma industry, and I had a rude shock when I came into the hospital sector. Our country was a place for dumping obsolete equipment. There was little or no after-sales service for equipment in our country. We had no homegrown engineers, biomedical engineering schools, teaching modern day technology. And we found this as our responsibility very early on. So we have become a catalyst, an advocate for many decades. So it's going on 2 decades right now. So it's first started by us wanting to change the narrative of increasing diagnostic capabilities in the country and then moving on to intervention. So we started, of course, knowing that the budgets for the federal government was dwindling over time. It didn't start today. We worked with several hospitals, UCH Ibadan, University of Abuja Teaching Hospital, Lagos University Teaching Hospital, Aminu Kano Teaching Hospital, and we put on modern day, up-to-date diagnostic centers, putting the first 64-slice CT in the public sector in UCH Ibadan, doing the first cardiac center in UCH Ibadan, and doing other centers like that. And that's how we really started. But the challenge really was, there was a big challenge with the fact that our patients were having to make tough choices. We've heard today from the various presentations, especially the Lancet report, that the difficult choices that our cancer patients have to make, going from out of pocket to catastrophic out of pocket. So we realized that we cannot do this alone. We needed to work in collaboration with others. And we worked alongside the Healthcare Federation of Nigeria, various stakeholders here. And we said, look, we need to work with the government to create an enabling environment, have the right kind of policies to be able to get and attract investment into the space. But I also say, although we're an equipment company, and we provide equipment solutions, equipment doesn't make it happen. What makes it happen is people. So it's partnerships with ARCON and other associations like ARCON, developing continuous professional development, learning and development, investing in our people that really starts to make the difference. And then finally, we need to get access to finance. And we've worked with the likes of commercial banks and of course the federal government to create new models, and public-private partnership for us is one critical factor. So just to finalize, I think for us, it is advocacy to get early detection on cancer, is making sure we have research and development, that our hospitals are places of research and training and postgraduate training, that we work with the latest technology. We're not a dumping ground for obsolete technology. And because of the gap we have, we need to leapfrog to get the best technology to be able to give our patients cutting edge solutions. So that's where we come in. Collaboration is the way to go. The Lancet report to us redefines everything that we need to do. And we're really ready to partner with ARCON, with the Lancet to be able to make a difference. Thank you.
Thank you so much, Claire. I think you've touched on so many of the important points, but I want to just circle back to your work across sectors and partnership as being key, not only with the Federal Ministry of Health, with the funders, with the private sector. I think partnerships will play a key role in moving cancer care forward in Nigeria. Do we have Josette Gimudu on the line? Can we bring up Josette?
Hi, Jennifer, can you hear me? Hey, Jennifer, can you hear me?
I can. Josette, welcome, welcome. We're here in Nigeria, as you know, for the launch of the Lancet Commission report on cancer in sub-Saharan Africa. Really excited to hear from you, Josette, about MSD's commitment and some of your strategic initiatives that you're planning in the oncology space in sub-Saharan Africa. Could you speak to those points, please?
Absolutely. So it's a pleasure to be with you all, certainly virtually. Unfortunately, couldn't make it live, but certainly I think this has been a very inspiring conversation and dialogue. So certainly excited to be happy to be part of it and to help sort of push the agenda forward in terms of what is achievable and doable around expanding access to important cancer treatment pathways across sub-Saharan Africa. So as Jennifer said, excuse me, MSD as an organization, we are incredibly committed to ensuring that really across the globe, we have strong presence. And I'll just start off by saying how that's really manifesting and coming to fruition. So for starters, we've made very strong commitments around health equity within our ESG goals. So ESG stands for environmental, social, and governance. And so what that really means is, what are we as an organization and corporation doing to be global stewards and to ensure that really we are meeting patients where patients are at? And so one of the goals that we've put forward around advancing access to health is, one, we would advance health equity by reaching 30 million people in lower to middle income countries and in the US underserved populations through our social investments by 2025. We also have made a pledge to enable 100 million more people to access our innovative portfolio globally. This is going to obviously happen through what we do from an access, solutions, and more critically, from a partnership perspective. So as it relates to kind of bringing it home and thinking through what we're doing in sub-Saharan Africa to ensure that we are on that road to achieving these very clear and discrete goals within our ESG is, number one, in alignment with our access to health guiding principles, our oncology access strategy does aim to address unmet needs across geographies by ensuring that we are pursuing regulatory approval and reimbursement, supporting patients' ability to pay for treatment, investing in health system strengthening so that countries can expand quality access care along the treatment pathway. Now, obviously, we know that countries are at different places along the spectrum. So for countries where there is strong health systems that do enable and support administration of innovative therapy, in those countries, we're implementing patient access programs addressed, to hopefully address out-of-pocket costs. We're also having and deploying programs tailored to specific needs of the patient segments that range from sort of product donations, as well as also just, as I mentioned earlier, really thinking through and in partnership with different governments, thinking about how we can obviously offset that cost burden. Now, in countries where there's certainly, I think, huge, opportunity to think about infrastructure development, ecosystem strengthening, we've partnered with organizations like City Cancer Challenge and the American Cancer Society. So in Kenya, we've contributed about $2 million or so. This is a 5-year grant for Merck. It's really focused on fortifying patient navigation programs in Kenya, and we've also deployed a program in Uganda. With the City Cancer Challenge, we are working with Ghana, Rwanda, Kenya, where we're focused on advancing more equitable outcomes for women with breast and cervical cancer. And we're doing this by looking at the digital health and multidisciplinary care. So for example, in Rwanda, where we're collaborating with the Ministry of Health, we're rolling out an interoperable communication platform in Kigali that is accessible through an app to enable healthcare professionals from different disciplines and institutions to be able to communicate and coordinate care. And we certainly understand the importance of having strong digital platforms in place to enable, once again, adequate care coordination, adequate delivery of care. Also in Ghana, Rwanda, Kenya, we understand the importance of data and having really strong data and a back-end model to analyze cancer data to understand where there's gaps in care, where we need to be thinking about how we can put the right interventions in place to support outcomes and to ensure that we can do better targeting. Also in those same countries, we're working on nursing leadership and ensuring that we're improving the capacity of nurses and really professionals to be able to, once again, have what they need, the resources they need to deliver care. So certainly we're excited about what we're doing in sub-Saharan Africa. I think Nigeria is incredibly ripe for us to really expand a lot of these programs. And so looking forward to the types of partnerships that we can put in place to bring really this whole notion of developing the infrastructure to enable access, once again, to treatment, but also to enable the systems and the infrastructure that's needed to ensure that professionals are in place to deliver this care, to ensure that the data is there and the digital platforms are there.
And I'm
Jennifer.
glad you touched on Nigeria, because with your family coming from Nigeria, we're hearing about these other countries, but I know everyone here is saying you should be in Nigeria now. So looking forward.
We plan on it. We absolutely plan on it. And so trust me, there's more to come.
And I want to turn to Ansu. I mean, some big changes with Varian recently with the acquisition by Siemens. Hopefully that gives you much more power, much more oomph to do more to bring radiotherapy excellence to Nigeria and Africa. Could you tell us about the change in the company and what you're planning to do in Nigeria and sub-Saharan Africa to improve treatment options?
Thank you for that, Jennifer. It sure does. So what that has created, that is our combination with Siemens Healthineers. Varian and Siemens are now one company. It's basically giving you the biggest company in the world as far as imaging, diagnostics, imaging, and radiotherapy. So what we're doing with that is that we're accelerating the path from diagnosis to therapy to treatment. We have a really aggressive goal now. On average, even in the advanced world, it takes about 2 weeks from diagnosis to treatment. So our goal is to shorten that to 2 hours. And we have the tools now to be able to do that, right? Because for all the clinicians here, you all know the importance of integration. So when you have diagnostic equipment where you have to export images to a system that do not speak the same languages, it increases your CapEx as far as investing initial investment. So with Varian and Siemens now, we're giving you the tools to be able to make those decisions real time. And there is no need for export of images from one system that doesn't speak the same language as the other. So what does that mean for closing the gap? We talk about the late stage presentations that are happening. If we're able to shorten the time from diagnosis to treatment, it means patients are not waiting, right? I know in Nigeria, on average, it's taking about a month or more for patients to go from diagnosis to treatment. And so what we are planning to do with that combination is to use technology and also human expertise to be able to close that gap and bring the efficiencies that are going to be needed to make sure that sub-Saharan Africa is moving towards where we want it to move to be able to close the gaps as highlighted by the Lancet report. 120,000 cancer patients that are diagnosed in Nigeria annually, I believe, according to GloboCan, and 80% of those patients do die from the disease. So it means we need to increase access to care. So when we talk about access, often we think about equipment only. But we can have all the equipment that Nigeria needs today. If we don't have the human capacity to be able to treat those patients, it does absolutely no good. So at Varian, we're bringing solutions to the market where we're looking at the gaps as far as human capacity to see that we don't have enough physicists. It will take us years to train physicists. So what we are doing, we're offering oncology as a service. So Varian can do your planning for your facility. So if you were to acquire Varian services today, we can install your equipment and we can do planning for you. So we get your images, we do your planning. You do not need an expert physicist at your facility. Varian can do your planning and make it available to you real time. So you're able to treat your patients much quicker. So you shorten that time where you're waiting for physicists that do not have the expertise to be able to do all these plans. So these are some of the amazing things that we're bringing. And this is not only to Nigeria, even in the US. When we introduced this oncology as a service, we had only one customer 2 years ago. Today, we have over 100 US hospitals that are using that service. So there are lots of amazing things that Siemens and Varian are bringing to the market. And I believe Nigeria is primed to take advantage of that. Today, we have the largest cancer center in West Africa at Luth, NLCC. There is Marcel Ruth Cancer Center, and there's going to be many more that are coming up in the coming year in Nigeria. So in Nigeria, we're very local. The combination has given us over 70,000 employees around the world. In Africa, we have a policy or a strategy of being local. So in Nigeria, we have the local Nigeria team through our partner, Tanit Medical Engineering. We have locally trained engineers that are there at every facility to ensure that the machines are working fine. I remember when I came into Nigeria 7 years ago, the story where that Linux don't work in Africa. I think today Varian has proved that concept wrong, right? Because the machines at Marcel Ruth Cancer Center and the machines at Luth, they are working. Patients have been treated. We're treating over 200 patients at Luth today. So we're definitely motivated and we're working to add capacity. And we're just going to make sure that we have all those elements on the ground with the tools from Varian and Siemens, and make sure that that is available to ensure that the Lancet report. And, you know, so when you talk about going from 500,000 people that are currently dying from cancer in sub-Saharan Africa to 1 million that is projected 7 years from now. 1 million is a number, but let's just break that down.
And
I lost my father to
moving.
cancer, right? 1 million, we're talking about fathers, sons, mothers, daughters, 1 million. So there's a lot that all of us can do together to make sure that we don't hit that million mark.
That's very true. And I hope now that Varian's a larger company, you'll put more money and support into Nigeria in training those experts in the radiotherapy systems. I want to quickly switch to Charles, who's representing Merck, and ask Charles about some of the activities that Merck Germany, Merck Global, is taking to improve cancer patient care here in Nigeria, but across sub-Saharan Africa, and what you're doing next.
Good. Is it working? Okay, so thank you very much for having me. I'm happy that you made the distinction between MSD and Merck, and that's a very important one to start with. Speaking specifically about the call to action, I would say that my organization is done tremendously very well in terms of training. As far back as 5 or 6 years ago, even before we had the products in the country, we had the opportunity to sponsor a lot of experts to various international congresses. We also have different levels of preceptorships where we bring top experts all over the world to network with our caregivers here in Nigeria to upskill their skills. Then coming to a little bit about what do we do in terms of testing and diagnosis. We play in a particular area where it's important to know the RAS testing. So we're able to, and we know this is quite an expensive test in the country. So we're able to sponsor that test for every patient that has that would benefit from the test, and we pay completely for the test. Currently, we send the results overseas, and then we have partners in Nigeria who also work at the SIN lab, also works with us here in Nigeria to do those tests. We've gone a step further because of our interest in Nigeria, and we have another initiative now today to partner with government, where we'll bring the machines, and we have a couple of government hospitals in the country where we'll put down the machines and the tests can be done locally. And that will give a lot of opportunity for people to be trained better, know how to use the machines, provide a better access to our patients in terms of diagnosis. So, and we have different initiatives in terms of making the products more affordable for the population of the people in the country. I'll leave it at this for the moment.
Thank you so much. I think the KRAS testing, but bringing it to Nigeria is critical. I just want to quickly ask every panelist to quickly say, we've heard about the challenges, we've heard about the funding, we've heard about the opportunities. In 30 seconds or less, what do you think is going to make the biggest difference in achieving this, really this paradigm shift in cancer care? By, if anyone hasn't read this whole 65-page report, go to page 60 and look at the 8 calls to action, because that's what's got to happen in sub-Saharan Africa. And here in Nigeria, there's nothing preventing the country from achieving these goals. So I want everyone just to touch on what you'll do, what your company is going to do to deliver on these 8 calls to action that are critical for improving cancer patient outcomes.
Thanks very much. I think for us, 2 key things have to happen. One of them is partnerships, partnerships, partnerships. I think private sector needs to continue to partner together and with public stakeholders to ensure that implementation of the cancer control plans and also the Lancet Commission plans actually become actionable and are real and touch patients. I think the second thing, despite the success we may congratulate ourselves with advocacy, I think our advocacy is still not enough. This is not the time to rest our oars. We need to do a lot more advocacy for cancer care. It needs to be prioritized in the country and really to be given the prime of place in budgetary allocations, in mindset of our stakeholders, and also in professionals. Those would be the 2 key things.
Thank you, Hamid.
Yeah.
So for us at Johnson & Johnson, what is critical is it's important to understand the oncology landscape and on the African continent, and how we can do this is to better work with partners, partners like yours, to see how we can develop capacity of even the clinical trial clients or patients, include diverse population in clinical trials for oncology on the continent. Those are very critical things to ensure that we are well represented and new innovations are developed that match diversity.
Perfect. Thanks, Ike. Claire.
Thank you. As JNC and Electa, I think our focus first is the fact, as a proudly Nigerian company, that we have a responsibility for creating an enabling environment for the right kind of policies that will speak for our patients. We must be patient-centric in every decision that we make, and we see ourselves as an advocate and as a catalyst to make that. So as Electa promises to provide the cutting-edge technology with AI solutions, such that we train Nigerians for Nigeria. We don't want to export our jobs. We want to be able to use technologies that we have using AI to be able to train you and leapfrog your skills from where you are today to where you need to be. We need to have it homegrown in country. And secondly is partnerships, partnerships, partnerships. As my colleagues have said here, we cannot do it alone. Government cannot do it alone. We have a joint responsibility as academia, as researchers, as private sector to work with you. And as a clear example, we have 2 huge public-private partnerships, one in Kaduna State, setting up the probably most advanced center in the whole of sub-Saharan Africa, with a gamma knife and several other things that are coming in there, and also with Lagos State. So there's a lot of partnerships with the federal government, with state governments that will redefine the way cancer is treated, cancer is advocated, and most importantly, patients get access to quality, affordable care. So we need to work together.
Thank you, Claire. And Sue.
I totally agree with all the sentiments. I think collaboration is key. Everyone in this room is holding a different piece of the puzzle. Put all of it on the table, right? For Varian, we are here and we commit to just continue and building on what we've been doing. We have a very important partnership with the NSIA that we're looking to expand on. And what I can commit to you also is that Varian will open a training center here in Nigeria, where we will train Nigerians and also bring people from outside the world. Because I know Nigerians do not like when we talk about Ghana, having Ghana being the place for Nigerians to go. So we are committed to building that training center here in Nigeria with partners like the NSIA to ensure that Nigerians don't have to fly out of Nigeria to get training.
Okay, 20 seconds, Charles.
Good. So what I would say, I wouldn't say anything different from what has been said, but I would make you laugh. For us, we look at Nigeria as a center other than Ghana. So we are trying to build more machines in Nigeria so that it can access the West African region. So we will improve access to care and we also improve training for our caregivers. So thank you very much.
Okay, thank you. We're going to wrap with everyone on the stage. Thank you very much, everyone. Here, read this publication, the call to action particularly.
Thank you very much. Very interesting session. And I like the collaboration that has been stimulated here. Can we have a group photograph, please? Yes, following up, we'll be following up with this panel in terms of tangible and deliberate commitments that have been made. Can we would like David and Will to come up, please, quickly. And thank you very much for being part of this very important section of this intervention by ACON, allowing integration with Lancet. I'd like to bring on Dr. Tessie now, and for further announcements, have a very good afternoon in Abuja. It's been wonderful being part of this. Thank you very much.
Thank you so much, Ma. Thank you for the moderation. It was a good session. Thank you, everyone, the panelists. Lunch, yeah. Okay. Thank you so much for your patience. We've come to the end of the Lancet Oncology session. It's time for lunch, and I would ask, please crave the indulgence of all participants to get their tickets and go for lunch. Every other person will be sorted out afterwards. Please, participants, get your tickets and go for lunch. We want to have it as quick as possible so that we can come back. Tickets are available at the stand. At the staircase, please just get your tickets at the staircase and then go up, grab your lunch, and let's come back and conclude the last session for the day. Please, all presenters for the next session, can you get your slides to the IT session and then come back from lunch as soon as possible so that we can start.
Hello, everyone. Housekeeping information. We are resuming here in 1 hour. We'll resume at 3:30, please. We are resuming at 3:30 to continue our presentations. The last lap. Eh? No, you can't resume now. Lunch. Oh, okay. So I've been informed that it's at 3:15. We are resuming here at 3:15 in 45 minutes. Please proceed to have your lunch now. Thank you so much. And then we can continue with the scientific session. Thank you.
intensive and palliative care in forms of chemotherapy, immunotherapy, and hormonotherapy. The unit is less than a year old, but it has treated a lot of patients with varying forms of cancers.
The University of Education Hospital Center of Excellence have undergone so many transformations by quality for the healthcare services to the people. The institution has taken the bull by the horn by making a dashing entry into the cancer management space in Nigeria by establishing state-of-the-art cancer facility. The University of a new era of providing radiotherapy services. The center has successfully installed the Electa Infinity Linear Accelerator, an Electa Flexitron brachytherapy machine, a Varian Bravos brachytherapy machine, a 6-4-slice Canon CT stimulator, and a C-arm. Other facilities at the center include Electa Versa HD Linear Accelerator awaiting installation. The center is designed to give comprehensive cancer care through provision of chemotherapy services, multidisciplinary clinics, and laboratory services. In this center is a clinic team comprising of clinical oncologists, medical physicists, therapy radiographers, and oncology nurses trained to provide better and oncology care. The center will key into research and capacity building by establishing partnership with the best oncology centers across the globe to solve healthcare problems. When commissioned, the UMTH Cancer Center will play a pivotal role in providing accessible and quality healthcare for cancer patients, not only in Nigeria, but the whole of West Africa, as it is the first of its kind.
My name is Dr. Bolaji Latif Salako, consultant radiation and clinical oncologist, FMC Abeokuta. Our center is new and growing.
This is the Department of Radiation and Clinical Oncology, Federal Medical Center, Idiaba, Abeokuta.
Hello. Hello.
This is the radiotherapy bunker.
Please, we need only the participants now to come over to where they are eating. Others should please hold on. Participants only.
Ultra beats on the track.
My name is Professor Saad Ahmed, a professor of pathology and the medical director of Federal Medical Center, Abuja. Our oncology unit is about 2 years old, and we equally have 2 clinical and radiation oncologists manning the unit. They have quite a number of other support staff that they work with. And equally, we were able to establish multidisciplinary team within which various stakeholders in cancer care management do come together to sit down and address issues and then see the best way that cases are being treated. The clinics are running on weekly. We run about 2 clinics, and we equally have other clinical activities which we do. In terms of collaborations, we have support from the government, agencies of government, corporate bodies, as well as some other societies. Currently, we are in talks with Nigeria Atomic Energy Commission and the IAEA, who are quite willing and promising to support this center towards training of our personnel, as well as provision of cancer treatment equipment in this facility. So on behalf of staff and management of Federal Medical Center, Abuja, I welcome you to FMC Abuja, and I equally wish you a happy celebration at the ACON conference. Thank you.
Welcome to Jacaranda Cancer Center, an oncology specialist hospital with a group of specialists like radiation and clinical oncologists, surgical oncologists, gynecological oncologists, and anatomic pathologists. We organize with partners to do screening with mammogram, PET CT scan, ultrasound, CT, and MRI. Our chemotherapy suite and theater are fully functional. Look no further, because Jacaranda Cancer Center is your one-stop oncology specialist hospital with state-of-the-art equipment that caters to the full spectrum of cancer care, like screening, diagnosis, treatment, and palliative treatment. Jacaranda Cancer Center is affiliated with HCG Cancer Center, India, St. Biko Academic Hospital, Pretoria, South Africa, as well as other partners in the USA, Canada, and the United Kingdom. Jacaranda Cancer Center is located at 9 Second Hill Estate, GRA, Ibarra, off Olokemeji, opposite RCCG, Ogun Province 16 headquarters, Abeokuta, Ogun State. For more information and inquiry, please call 0816-037-4006 or email info@jacarandacancer.com.
Welcome to the NSIA Luth Cancer Center, NLCC, leading world-class cancer care in Nigeria, offering compassionate and comprehensive care at every stage of the patient's journey. At NLCC, we understand the huge burden that cancer diagnosis and its subsequent treatment places on the patient and their family, and we provide the most feasible route to alleviate the situation by offering affordable, safe, and proven treatment options. NLCC commenced operations on the 29th of May, 2019, with a vision to lead from the front as we continue to grow and raise the bar in healthcare and medicine by providing affordable, accessible, and accurate healthcare services across Nigeria. Located within the Lagos University Teaching Hospital, Luth premises, NLCC's privately run facility is the most equipped cancer treatment facility in West Africa. We have the best and latest in terms of equipment and highly skilled multidisciplinary professionals delivering care to our patients. Run as a standalone entity in a public-private partnership venture with Luth, our mission is to set the standard of excellence in healthcare, advance medicine through cutting-edge research, and uplift every community we serve. In all that we do, we put our patients first, providing cancer care at international standards. From our state-of-the-art equipment to our highly experienced team of medical experts, we believe that our patients deserve this depth of knowledge and compassionate care in their treatment. At NLCC, we have treated over 6,000 patients. We deliver curative and palliative treatments to our patients using the most innovative cancer therapy solutions. Some of the therapies available at NLCC are radiotherapy, brachytherapy, chemotherapy, hormonal therapy, and immunotherapy. When cancer occurs or recurs, It can be an overwhelming situation for the patients and their families. To get compassionate and comprehensive care, visit our website, www.nlcc.ng. Follow us on our social media channels to get our latest updates and health advice on cancer care at NSIA Luth on Twitter, Instagram, LinkedIn, and at NSIA Luth Cancer Center on Facebook.
Our new bright therapy building and housing our new bright therapy equipment. And then you see we are doing bright therapy right now. You see our team, see our director of oncology among, and then all the people are chief nursing and chief physicists. So we are doing a procedure now. But it's okay, let's catch up. You notice these are new units these are the that are being installed right now. We'll probably show you. In a procedure, and then the bunker. We have our C-arm and
So still part of the teaching hospital, University of Medical Science, Akure Complex. This is the male ward. This ward consists of patients that have had surgery, and then the medical patients too, and then we also admit patients for chemotherapy. So it's basically male surgical, male medical, and then oncology ward for the male patients that will receive chemotherapy. Good morning, everyone. This is the entrance to the University of Medical Science Teaching Hospital, Akure, in Ondo State here. Presently, the government is trying to give us a befitting structure. And so most of our main clinics, outpatient clinics, theaters have been like a makeshift. So we're hoping that very soon this building will be completed, and then we'll be able to have our clinics, oncology clinics, surgical clinics, and medical oncology clinics. Here is our consulting room actually we have 3 consulting rooms. This is one of them where we see our patients. I run clinic on Thursdays. So on Thursday morning, we run clinics here with the nurses and all the health care workers from the consulting rooms. Most times patients come from, there's a reception where they are being called from. Before we get to the reception, this is the records room, where the cards are being gotten from, the records, and then straight to the reception. You can see here that this is where the reception is, where patients wait to be seen. The waiting area where patients are seen and then called in to be. So lastly, this is the female surgical ward of the University of Medical Science Teaching Hospital, Akure. Here in this ward, we have female surgical cases, ENT cases, gynecological cases, and then I also admit patients for chemotherapy, female patients, a 30-bedded ward. And so I admit patients for chemotherapy. Basically, my chemotherapy days are Wednesdays and Fridays. So we try and admit them, and then we administer the chemotherapy for like 3-4 hours, and then they are discharged home. So it's basically an outpatient kind of treatment.
My name is Dr. Bolaji Latif Salako, consultant radiation and oncologist at FMC Abeokuta. Our center is new and growing.
This is the Department of Radiation and Clinical Oncology, Federal Medical Center, Idiaba, Abeokuta. This is the radiotherapy bunker. You can see the work is in progress.
Good morning, my great members of AFCONITE. This is Radiotherapy and Clinical Oncology Department, Usman Danfodio University Teaching Institution. This is our reception. You can see, as you can see in the reception, there are so many boxes. This is an ancestry of the arrival of the new linear accelerator. That's the variant type. The department was established in 12th October 2010, and it was one of the, I can say, second generation centers that were established after Lut and Ibadan. And it has contributed significantly to the Association of Oncology in rendering services to our oncology patients. We receive patients from our neighboring states and also from all over the country, and even the neighboring countries like Niger and Cameroon. You can see the work is ongoing, renovation of the bunker. This is the treatment control area. Renovation is ongoing. This is our bunker for the new linear accelerator that has already arrived. As I showed you in the reception, the boxes, you can see bunker well renovated now. The installation of the new variant linear accelerator. I just want to remind you, initially it was an Electra, which you all know. So the Electra machine has an Electra inside. In the other that was initially installed there are other centers. But now it gradually been replaced by variant, that's the vital beam now. Let me take you to the PP suite, where we do our simulation of the patient and see the new look of the This is the new look of our tissue. You can see all the components that is there. This is the located. You can see the bunker is really ready to accept to receive the new CT material. Similarly, the center is also one of our LCMD has done very well in brachytherapy. So I want to use this opportunity also to take you to our practice.
Welcome to the Department of Oncology Federal Medical Center, Ebute Meta, Lagos. Our patient-centered care services include constituting neoadjuvants, adjuvants, and palliative care in forms of chemotherapy, immunotherapy, and immunotherapy. The unit is less than a year old, but it has treated a lot of patients with varying forms of cancers.
The University of Maiduguri Teaching Hospital Center of Excellence have undergone so many transformations under the leadership of Professor Ahmad Ahiju to provide quality and affordable healthcare services to the people. The institution has taken the bull by the horn by making a dashing entry into the cancer management space in Nigeria by establishing state-of-the-art cancer facility. The University of Maiduguri Teaching Hospital Cancer Center brings a new era of providing radiotherapy services. The center has successfully installed the Electa Infinity Linear Accelerator, an Electa Flexitron brachytherapy machine, a Varian Bravos brachytherapy machine, a 6-4-slice Canon CT stimulator, and a C-arm. Other facilities at the center include Electaversa HD linear accelerator awaiting installation. The center is designed to give comprehensive cancer care through provision of chemotherapy services, multidisciplinary clinics, and laboratory services. In this center is a clinic team comprising of clinical oncologists, medical physicists, therapy radiographers, and oncology nurses trained to provide better and oncology care. The center will key into research and capacity building by establishing partnership with the best oncology centers across the globe to solve healthcare problems. When commissioned, the UMTH Cancer Center will play a pivotal role in providing accessible and quality healthcare for cancer patients, not only in Nigeria, but the whole of West Africa, as it is the first of its kind.
My name is Dr. Bolaji Latif Salako, consultant radiation and clinical oncologist, FMC Abeokuta. Our center is new and growing.
This is the Department of Radiation and Clinical Oncology, Federal Medical Center, Idiaba, Abeokuta. This is the radiotherapy bunker. You can see the work is in progress.
Ultra beats on the track.
My name is Professor Saad Ahmed, a professor of pathology and the medical director of Federal Medical Center, Abuja. Our oncology unit is about 2 years old, and we equally have 2 clinical and radiation oncologists manning the unit. They have quite a number of other support staff that they work with, and equally, we are able to establish multidisciplinary team within which various stakeholders in cancer care management do come together to sit down and address issues and then see the best way that cases are being treated. The clinics are running on weekly. We run about 2 clinics, and we equally have other clinical activities which we do. In terms of collaborations, we have support from the government, agencies of government, corporate bodies, as well as some other societies. Currently, we are in talks with Nigeria Atomic Energy Commission and the IAEA, who are quite willing and promising to support this center towards training of our personnel, as well as provision of cancer treatment equipment in this facility. So on behalf of staff and management of Federal Medical Center, Abuja, I welcome you to FMC Abuja, and I equally wish you a happy deliberation at the ARCON conference. Thank you.
Closing the cancer care.
Welcome to Jacaranda Cancer Center, an oncology specialist hospital with a group of specialists like radiation and clinical oncologists, surgical oncologists, gynecological oncologists, and anatomic pathologists. We organize with partners to do screening with mammogram, PET CT scan, ultrasound, CT, and MRI. Our chemotherapy suites and theater are fully functional. Look no further, because Jacaranda Cancer Center is your one-stop oncology specialist hospital with state-of-the-art equipment equipment that caters to the full spectrum of cancer care, like screening, diagnosis, treatment, and palliative treatment. Jacaranda Cancer Center is affiliated with HCG Cancer Center, India, St. Biko Academic Hospital, Pretoria, South Africa, as well as other partners in the USA, Canada, and the United Kingdom. Jacaranda Cancer Center is located at 9 Second Hill Estate, GRA, Ibarra, off Olokemeji, opposite RCCG, Ogun Province 16 headquarters, Abeokuta, Ogun State. For more information and inquiry, please call 0816-037-4006 or email info@jacarandacancer.com.
Welcome to the NSIA Youth Cancer Center, NLCC, leading world-class cancer care in Nigeria, offering compassionate and comprehensive care at every stage of the patient's journey. At NLCC, we understand the huge burden that cancer diagnosis and its subsequent treatment places on the patient and their family, and we provide the most feasible route to alleviate the situation by offering affordable, safe, and proven treatment options. NLCC commenced operations on the 29th of May, 2019, with a vision to lead from the front as we continue to grow and raise the bar in healthcare and medicine by providing affordable, accessible, and accurate healthcare services across Nigeria. Located within the Lagos University Teaching Hospital, Lute premises, NLCC's privately run facility is the most equipped cancer treatment facility in West Africa. We have the best and latest in terms of equipment and highly skilled multidisciplinary professionals delivering care to our patients. Run as a standalone entity in a public-private partnership venture with Lute. Our mission is to set the standard of excellence in healthcare, advance medicine through cutting-edge research, and uplift every community we serve. In all that we do, we put our patients first, providing cancer care at international standards. From our state-of-the-art equipment to our highly experienced team of medical experts, we believe that our patients deserve this depth of knowledge and compassionate care in their treatment. At NLCC, we have treated over 6,000 patients. We deliver curative and palliative treatments to our patients using the most innovative cancer therapy solutions. Some of the therapies available at NLCC are radiotherapy, brachytherapy, chemotherapy, hormonal therapy, and immunotherapy. When cancer occurs or recurs, it can be an overwhelming situation for the patients and their families. To get compassionate and comprehensive care, visit our website, www.nlcc.ng. Follow us on our social media channels to get our latest updates and health advice on cancer care at NSIA Youth on Twitter, Instagram, LinkedIn, and at NSIA Youth Cancer Center on Facebook.
Our new brachytherapy building and housing our new brachytherapy equipment. And then you see we are doing brachytherapy right now. You see our team, see our director of oncology is among, and then all the people are chief nursing chief physicists. So we are doing a procedure now. But it's okay, let's catch up. Notice these are new Linux, these are the Linux that are being installed right now. We'll probably show you one camera. We're doing a procedure, and then this is the bunker. We have our team and take it.
So still part of the teaching hospital, University of Medical Science, Akure Complex. This is the male ward. This ward consists of patients that have had surgery, and then the medical patients too, and then we also admit patients for chemotherapy. So it's basically male surgical, male medical, and then oncology ward for the male patients that will receive chemotherapy. Good morning, everyone. This is the entrance to the University of Medical Science Teaching Hospital, Akure, in Ondo State here. Presently, the government is trying to give us a befitting structure. And so most of our main clinics, outpatient clinics, theaters have been like a makeshift. So we are hoping that very soon this building will be completed, and then we'll be able to have our clinics, oncology clinics, surgical clinics, and medical oncology clinics. Here is our consulting room for, actually we have 3 consulting rooms. This is one of them where we see our patients. I run clinic on Thursdays. So on Thursday morning, we run clinics here with the nurses and all the health care workers from the consulting rooms. Most times patients come from, there's a reception where they are being called from. Before we get to the reception, this is the records room, where the cards are being gotten from, the records, and then straight to the reception. You can see here that this is where the reception is, where patients wait to be seen. The waiting area where patients are seen and then called in to be. So lastly, this is the female surgical ward of the University of Medical Science Teaching Hospital, Akure. Here in this ward, we have female surgical, that is surgical cases, ENT cases, gynecological cases, and then I also admit patients for chemotherapy, female patients, a 30-bedded ward. And so I admit patients for chemotherapy. Basically, my chemotherapy days are Wednesdays and Fridays. So we try and admit them, and then we administer the chemotherapy for like 3-4 hours, and then they are discharged home. So it's basically an outpatient kind of treatment.
My name is Dr. Oncologist Latif Salako, consultant radiation and clinical oncologist at FMC Abeokuta. Our center is new and growing.
This is the Department of Radiation and Clinical Oncology, Federal Medical Center, Idiaba, Abeokuta. This is the radiotherapy bunker. You can see the work is in progress.
Good morning, my great members of AFONITE. This is Radiotherapy and Clinical Oncology Department, Usman Danfodio University Teaching Hospital. This is our reception. You can see, as you can see in the reception, there are so many boxes. This is an ancestry of the arrival of the new linear accelerator. That's the variant type. The department was established in 12th October 2010, and it was one of the, I can say, second generation centers that established after Lutz and Ibadan. And it has contributed significantly to the Association of Oncology in rendering services to our oncology patients. We receive patients from our neighboring states and also from all over the country, and even the neighboring countries like Niger and Cameroon. You can see the work is ongoing, renovation of the bunker. This is the treatment control area. Renovation is ongoing. This is our bunker for the new linear accelerator that has already arrived. As I showed you in the reception, the boxes, you can see bunker well renovated now. And this is the installation of the new linear accelerator. I just want to remind you, initially it was an elector, which you all know. So the elector machine has an elector site. In the other that was initially installed there are other centers. But now it's gradually being replaced by variant, that's the vital beam now. And let me take you to the PT suite, where we do our simulation of the patient and you see the new look of the you're welcome to the CT. This is the new look of our CT. You can see all the components that are there. This is the located. You can see the bronchi is really ready to accept to receive the new avenues, CT machine. I mean, similarly, the center is also working on our MCMD has done very well in brachytherapy. So I want to use this opportunity also to take you to our practice.
At least by the time he's coming and he's falling and everything. Oh, we'll find a way around it. Let me just.
So good afternoon, everyone. You are welcome from the lunch break. So our next session is sponsored by Sanofi. So I'd like to call Dr. Jerome Epum. He's going to moderate the Sanofi session. Dr. Jerome, please, we need you up here. Okay.
Okay, greetings, everybody. I trust we had a wonderful time during the lunch break. I know the glucose level is now up. At least we can pay a bit of attention as we commence this session. So we will be having a panel discussion. Our intention is really to deepen the conversations around prostate cancer. And today we'll be having short presentations and have the presenters come together to present in a panel discussion. So chairing this panel discussion, among the discussants will be Dr. Abubakar Bello. Please, let's give him a round of applause. Thank you very much, sir. We can do better than that. There's more energy now. Thank you very much. Yes. Also, as part of discussants and speaker, as we continue in this meeting, will be Dr. Mutiu Jimo. Thank you very much. Thank you very much. A round of applause for him. And lastly, our able president of ACON, Dr. Amaka Lashibiko. Let's give her a big hand. Thank you so much, madam. All right. So this will be our flow. We would have the first presentation by Dr. Jimo, followed by Dr. Lashibiko, and we'll have a wrap up by the chairman, Dr. Abubakar Bello. So I'd like to welcome Dr. Jimo. Thank you.
Good afternoon, everyone. So we want to share our experience and the one we manage with second line taxing in our center. Can we have the slide? Okay. Well, who needs a second taxing? I'll do the case presentation, and then my president will do the and then my president will also discuss about the use of second line taxane in prostate cancer. Right. I'm going to follow this outline, patient presentation, supporting journals, the use of NCCN guidelines, then some cases and the side effects. Where I present Mr. OO, a 62-year-old man with a diagnosis of metastatic adenocarcinoma, Gleason score 3+4, ECOG 0, no comorbid condition. Actually, his symptoms started in 2017 when he presented to a private facility with inability to urinate. And then he was evaluated in that private setting, and the PSA was around 16.7. Then he was given some medications, no more than that, and patient went back home. Then after a few months, the symptoms resurfaced again, and the patient went back to his doctor, who further evaluated patient by doing an imaging, and the MRI showed enlarged prostate with increasing PSA. PSA increased to like 62. We are going to see the graph. So he planned that patient for surgery, and he had surgery in 2018, February. After surgery, patient was placed on the dual androgen blockage, Soladex 10.8 with bicalutamide 150 milligram. Then the same year, around September, patient had pelvic XRT, 54 grain, 27 fractions. So October of the same year, the PSA repeated came back to be normal. So patient was happy. But on the following year, around February, the PSA increased again. So, and that time, it was also evaluated for what is going on. So the image showed there's bony metastasis, and patient was placed on zoledronic acid and add XRT, further XRT to the metastatic site. So despite this, PSA keep on increasing. Now, patient now presented to us for continuation of treatment in May 2019. We evaluated the patient. We discovered that the patient has a spinal metastasis. And then we sent the patient again for XRT to the spine. And then commenced patient on abiraterone. After 5 cycles of abiraterone, patient progressed with new lesion in the liver. Then we stop it. Then we then commence first-line chemotherapy, docetaxel. And he completed 10 cycles of docetaxel. But on follow-up, we also discover again that after 10 cycles of docetaxel, PSA started increasing. Wow. So we now look at, okay, what tests are we going to do for this patient? So we look at some trials to look at the use of second-line chemotherapy. So we consider this criteria while we are considering the patient for second-line taxane. And it's also very important for us to consider that when you want to take a patient through another line of chemotherapy. So histologically confirmed, and it's confirmed that patient has metastatic castration-resistant prostate cancer. At least 3 cycles of prior docetaxel. He had 10 cycles of docetaxel. Progressive disease less than or equal to 12 months. If you look at that, he progressed before even 1 year. Then ECOG status. Performance status of that patient was 0, fully active. Except mild pain. Even the liver met that we are talking about was not symptomatic of the liver met. So we did another scan after the docetaxel that also saw disease progression by increasing PSA and another lesion in the lungs, though not symptomatic. So we now commence cabazitaxel in 2020. And patient had 10 cycles of cabazitaxel. And this, after the cabazitaxel, we follow up on the patient. Fortunately, the PSA is going down. Then the imaging remains stable since after that. Right. So now we look at, like I said, that apart from the eligibility criteria, we look at some supporting journals. This CAT study, the most important thing in this CAT study it really showed the difference between the capacitor group and the enzalutamide group or abiraterone group. And where we have the primary endpoints to be the radiological progression-free survivor and the secondary endpoints too. So we back our decision with this study. And we also opened the NCCN guideline. We look at where does this patient fall into this NCCN guideline. Patient has had cabazitaxel and abiraterone. So we can consider this patient for second line taxane, which is cabazitaxel. So we also open this to back our decision. We didn't just take the decision and then. So with this, the use of this evidence, and then now, as at last time that patient presented to us, the PSA still remain low and stable. We are still observing because it's just 1 year ago. Now, the major side effect that patients complain about during this chemotherapy was just fatigue, where grade 1 peripheral neuropathy, and which is also manageable. No other side effects than that. Now, we look at some journals and the issue of toxicity reports. If the effect, the toxicity is much, for example, if patient presents with a grade 3 neuropathy, we can discontinue. If it's grade 1 and 2, it can be managed, you can reduce the dose. We were watching when patient was having that chemotherapy, but fortunately, he has only just grade 1 neuropathy with fatigue. Thank you very much.
Thank you very much, Dr. Jimo. So I'll call on Dr. Lashibiko to take on the next presentation. Thank you.
Okay. Good afternoon, ladies and gentlemen. Thank you for staying with us this long. And I know the challenges of having to deliver a presentation shortly after lunch. So I will try to keep this short and simple. But one of the good things about presenting after somebody is that there might be that possibility of having 1 or 2 of your slides already presented, which is the case here. So like I said, I will try and keep it short and simple. So my talk basically is centered around who needs a second taxane, when and why. And I'm going to be using this as my objectives. Disclosure is Sanofi. And okay. Okay, so just to refresh our minds, so we've had a practical example of a patient that was put on cabazitaxel following hormonal treatment, which he failed on, and then went on to have docetaxel and then cabazitaxel. So, but just to refresh our minds, we know that the treatment landscape of prostate cancer has changed in the last years. And there are lots of new molecules out there targeting different stages of the disease. Prostate cancer is actually one of the diseases where we can say they have a certain trajectory of how they will flow, starting from the non-metastatic hormone sensitive space, moving on to the metastatic hormone sensitive space before you get onto the metastatic, non-metastatic castrate resistance, and all the way down to asymptomatic castrate resistant and subsequently being symptomatic. So when you have this kind of patient, what do you do? What are the things that should guide your treatment plan? Dr. Jimo during his presentation talked about a few things that were used for them that guided them in what they would do. So I'd just like to touch on two things which essentially should guide our treatment plan as clinicians. One is the data surrounding the tumor or the disease entity that you want to treat. And the second, which sometimes is overlooked, but really shouldn't be, because in this era of personalized medicine, we should be able to look into patient characteristics and provide individualized care as much as we can. So in the clinical trial data, looking at efficacy, we're also wanting to make sure that the toxicity profile in terms of safety is taken care of. And then ultimately, we want to cure without really pulling down the patient's quality of life. Patient characteristics, we're looking at biological age, even though when we talk about biological age, it is not just the numbers, but we are aware that as patients increase in age, like we saw earlier on, there are certain comorbidities that come with increasing age. So that needs to be taken care of, especially to avert polypharmacy, which usually is the case as they advance. The volume of disease, the stage, and I just want to highlight the patient preference should also be taken into account when designing your your treatment plan. And fitness for chemotherapy, the patient that we saw was an ECOG 1. If the patient was an ECOG 2, I think these would have far-reaching implications on the treatment plan that would be chosen. Suitability for corticosteroids, co-medication is also something we need to think about, because most of these patients will require some form of pre-medication with corticosteroids. And if they are unable to, then we need to look for alternatives. Another thing that should guide your treatment plan, particularly in Nigeria of today, is the use of the NCCN harmonized guidelines. Last year, during the International Cancer Week, the federal government, through the Ministry of Health, mandated that all cancer should be treated using the recommendations from the NCCN harmonized guidelines. And it's important that we get familiar with it, the color codes that are in there, and essentially how to navigate the NCCN harmonized guidelines. Optimal treatment choice depends on the sequencing. Now, like I mentioned at the beginning of my presentation, there are many drugs that are available now, but it's important to sequence it right, knowing when to give what and how to give it, because we know that optimal benefit is often achieved when both a taxane and an ATA is included in the treatment plan. But when you're deciding for a chemotherapy as opposed to an ATA, we must remember that sometimes it might be better to bring that up along the treatment plan rather than later on when the performance status is optimal. Okay, so we're just going to briefly look at the evidence which would guide our treatment plan. I'll be talking a little bit about the CARD study, which was a randomized open-label multi-center trial, randomized 1-to-1, that looked at the efficacy and safety of cabazitaxel as compared with an ATA in patients with metastatic castrate-resistant prostate cancer who were previously treated with docetaxel and who had progressed within 12 months while receiving the alternative inhibitor, that is either abiraterone or enzalutamide. So these are the characteristics of the trial design. Like I said, it was randomized 1-to-1. One arm receiving cabazitaxel at a dose of 25 milligram, and the other arm receiving an ATA, either abiraterone if they had had enzalutamide, or the other way, depending on which they had had. Endpoints include, the primary endpoints include radiographic progression-free survival, while key secondary endpoints include overall survival, progression-free survival, PSA response, and tumor response, which are key facts that we need to consider, especially in light of the patient that we had just seen. I also want to mention that stratification was based, we had patients who were ECOG 1 versus ECOG 2 as well. So I just want to, this slide just highlights the patient characteristics, and I highlighted a few things here because I feel they are relatable. I had no idea the case Dr. Jimo was going to present, but I do know that most of the patients that we see in the metastatic setting would have some form of visceral metastasis. So we can see here that patients in the cohorts that was recruited had liver metastases or lung metastases. We also see that in terms of the type of progression that they had patients that had PSA only, which we saw until later on. I think he had a little pain, but because we know that pain is also one of the factors that brings patients to the clinic. So in terms of the types of progression that were included in this study, we saw quite a number of patients presenting with pain, but still also presenting with radiographic progression and PSA only as well. In terms of the disease history, we see that quite a number of patients that were enrolled in this trial had high Gleason score, which is similar to what we see in our clinics. Again, like I said, that slide was put, we can really relate with the outcome of the study. From this Kaplan-Meier curves we see that in terms of overall survival, we see there was a clear advantage of cabazitaxel after disease progression on the ATA and docetaxel as opposed to going back to an ATA. And then in terms of progression-free survival, we see very clearly that the split is actually quite early on. Again, which is why sequencing of your treatment options is very critical. Then in the subgroup analysis, see that in terms of time, we see clear advantage in patients that progressed more than 6 months, but we also noticed that there was some activity in patients that were less than 6 months following progression. But I'd like to really pull your attention to patients who had a Gleason score of between 8 to 10. We see there was a clear survival advantage in the cabazitaxel as against continuing with ATA. And we know that most of our patients present with aggressive disease here. And again, in types of progression, down at pain, which is a common presentation of our patients, we see that there was a clear benefit in the cabazitaxel as opposed to those taking either enzalutamide or okay. So in terms of the endpoints, the primary end outcome, they showed that those in the cabazitaxel had a median radiographic-based progression-free survival of 8 months as against 3 to 7 months in the comparator group. Secondary outcomes include median overall survival was better with 13.6 in the investigational group cabazitaxel as compared to 11. There was also noted a reduction in the PSA level of at least 50% from baseline 3 weeks after the initial study began. Pain response was confirmed in 45% as opposed to 19.3% in the ATA group. And the median time to symptomatic skeletal event was not reached in the cabazitaxel group. However, that was seen at 16.7 months in the androgen receptor signaling inhibitor group. So in conclusion, cabazitaxel led to longer based progression-free survival than abiraterone or enzalutamide among patients with metastatic castrate-resistant prostate cancer who had previously received docetaxel and the alternative, either abiraterone or enzalutamide. Cabazitaxel also significantly improved OS and other secondary endpoints. So the next time I'm just going to look, this is also a subgroup analysis still within the CAD trial, but this time focusing on males, patients who were older than 75. We know that quite a number of patients are older than so we really need to be sure that this drug is safe and effective in this patient population. The outcome measures were similar to the initial one, with the primary endpoint being radiographic progression-free survival and the others. In the interest of time, I will try to speed up, but just to point here now that as we see from this slide, in men that were more than 70-year-old, we saw that there was a definite advantage in the radiographic progression-free survival and median overall survival, favoring cabazitaxel as opposed to the comparator group, abiraterone or look at the 3 factors that patients would often present with in terms of disease progression: PSA response, tumor response, pain response. We can see clear advantage over the taxane, with the taxane over the abi or enzalutamide group. In terms of safety profile, we note it was noted in the study that almost all patients had adverse effects of any grade and mostly greater than grade 3. the summary was that most of the patients had a different safety profile compared to the younger ones. And it's important we take note of that because the common grade 3 adverse events seen in the cabazitaxel group in older patients included fatigue, asthenia, diarrhea, and febrile neutropenia. So if you're thinking of giving this in the older age group, you really need to be mindful of this and take that into consideration. In conclusion, cabazitaxel improved radiographic progression-free survival and median OS. All other secondary endpoints also favored cabazitaxel, but like I said earlier on, there was a different safety profile with higher rate of grade 3 or above adverse events in patients that were over 70. In the interest of time, I will skip this slide and go on to the conclusion. The Proselica style was essentially around pain and pain control. So it was a post hoc analysis of a large phase 3 study in the MCRPC patient population. And it further confirms that pain progression at CABA initiation is associated with clinical and more biologically aggressive disease and worse outcomes. And so we should take note of that once we have patients in that category. So because in this age, we're really looking to personalize care and really offer value-based care, I put up this slide to look at the clinical and cost impact of cabazitaxel versus a second androgen receptor targeted inhibitor. Because when we give, again, like I mentioned, sequencing is critical, and it is important for us to be able to balance the benefits with this economic implication of it as well. So the objective of this study was to develop an economic model to determine potential healthcare resource utilization. And at the end of it, the conclusion was that it was far more, it was economically better to have patients who had progressed to go on to a second taxane rather than to move on to another novel hormonal agents as well. So in conclusion, I'm going back, sorry about that. Okay, so Dr. Jimo had also talked about using the NCCN harmonized guidelines and showing where and the role of the second taxane is in the treatment trajectory, which I will not bother to go back to again. But just to close out by saying that if you're considering using a second taxane, cabazitaxel, the things you should consider: age, patients below and above 70, there's a clear benefit. However, toxicity issues and safety profile should be taken into consideration. Patients that derive the greatest benefit are ECOG 0 to 1, and it definitely has a strong role to play in rising PSA doubling time, and it's also useful with prior treatments in post-Taxel era, post-ATA era. And indeed, there have been some studies that have not used in first line. However, one needs to look at that data very critically, because it says that for patients who are unable to tolerate glucocorticoid therapy, which we know must be given with the docetaxel, but these can be considered as well. So I close out by saying, in conclusion, that patients that have worsening pain, as we saw in Dr. Jimo's patient with rising PSA, would derive strong benefits with cabazitaxel use. And thank you very much.
So thank you very much. We've had the presentation of the patient by Dr. Jimo. I don't need to make a recap because time is well spent. Already they've been telling us 1 more minute, but I think we will take just 2 questions. One to Dr. Lashibikon and then to Dr. Jimo. One question each. Anybody? So no, I know it's there after lunch, people are a bit hyperglycemic. So I understand maybe a patient that Dr. Jimo presented, who is a 65 years old male, 62, who actually had bilateral orchidectomy, right? No orchidectomy. but he had, okay. And then Dr. Taxel, 10 side. Okay, so I will just quickly ask you, so looking at that case profile, how do you think the treatment plan for that patient can be better optimized? Press the button. Right.
Hello. Okay. So it is very important as a clinician to know that when we are treating a patient, we need to educate our patient. Right. We also need to let the patient know that, well, human nature can also change. Because there are some situations where you may need to rebiopsy. For example, this patient has TURP. If the imaging show maybe another mass there, it's also possible to rebiopsy that. For example, now in breast cancer, when we have immunohistochemistry that can change, when you have a lesion, excise, and then you have another tumor again. So we need to educate them very well. Another thing is to also clearly define the importance of their treatment, and then when they need advice, when they're on treatment, so that they can seek for advice or seek for intervention or help. For example, a patient on chemotherapy, if they notice anything, they need to come around, right? We need to also look at our local environment. What do we do to prevent side effects, severity of the side effect, so that patient can be adequately prepared and then get all those maybe post medications and even adequate pre-medications. Thank you.
Thank you so much. I do know that the use of guidelines is very critical. I happen to chair the NCCN Harmonized Guideline for Sub-Saharan Africa in prostate cancer. So I can see that it's been alluded to. So very important for our clinical practice. Let me just quickly ask one question to Dr. Lashibikon, because she talked of the safety profile of cabazitaxel. I know that a lot of clinicians are worried about the myelosuppression, especially for those that are not aware that cabazitaxel has a double dose dilution, and it is critical that you understand what that means. So my question to you is that, are you really concerned about the myelosuppression, and how do you actually prevent that? Thank you.
Okay, thank you, Dr. Bello. I quite agree with you that in using this drug, we really need to strive a balance between efficacy and safety, because otherwise using a sledgehammer to kill a fly syndrome would not really suffice in terms of improving quality of life and really driving what we want. So yes, safety is important. Like you touched on in the drug administration, double dilution is critical. Patients, like we saw in Dr. Jimo's patients, fatigue is a problem, but that doesn't mean we should not look into the myelosuppression. And as part of drugs that need to be given before we have to put the patient on granulocyte colony stimulating factors, so that, and then not just that, but you should also monitor as well. Monitor, because you just want to drive in safety and efficacy as well.
Excellent. I think that's a very excellent answer. Granulocyte colony stimulating factors are critical, and you can actually use them prophylactically. I have seen that also, that sometimes you see that the platelets tend to also go down. So we have some drugs that you can actually use, but if they are so low, then platelet concentrates are very critical. Eltrombopag has been used sometimes not only as prophylactic, but for real treatment to stimulate the bone marrow to produce platelets. So thank you very much, lady and gentlemen. And I think we've been, they said we're 5-10 minutes more. Thank you. So that's the end of this discussion. We thank Sanofi for bringing this up. I think it's apt And I think going forward, Cabazitaxel is available in the country, right? It's available. Okay. Thank you. So thank you, everyone.
Sponsored session. I would invite Dr. Popola Benjamin and Dr. Eriba Lucy. They are both radiation and clinical oncologists from Federal Medical Center, Abuja, and University of Benin Teaching Hospital, respectively. They will be moderating the next session. Thank you, Dr. Eriba. Good afternoon, everyone. It's been a very beautiful day. This afternoon, to continue the scientific session, we'll be having some presentations this afternoon, and we're going to be calling in presenters. Please, we're going to be very mindful of time. As we all know, time is fast spent. So right now, we're going to be calling our first presenter right now is Professor Solomon Rotimi, who is going to be talking on precision oncology care in Nigeria. Can we start now? Please, can we have Professor Solomon Rotimi? Thank you very much. You're welcome.
All right. Good afternoon, ladies and gentlemen. Let me briefly introduce Professor Solomon Rotimi. He's a professor of clinical biochemistry at the Covenant University, Ogun State, Nigeria. He is a principal investigator at the U.S. Department of State, Department of Defense for a program in the U.S. He's also a co-chair of the research committee in IOTIC. Dr. Rotimi research work is focused on understanding the contribution of genomics and the environment, particularly pathology, nutrition, and xenobiotics to cancer disparity in Blacks by using technology, basically genomics, molecular, and bioinformatic tools. He's very passionate about his job. He's interested in developing people, and he's here this afternoon to give us a glimpse into the future as regards personalized medicine. Ladies and gentlemen, Professor Solomon Rotimi.
Thank you very much, sir, and good afternoon, everyone. Well, I believe the last session presented by Dr. Jimo and Dr. Lashibiko actually provided a very good background to build my presentation on. And what I want to do is to present you some of the data that we have from our studies. And at the end of the day, to let all of us agree or decide or disagree, as it were, on whether it is good time for us to begin to look critically at integrating, precision oncology care, particularly looking at, genomic information into our practice. So to start off, I think I'm someone that I sort of like history a little bit. So I started looking at, is there any historical evidence for genetic contribution to cancer in this part of the world? And they started looking at some of the earliest, published scientific publication on cancer. So I came about this this paper published in 1910 in British medical journal by John Randall, who was actually a practicing physician in Nigeria at that time. And I take an excerpt from it. I read. I was talking about the Jebus, said they were the most conservative, and that after the British conquered them between 1892 and 1893, it was posted to the Jebu nation, as called them, to the British military garrison there to serve as a medical officer. And he said, among such a conservative people, he saw his chief, a male, presented with breast cancer. He persuaded him to remove it, but after he had done so, the disease reoccurred and then subsequently killed the man. He said, now, this occurred in a man who was a typical aborigine. As at that time, there was argument whether it was the European coming to Africa that were bringing cancer and that whether cancer was common among the Aborigine or indigenous people or not. Again, about 2 years, that was around, this time around 1908, the man's son, also a pure Aborigine, applied to me for treatment of cancer in its late stage. And from this disease, he also died. So this seems to me to be the first, one of the earliest examples to show that there must be a contribution, genetic contribution to cancer as we have it in this part of it. And so with that, we know that just a little bit of basic biology or biochemistry or molecular biology. So if you have a good DNA, the DNA is transcribed to RNA, and then your RNA is transcribed to protein, and then the proteins perform the function and all of the activities that we have in the body. But if you look at about 30,000 or 20,000, there are about genes that we have in our functional genes, 30,000 to 40,000 functional genes that we have. If you have abnormal gene, what happens is that it's easy for you to then realize that you have abnormal protein, and abnormal protein gives abnormal cells and abnormal tissue, and that results in what we call disease, and in this case, cancer. And so basically, let me just jump through this for time. So basically we know that in basic essence, cancer is a genetic disease. And there are several things that can cause the genetic alteration. It could be internal and it could be external. And there are two groups of genes that we look at. We basically look at oncogenes and tumor suppressor genes. So these are genes that control the rate of cell growth and genes that accelerate. So sort of look at cancer as a loaded vehicle with rocket fuel. The brakes are off and the accelerator is stuck to the floor. And so the cell is just moving on uncontrolled. And so the question then becomes, how then could you explain a 20-year-old without history of cancer, family history of cancer, but then develop aggressive triple-negative breast cancer? I mean, I have colleagues here who have told me that this is not an unusual thing. Well, it's possible that you may have the parent who have cancer because of this, Kuhn's 2-hit hypothesis. That you can inherit, you have two alleles, so one could be good and one has an issue. And so when you then have mutation of the second one, then you can have the disease occurring very early. Or then if you inherit two good alleles, then you could have the disease coming on later on in life. And they talked about, that is sporadic, cancer. Okay, so that's just me trying to provide some explanation. And so we then realize that no matter the site of the cancer, no matter the tissue, what we continue to see from genomic data coming out is that you have several tissue-derived tumors sharing common mutation. And so it's therefore not surprising, therefore, that the new line of drugs coming out now are what we refer to as tissue-agnostic therapies. And so I've given you two examples of some of the works that have been done in this part of the world, looking at genomic data. I'll first of all start briefly on breast cancer, and I will dwell more on prostate cancer, which is the primary area where I work. And so, I'm excited, Dr. Atara is here, and thank you so much for the work that you're doing. And so I want to take a clip from the data available from US based on the disparity between breast cancer survivor between white and black. If you look at the data from early 70s, you realize that there's really no disparity. But as soon as we're making advances, we move from molecular pathology to genetics to gene expression and now to precision therapy. It seems that the gap is widening. So the question then becomes, why is the gap widening? Why the gap in survivor widening? As we are increasing and advancing the technology, it shouldn't be so. The reason why we have that is, one, we realize that the African and Black populations are underrepresented in genomic studies. And most of these drugs that are driving down or increasing the survival rate are basically derived from genetic information. And so because number one, we're not involved in genetic study, there's limited involvement in genetic study. Again, you look at clinical trial to test these therapies and how effective they are. Again, Africans and Black populations are grossly underrepresented, in fact, less than 4%. And so the challenge is to us, and that's why I give it out to the work that Dr. Atara and all of us, so many people here are doing, to see that we increase clinical trial for our population. And so based on that, I'll talk on the work that, led by Professor Funmi Olopade on breast cancer. And simple, the data speaks to itself. What they did was that they took the tumor and they did whole exome genome sequence. And you look at the mutations that they call. Up there, you have P53. And then next, you have a lot of other things. But importantly, you then see BRCA1 mutation, you see BRCA2 mutation. So I wanted to hold this on one hand, and I will tie it up by the time I begin to explain the prostate cancer study. And so, but we know that when tumors harbor BRCA mutation, they do very well to a class of drug. And so one more thing that also happens is that when they harbor this mutation, they also have a tumor microenvironment that makes them respond better to immunotherapy, particularly anti-PD-1. Okay, that's another good information, that they didn't just have this mutation that makes them respond very well to PARP inhibitors, but then they also have higher potential to respond even better than that to anti-PD-1 than even to PARP inhibitors. Okay, now to prostate cancer. I mean, so I just wanted to talk about this slide. Dr. Jimo just talked about it. Castration-resistant prostate cancer is very real. The percentage is quite high in this population. And then there are suggestions to say, oh, let's catch it early. But the data is showing, the data we're seeing is showing that, look, even if we try to catch it early, how early should we catch it? Now, this is the data that came out from Lagos. And who's controlling it? Okay. And that showed that, and they look at autopsy, data, and they realize that incidental prostate cancer in men who died from other causes is very low in this population, lower than you have in African Americans and lower than the Caucasian. So which means that perhaps the tumor it's not that the tumor has been there for long. The issue is that when the tumor begins to grow, it grows aggressively, okay? And when you see that kind of aggressive growth, it's not about catching it early enough, but then there's something about the biology of that tumor that we need to understand. And so a lot of our work, again, Cos J, those of us that know him, released that there's this publication that came, these two publications that clearly show that even in the US, within the veteran VA population, when you normalize access, Blacks will still die more than Caucasians. It's about 1.8-fold increase in mortality, even when you normalize for access. They have access to care, they have access to screening, they do everything normally. The Blacks still carry the burden of mortality from prostate cancer. So the question then becomes, what is it about the biology of this disease in the Black population that we need to understand? And so we're excited that during the last AACR, disparity conference, our publication was out. It's been a long journey. You probably will know a number of people on this publication. I will publish the whole exome sequencing of prostate cancer from Nigeria. And we found out, I won't bore you with this methodology, but if anybody is interested in it. So we found out very simple. A is Nigerian data, B is African American, and C is Caucasian. So we compared with the population. Well, you see the Nigerian data up there is what you see in BRCA2 mutation, followed by APC, followed by ATM, followed by BRCA1. Very enriched, HIR mutation, pathway mutation in Nigerian prostate cancer. Again, just another way to look at it, the lollipop plot and where those mutations are located. And so we of course, we now know that when you have tumor that is enriched for, BRCA1, BRCA2, ATM, the sensitive to, to what we call synthetic lethal anti-cancer therapeutics. And they are talking here about PARP inhibitors, that we do very well. They respond very well to PARP inhibitors. And so we're not surprised when the data from this, profound clinical trial came out that showed that olaparib performed better, than ezetimibe and eberleterone combined. And so then we look at the data and the population recruited for this study. Lo and behold, out of the 200 patients, only 3 Blacks were there. And this is for a disease that disproportionately affects the Black population. And we have data now that show that Nigerian population is enriched for mutations that will make them to benefit from this class of drug. So the challenge to all of us here is this. We should go now and speak to all of these pharmaceutical companies and ask them, now with this data, they need to support clinical trial. In this population, all of them should bring out their PARP inhibitors and let us try it out on this kind of patient that Dr. Jimo is seeing in his population, in his patient, that the kind of patient that are having castration-resistant prostate cancer, because this is a drug that we have evidence now that it will do very well on, not just the men, but also for ladies that present with triple negative breast cancer. That's on one hand. And then, of course, what happened based on the evidence of that data, FDA approved olaparib for metastatic castration-resistant prostate cancer once the individual mutation carries mutation in these genes. Okay, that we have now seen that is enriched in Nigerian patients. But we also know that when you have mutation in those DNA repair genes, it also affects your inflammation and immunoinflammatory environment. Do we have data for that in this population? And we're building that on work done by persons like Dr. Rennie Reams and Stefan Arms at NCI. And so we've done RNA-seq study. We look at the RNA and we profile the immunoinflammatory response of Nigerian patients. And then we compare it with white patients. What you see on the corner, the A showing you the heat map, you see the Nigeria on the left and the TCGA European America on the right. Clearly, the tumor biology is different. Okay, we did what we call the volcano plot. We identified genes that are upregulated, and based on that, some of those genes, we look at the biochemical parameter evidence, and one of them is what we call the TGO2, which converts tryptophan. Rather, typically tryptophan should be converted to serotonin, but when TGO2 is upregulated because of the presence of the tumor and the biology of the tumor, tryptophan conversion to serotonin is inhibited or is altered, and it's then converted to kynurenine. But the reason why the tumor does this is it uses kynurenine to invade the immune system. You see, kynurenine is an immunosuppressant. And so we've seen that evidence, and then we went into the serum of the sub-Nigerian patient. We did case control study, and right there, they said that we see kynurenine is significantly upregulated. And based on that evidence, we approached the DOD to fund us to develop what we call the IKEA program for Black men. Okay. Okay. So what we're looking at is to identify the biological factors that contribute to poor quality of life, particularly among prostate cancer survivors. And this is a collaboration between Mayo Clinic USA, City of Hope, Georgia Tech, and then Covenant University, and these are the multiple PIs on it. And for the Nigerian project, I have we have centers, across the country, and we're grateful to all the people collaborating with us. And recently, and I think that was last week, we got additional funding from NCI, supplemental funding, to then extend the same study to Kenya. And so what we have seen then from our RNA-seq study, just to provide you some more data, to further explain to you why we are having this castration resistance. So we compare the tumor biology from Nigerian population samples that we have with Ghana population. What you see clearly is that there's upregulation of AR variant. And so because of this AR variant, even when you give, you do castration, androgen deprivation therapy, the AR variants are upregulated and therefore drives the castration resistance. That Nigerian, tumor biology prostate tumor biology is driven through this AR pathway. Again, but then when we look at the immunoinflammatory pathway, we realize that the Ghana population, those samples are even more enriched for T1, TH1 cytotoxic T cells, and also through the CDK pathway. So again, that seems then to be driven more through the inflammatory pathway, while the Nigerian, samples that we have seems to be through the AR pathway. Again, this again showing what some of us who work within the genomics part, space know that there's different. That the fact that African is called African, there's highly population heterogeneity within this continent. Just as I begin to round up, I just thought I should show a couple of things that we are also doing in terms of training. Just last week, we completed a genomics training for African investigators. Yeah, and I think I've seen somebody here who actually participated in this. And actually, there are a couple of people that have come to our lab at Covenant University, and I'm talking of even oncologists, pathologists, resident doctors, that we're now trying to train and expose to some of these technologies to see how these things, are done. Thank you very much. As I begin to round off, I just want to share a closing thought, thank you. That cancer is a genomic disease. I think we have evidence to show that PARP inhibitors, checkpoint inhibitors, immunotherapies, and the likes, we do very well in this population. And I think we have enough technology for us to start doing some sort of PCR screening, at least that we can use for pharmacogenomics or pharmacogenetics, particularly when it relates to drug dosing. Thank you very much.
So Solomon, he has succeeded in, I'm sure, pricking our conscience regarding beginning to think about precision medicine in Nigeria. Sitting down there when the first presentation was going on about prostate cancer, I asked myself, what if there was one thing, just one single thing that could be attacked for this man to get back his health? He had radiation, he had surgery, he had hormonal therapy, he had chemotherapy, but he's still not free from disease. The basic thing is that cancer is a disease of mutation. Mutation occurs at the level of the gene. So any effort to get rid of cancer must pay close attention to the gene. Hence the need to commence personalized treatment medicine, precision medicine in Nigeria. We would love to take questions, but we'd like to please ask that the questions should wait until the end of the presentation so that we can save time.
Thank you very much, Professor Rotimi. We all do know that the patient is the major person that we are really talking about in all this that we are doing. And the patient, as an active participant in her decision-making, the cancer treatment journey is very important. So this afternoon, we're having somebody who's going to give us a speech on the patient as an active participant in making decisions on her treatment journey. To give us that speech this afternoon is Mrs. Gloria Oji Wanjogu. Mrs. Gloria is the president of the network of people impacted by cancer in Nigeria. I think she's going to do good justice to that and taking who is important to really be very important. You're welcome.
Good afternoon, ladies and gentlemen. Please, may I stand on existing protocol? My name is Gloria Oji Wanjogu, and I am the president of Network of People Impacted by Cancer in Nigeria. We are a cancer patient support group, and we support ourselves, the patients, with correct information on our cancer journey. So as I stand here, I am representing all cancer patients in Nigeria. Before I start on the topic we have, I really need to appreciate the LOC of ACON for giving us this opportunity to speak to our doctors. I think to the best of my knowledge, this is the first we are having in such gathering. So I really appreciate the LOC of ACON for doing that. Thank you so much. Today I am here to speak on the topic, the patient as an integral decision-making participant in their cancer journey. Next slide, please. You know, we are all here, just like the moderator said, we are all here because of the patient. Whether you are an oncologist, a pharmacist, a surgeon, a nurse, we are all here because of the patient. So the patient is at the center of everything that you are doing. And so we believe that the patient also should participate in the course of her treatment. We should know, we should be in the know of what is happening to us. Fine, we know that sometimes when you are, faced with the diagnosis, you kind of blank out. But that doesn't mean that subsequently you wouldn't want to know. Next slide, please. So the patients are asking for this from you all, our doctors. The first is, see us, the patient first, not the disease. In 2019, I was at SOPD at the National Hospital. And when I got into the office of my doctors at the clinic, someone said, oh, this is a cancer patient. And it was like everybody was excited about it. And the next thing, the person said, it's breast cancer. And everybody said, oh, why must it be breast? Why should everyone that is coming is breast, breast, breast? I was taken aback by that because left to me, I wouldn't have even chosen cancer at all, not to talk of determining whether it is breast, hand, head, or whatever. So when we come in, please see us first as the patient, not the disease. Secondly, offer us all the available treatment options. Don't look at us and believe that, oh, this option, she will not be able to afford it. That option, of course, she can afford it. Tell us everything. Let us make our choices. You may be surprised what happens. In the process of this, we will be working with you because you have told us everything that we need to know. We will work with, even as you're telling us from the expert point that this is the one we want you to take because this is what you benefit from it. Give us that opportunity to know that you are caring for us, to know that in this journey that we are going, you are working with us. So if the drug is very expensive, let us know. If there are cheaper ones, also let us know. Let us make that decision. As we work together, I believe we'll definitely be having better outcomes. Then manage patients' expectations. Most of the times when we get to, okay, let's assume you had a patient that presented in stage 1 and we decide to disappear, probably went to the mountain to pray for a year and came back a year later and it is stage 4. I know how your faces will look like. It's our fault. Yes, we know, but please manage us. Try to see how you can help us. Don't give up on us. Most of the times we leave because the face of the doctor had already told us that, guy, you're gonna die. So what's the essence? So please, even though it is our fault, we didn't continue with our journey. We didn't continue with our treatment. Please bear with us and follow us through, no matter how bad it may seem. We may appreciate it. We'll be dying and we'll still be grateful because you gave us that opportunity to live. Communication. I think this is one of the most important things. The communication between the doctor and the patient is sometimes a very difficult thing. You are telling us and we are not understanding you. You may be using the medical jargon. I can remember when my doctor asked me to be on tamoxifen and I read, because whatever drug I'm taking, I read the leaflet and it said you are prone to uterine cancer. And I was like, I'm trying to run away from breast cancer and I am going to have cancer of the womb. Honestly, I didn't take that drug. And after 3 months, when I came next, my doctor asked me, are you on tamoxifen? I said, Doctor, but it causes womb cancer. And he said in his 11 years of practice, he had not been able to even detect one, that it is just there. He was able to convince me. He communicated properly. And that helped me, and I started taking the tamoxifen. So please, communicate properly. Calm down to our level so that we'll be able to understand you, so that we'll be able to trust you, so that we'll be able to move with you. If we do this, don't mind, sometimes we may reject it. Sometimes we'll tell you you are the devil giving us the bad news. Forget about all those things. Please bear with us. But tell us what we need to know. Gradually, we will still turn around and come back and still go forward with you and trust you more. Finally, I want to say this to you, our dearest doctors. We know that a lot of your colleagues are leaving the country in droves. So you are overworked. We know that your pay are not up to par. We know that you do not have the equipment and resources to do your job properly. We also know that you may have other things going on in your personal lives, which makes it challenging to give your best. But please, when we, the patient, works into your clinic, do not see us as a villain in this cause. See us as a child of circumstances, as a child who didn't choose to have cancer, but it is here with us. So thank you for all that you have been doing. God bless you all.
Thank you very much, Mrs. Gloria. That is the voice of the patient. The patient is in the center of it all. There's an appeal. We know you're overworked. We know that we might not listen to you ab initio. But please, when we come back, always embrace us and answer us. I think we have all had, being on the other side can be harrowing sometimes, but I can tell you, if you get someone who can listen to you, if you get somebody who can pat you on the back and say, don't worry, all will be well, it goes a long way psychologically to help that patient. Thank you again, once again. We really appreciate you. Continuing our session this afternoon, we're going to have a little deviation somehow. Please give your indulgence. We have a message from the president of the Nigeria Medical Association, and we'll be calling the immediate past chairman in Benue State, NMA, in the person of Dr. Samuel Otene, to please briefly give us the message of Mr. President. You are welcome.
Thank you very much, Dr. Eriba. Good afternoon, everyone. I actually crave our indulgence to stand on already established protocol. Mr. President sent this to me 2 days ago as the NMA National Committee on Cancer chairman that I am, and asked that I help him read this. I think my job is simple. It's just to read his speech and get back to my seat. It is with much pleasure that I address this gathering of great minds, all assembled with the common purpose of forging ahead in the monumental battle, which is what the fight of mankind against the scourge of cancer has become. That most of you have manned the front lines in this battle, striving to give much needed hope to many, is indeed worthy of commendation. When one ruminates on the cancer situation, especially in the setting of our sub-Saharan Africa, one cannot help but feel a deep sense of foreboding. This is because apart from the numerous global challenges, we still have our own unique, deep-seated issues which make the task of cancer care much more daunting. From the very high and even rapidly escalating cancer burden to a system of data collection which is marred with irregularities and inconsistencies, to issues of poor accessibility, availability, and affordability of comprehensive cancer care facilities, it is not too difficult to understand why the system often seems easily overwhelmed. The Lancet Commission report to be launched as part of these ARCON conference activities, it was launched earlier. This speech is coming later than when it should have been, also underscores the reason why all hands just need to actively be on deck in this cancer fight. To think that with every minute, 16 to 18 people globally die of cancer. To think that over 800,000 of these new cases and over 500,000 of these deaths are in sub-Saharan Africa is really unnerving. The fact that cancers of the cervix, breast, and prostate, which have well-defined screening methods globally, with even primary prevention by vaccination for cervical cancer, are the major cancer culprits decimating our population in sub-Saharan Africa, is very disheartening indeed. Also, that the cancer burden is projected to double in sub-Saharan Africa within the next 20 years to an estimated 1.5 million new cases and about 1 million deaths by 2040 is a clear pointer to how fast we all need to work to effectively and efficiently brighten the cancer horizon. However, we know that it is not just a gloomy story in its entirety. This is where the Federal Ministry of Health and all its partners and stakeholders in the cancer space, including ARCON, need to be commended, because within the last 5 years, a lot has happened to paint a brighter picture of the cancer landscape. The way the Nigerian Cancer Control Plan 2018 to 2022 is structured, with its inherent monitoring and evaluation tools and definite tasks clearly spelled out, gives an indication that perhaps we are taking this issue a little bit more seriously. It gives us something with which to evaluate our progress and make necessary plans to upscale our current efforts. The Catastrophic Health Fund, recently graciously rechristened Cancer Health Fund, is also another indication that Nigeria is now ready to pay more than just lip service to these issues. This is clearly a task that requires all hands to be on deck. Being the largest medical association in West African sub-region, with over 40,000 members spread across every state in Nigeria and the Federal Capital Territory, and about 19,000 in diaspora, the Nigeria Medical Association is uniquely placed to take this cancer battle closer to the population. We are very willing to work closely with the Federal Ministry of Health and all relevant government agencies, corporate bodies, and organizations to enhance the prevention, early detection, treatment, and control of malignancies in the country. Although we acknowledge that the Federal Ministry of Health and its partners are doing a lot, we still know that a lot more needs to be done. The president of the Nigerian Cancer Society, NCS, Dr. Adamu Al-Hassan, recently mentioned that Nigeria needs at least 300 radiotherapy machines to serve its population. The current situation where only a maximum of 2 to 3 public radiotherapy centers are functional at a time leaves a lot to be desired. Thankfully, we are seeing more positive movements in the private sector. We have moved on from nearly a decade of having only 1 private radiotherapy facility in Nigeria to at least 4 easily identifiable centers now within just a couple of years. However, we will agree that 7 to 10 functioning centers serving over 200 million population is a far cry from the ideal. The gap is huge. We look forward to more cancer centers equipped with radiotherapy machines, both publicly and privately owned, springing up across the country. This will reduce the significant distances many Nigerians need to traverse in order to access much needed care. We commend the public-private partnerships of government in this regard and encourage more investors to key into this very vital aspect of healthcare so as to help cut down medical tourism. In spite of the current brain drain, which has caused a dearth in the medical personnel across the country, if we set a long-term target of having a functional radiotherapy center in each of the 36 states in Nigeria, including Abuja, it is not too much for Nigerians to ask. And I am sure ARCON can assure us that they have enough members to populate these centers and bring about much needed succor to our patients. I congratulate ARCON for the feat of bringing various specialists in the field of oncology in Nigeria and even beyond together to deliberate and fashion out innovative ways to surmount the mighty hurdles sprawled out ahead of us. Congratulations once again on your annual general meeting and scientific conference, ARCON 2022. I wish you very fruitful deliberations, even as I look forward to much more robust collaborations in the years ahead. Thank you very much.
Thank you very much, Dr. Otene, for the speech. We would like to call upon the Oncology Pharmacists Practitioner Association of Nigeria for their presentation. We have seen with time that the management of cancer has evolved. It is now a multimodality, multidisciplinary, and as a matter of fact, multinational approach that is applied to the management of cancer. The pharmacists constitute a significant part of this team. It is on this note that I welcome the member for the presentation.
Thank you very much. My name is Michelle Richard. I bring you greetings from Opan. Congratulations, Econ, for this wonderful conference. I would want to begin with a short story. When the human body was created, there was a debate about which part of the body was the most important. Of course, the brain and the heart stated their importance, and the other parts were trying to say how important they were. They were trying to make their points until the anus stated its point. They all laughed at it and made it angry. Angered by this, the anus decided not to work for that day. It took a day off. By the end of the morning of the second day, the eyes were crossed, the heart was filled with toxic blood, and the brain was having a serious migraine headache. Then they realized that they could not function well without the anus. And from that day on, they decided to cooperate together for them to function well. Ladies and gentlemen, I'll be presenting on multidisciplinary approach to cancer care, the impact of pharmacy in patient intervention. Okay, thank you very much. Okay, this will be my outline. We'll just short brief this in. The multidisciplinary approach in cancer, in oncology care is defined as the cooperation between the professionals involved in cancer care with the overreaching goal of improving treatment and efficiency and patient care. The MDT actually emerged in the mid-80s. That was a time when the addition of chemotherapy to surgery and radiation was actually proven to improve survival. It started as a small team of few professionals that they met regularly to review new patients and design treatment guidelines for them. When they saw the success of this team approach, they decided to bring in new specialties, which was focused on supportive care. This new addition of new specialties, which might include the nurses and the pharmacists, actually improve the quality of cancer care by preventing and diminishing treatment side effects, in which turn improve patient adherence and compliance to therapy. Gentlemen, this is the natural evolution of the functional units of multidisciplinary team in oncology. Today, what we're having is MDT is the gold standard in management of cancer. For a team to work together to collaborate for success, there should be some ground rules or rules of engagement. These are some of the qualities or attributes that are needed for this team to work. There should be collaborative practice, meaning they have to interact. There should be clear communication between them. This is very important. As a pharmacist, sometimes we get prescriptions not knowing what the BSA of the patient is, what the height is. These are things that are very important. We need clear communication. And if we have any clarification, we need to make it clear to the doctors what we really want. Definition of tasks and responsibilities. This is very important. There are overlapping duties, and these things need to be sought out based on best practices, recognition and respect for competence and contribution of each member, and they need a competent leader for the team to work. Gentlemen, meet the multidisciplinary team in oncology. Like I want to not to be controversial, the arrangement of the list is not in any order of importance. So let's not have any argument as what it is. The patient is part of the multidisciplinary team. If you notice the other side of this, these are non-health professionals on the team. The psychologists and medical staff are not medical staff, but they are part of the team. The group picture in the middle are the team that are working in the oncology space. What I'm going to do for today, I'm going to zoom this group picture and focus on the pharmacists and what they do through their activities. These are pictures of my colleague in UBTS. They are the pharmacists that are practicing. These are centers where pharmacists are involved in cancer care in Nigeria. So the next few slides, I will be talking about the activities of pharmacists and how they impact on patient outcome. I will be discussing it under the following headings. So quickly, I will start. In case we see any picture, I will just flip over it because it's just trying to explain what I just explained earlier. Increase access to cancer care. Cancer drug, cancer medications are very expensive. The cost of cancer care has inhibited patients from getting treatment. It is interesting to know that there are concerns about the quality and sources of these drugs. But with the involvement of pharmacists, with correct partnership with pharmaceutical companies and NGOs, pharmacists have been able to help bring down the cost of cancer care and analgesics like morphine, which they produce locally in most of the hospitals for benefit from. This partnership with NGO NCAP is now evolving in most of our centers. Pharmacists have taken ownership of this project and are doing really well, bringing down costs of cancer care in that patients are now able to complete their courses of chemotherapy with much less than what they were using 3-5 years ago. Medication errors are actually avoidable. They are actually avoidable events that can lead to incorrect use of medicines and harm to the patient. The pharmacist in top is to carry out screening and validation. Through this process, the pharmacist gets to understand the mind of the doctor to interpret it. By this process, if there are any unusual deviations, the pharmacist needs to clarify this with the doctors to save the patient any problem that might occur from it. They do this through a systematic approach, which will require what we call the rule of 5 R's: the right patient, the right drug, the right dose, route of admission, and time. Other checks that are carried out of the appropriateness of the protocol, drug interaction, contraindications are usually used. And sometimes we review laboratory results to check that these are all in line. These are all done to help out patients and the doctors to make sure that the patient does not have any problem while undergoing treatment. This is just a picture to trace the first point there. Patient education and counseling. Safety and effective use of drug medication in cancer requires that the patient is well aware of what drug he's using and how to use them. The pharmacists are involved, engage the patient in a constructive discussion most times. It's called what we call counseling. This is a cooperative process where the pharmacist involves the patient to identify areas of difficulty or concerns. Things like fertility, hair loss. The patients have concerns about this. These are things where pharmacists intervene. But more importantly, the patient goes home with the information about how the drugs are to be used, what side effects are expected, what are the early signs of emergencies that he needs to report, what can be treated at home. Other things are, as nutrition, proper storage of these drugs are very important and vital, and they have helped impact on patients' outcome in the policy. Patient education and counseling, that was just to illustrate the point out there. Aseptic reconstitution. I think I would want to use the word safety, efficacy, and precision as one of the words to describe the involvement of pharmacists in chemotherapy reconstitution. Pharmacists are skilled in the act of reconstitution and precision. This is something they practiced mostly when they were in school. The pharmacists are shown that when reconstitution are carried out by pharmacists, there's actually a reduction, 20 to 40% reduction, average reduction in the cost of drugs. This they do, enabling patients to, up to 80% of patients to actually complete their cycles of chemotherapy. They do this through the process, what concept we call microdosing, which is vial sharing, where you bring patients that have unusually very expensive drugs to share these vial drugs and save them costs generally. We are also involved in improved safety of patients and staff by moving away chemotherapy reconstitution from the bedside to a restricted area where the environment is safe and other people are safe for it. This are generally what we do. Drug therapy problems, these are undesirable events experienced by patients that are involved or is suspected to involve drug therapy and are actually potentially can interfere with that outcomes. Studies have shown that up to 74.7% of patients on chemotherapy have encountered one form of DTP or the other, of which studies have shown up to 5 to 10% of patients of chemotherapy usually leads to hospitalization, of which 50% can actually be avoided. The pharmacists work with the patients and the clinicians to make sure that drug therapy problems are solved. These are some of the examples of the drug therapy prevalence that are actually classified into 7 groups. Example in case is a wrong, where the drugs is a wrong drug completely because of similar names and lookalike drugs. Paclitaxel sometimes can be interchanged for docetaxel. If not picked at very early, it can cause a problem later. A drug too low, morphine, which is used 4 hourly, that's the required dosing. The patient gets better benefit when it is used like that, but sometimes prescription come with 8 hourly or 6 hourly dosing. I won't go through all these things, but these are some examples. High dosing, vincristine, actually is used at a dose of 1.4 milligram per meter. That's the parameter. But based on toxicity, it's usually cautious that it's capped at 2 milligram. Outside this sphere, indirectly, the patient benefit from pharmacists' involvement in research field. Pharmacists are listed as one of the investigators in clinical trials in cancer treatment. The pharmacists are responsible for everything to do with the drugs, the storage, the handling, compounding, and mixing of the drug. The pharmacists are currently carrying out research in the LUTS and other centers called the ARETA trial, which is currently going on. Pharmacists are constantly evolving and training themselves in the current best practices, and they are doing well in that field. Sorry, I'm moving very fast. You might be wondering, why are we not seeing the benefit in our center? There are challenges with the practice currently. These are lack of infrastructure, manpower, insufficient budget, and then sometimes pharmacists are not engaged in these centers. Pharmacists need to be engaged. Just like I'll leave us with this, just like I said, we are talking about multidisciplinary team. A chain is only as strong as its weakest link. If one part is weak, the whole is weak. These are the references, and these are centers, acknowledgements. And I will please want to acknowledge the industrial pharmacists, medical reps. They have really been wonderful, and I wish they can be part of the multidisciplinary team too. Thank you very much. Hold on.
Thank you very much. Thank you very much. I really say the pharmacy, yes, they are indeed a member of the team that makes things work. Interestingly, I saw that my hospital is one of the hospitals has acknowledged, University of Benin Teaching Hospital. Yes, we have a clean room and we have the pharmacists that consider our drugs. And I can tell you that we are doing very well. So a few announcements before we continue. There is a Nissan car key that was left upstairs. Yeah, I can see people checking their pockets. So if it's yours, just kindly know that the key has been picked for you. Then CME are also available for those who need. We have CMEs available. Thank you very much. Our next presentation will be advanced radiotherapy. Advanced radiotherapy, we're having Professor Dr. Salem Yanek. He is a consultant radiation, she's a consultant radiation oncologist, American Board of Radiation Oncology. She'll be talking to us this afternoon on advanced, please come up, advanced radiotherapy. Thank you.
Good afternoon, and hopefully it will be easy because I know everyone is completely disconnected, including me. Anyhow, let's start. You know, I'm talking about the advanced technology, which is advanced technology in radiotherapy. I have to just give you an example about the two machines we're using, which is the tomotherapy and CyberKnife machines in our center, which is part of somehow advanced radiotherapy, as is completely different from the other machines they are using for radiotherapy. Now for CyberKnife, I have a small video. You can have an idea, because when any physician send the patient for CyberKnife treatment, he will have some ideas, you know, how the treatment goes. Oh, no. How can I run the video? How can I run the double? How? Yeah, I just want to run this video about CyberKnife. You cannot run the video? So in general, you know, when are you able to run it? Yeah. It's just a video, you know, about the CyberKnife, the way how it goes step by step. Give an idea for all the physician how it goes, because a lot of physicians, they have no idea how it goes. Yeah, just run, you know, the play button. Okay. It's not working? No problem. Okay, so
SRS and SBRT innovation. Its unique architecture and a linear accelerator mounted on a 6-axis robotic manipulator enables unmatched precision and versatility anywhere in the body. The patient workflow starts with a CT acquisition, the primary image for treatment planning. Digitally reconstructed radiographs are then generated by the CyberKnife system. These are virtual projections. The CyberKnife system leads SRS and SBRT innovation. Its unique architecture and a linear accelerator mounted on a 6-axis robotic manipulator enables unmatched precision and versatility anywhere in the body. The patient workflow starts with a CT acquisition, the primary image for treatment planning. Digitally reconstructed radiographs are then generated by the CyberKnife system. These are virtual projections.
okay, if it's not working, let's go back to the slides. You know, we can go faster.
Leads SRS and SBRT innovation. Its unique architecture and a linear accelerator mounted on a 6-axis robotic manipulator enables unmatched precision and versatility anywhere in the body. The patient workflow starts with a CT acquisition, the primary image for treatment planning. Digitally reconstructed radiographs are then generated by the CyberKnife system. These are virtual projections at a 45-degree angle perpendicular to the patient couch. Transferred to the treatment delivery software, they are later used as references for pre-treatment patient positioning and real-time motion tracking and correction. The CyberKnife system's fully integrated image guidance system aligns the virtual projections to X-ray images taken prior to treatment delivery for patient positioning and continually during treatment delivery for automatic beam correction. The CyberKnife system uses specialized tracking algorithms to track the skull, the spine, fiducials, or the tumor itself, depending on the target location. For lung tumors, the Xsite lung tracking algorithm can distinguish the tumor from the surrounding lung tissue. For tumors that move with respiration, the Synchrony respiratory tracking system monitors the patient's breathing motion in real time with an optical camera and LED markers placed on the patient's chest. Before initiating treatment delivery, the system automatically acquires a series of rapid X-ray images.
Okay, as you notice, can we go back to the slides, please? You know, this treatment, as you see in the video, is like completely, you know, relaxing, free, no stress, no anesthesia, and the patient have the treatment. Even he doesn't know if he's getting treatment or not. Till, you know, we wake him up actually after half hour from the treatments. So is painless, free of pain, and the patient goes home within like 5 minutes. He can go and drive, go back home. As you know, you see, this is a robotic, and this is the X-ray, and that's continuous tracking during the treatment. So any movement, even 1 millimeter, the machine will stop and you know, continue the treatment when the position is back to normal. And this the benefits of those CyberKnife. This is the benefits in general for all SBRTs and SRS. No anesthesia, no pain, and can be targeted small area and anywhere in the body. This is for tomotherapy radixact, also one of the advanced radiotherapy. The reason, you know, I have to talk about it because it's completely different from the system of Elekta or a true beam or clinic accelerator. Because as you see, there's no gantry going around the patients. It's like a CT scan. And the system goes with the helical treatment more than, you know, to have, you know, VMAT or ARC therapy, or, you know, IMRT with the normal MLCs, you know, in the head of the country. Can we run this video too? You cannot? It's a video, yeah. Okay. This is the MVCT. We do it before the treatment. And should be done before each treatment. And usually it takes about 2 to 3 minutes. And then we align the current MVCT with the planning CT to be matched 100%. And now is the treatment going on after the matching 100%. The beams comes from all directions around the patients in a helical position. And when it's done, the patient also go home. It's very fast and precise treatment. And the difference about, you know, the other machines with the Tomo radixact, that's we can manipulate the size of the field as long as we can scan during the donut. The other machines like the True Beam or the Clinic or Elekta, they have a limit with the jaw sizes, which is about like 20 centimeter. So any field beyond 20 centimeter, they have to match it with the different field, especially when we treat the breast with the supraclavicular region, or we have a long spine treatments. That should be matched with a different field to be able to treat the whole things. With the radixact can be all done in one field and one treatment. So no need to split the fields. That's the difference. And the accuracy about, you know, sparing the normal tissue is very high in the helical technique more than the VMAT and the ARC IMRT or 3D conformal treatment. This is the advantage of it, as I mentioned before, no need to split the beams and also sparing the normal tissue much better than the other machines. I would like to mention some cases has been done in the last few months before I come here. They are very interesting cases. The first one is a 27 years old female. She had a history of right temporal lobe epilepsy. And it's been like for 3 to 4 years. She has in multiple anti-seizures medications, even, the other medication being stopped because has no effect in it. They changed it now. She's in Vimbat, Breviact, and Fycompa. She's drowsy all the time because of this large medication of anti-seizures. They did MRI. They found a small cavernoma, which has some hemicentrin in it. That's been have some blood vessels with a malformation, and that's causing all the seizures and headache she having. And the size of this cavernoma, it was about 11 by 7 millimeter. So I give her 1 dose of radiation with the SRS, 16 gray, and it was to the 80% of acidosis line. We did the 6D skull. This is the plan of her. It's like a small area in the brain, didn't affect, the other tissue of the brain, and it's away from any critical organs. After 3 months of the SRS, she came free of seizures. She has nothing, but when we repeat the MRI, she still have the cavernoma, but there is no vessels malformation inside the cavernoma tumor. So basically, she's free of the medications and free of seizures. Case number 2, we have a young female, 33 years old female. She never smoked. She never exposed to anything. She had COVID infection. After 1 year, she continues to cough. Chest X-ray found a large mass in the left lung. With the staging workup, she had biopsy. It was adenocarcinoma. MRI of the brain showed 2 lesions suspicious for metastatic disease, one large in the right cerebellum and the other one in the right temporal lobe. The one in the cerebellum measures about 2.7 by 2.5 by 2.5. This is the largest one. Even the patient still completely asymptomatic from those lesions. And the other one is about 5 millimeter, just a small area. So what I did, I give her SRS fractionated to the big lesion. I give her 5 fractions, and to the small one, I give her 1 fractions of 18 gray. And this is the plan for her. She's done without any complications. The opposite, she was functionally really doing well. And after 2 months of the treatment, that's the change of the size of the tumor in the cerebellum. If you see on the left side of the screen, and now how does it look in the right side? And that's changing in the size. Even if I repeat the MRI after 3 months, is going to be completely gone, I'm sure, because SRS and SBRTs works really up to 1 year in the body. This is case number 3, which is a young female, 30 years old. She presented with the tectal plate glioma. She presented with hydrocephalus and changing in her vision. And she had a shunt, and the tumor, if you can see in the tectal plate, I don't know if you're able to see it. It's about, blocking the aqueduct canal, and that's why causing the hydrocephalus. And the mass is about 2.5 by 1.7 by 1.6. I give her SRS treatment, 5 fractions. The reason, is the small area, but give her 5 fractions because it's affecting her optic nerve, and I don't want to make more damage to the optic nerve. And after 3 months of the treatment, you can tell how much the tumor being shrunk in the size. In the bottom one is the original one, and in the top one is the new after 3 months. And she is completely asymptomatic. Her vision back to normal, and she has no headache. This is a lady, 54 years old, breast cancer. She presented with numerous lesions in the brain. She refusing to have any treatment. She thinks like whole brain radiation will cause her decline in her memories or cognitive, declining, and whatever. She said, I don't want to have dementia early because of the treatment. And follow-up MRI showed the progression of the tumor. She started having problem like heaviness behind her eyes, headache all the time. Finally, I told her, you know, you have no choice. You have to have the whole brain. She said, I don't want to have whole brain because it caused me dementia. I told her, you know what, let's do something, you know, we can play with the dose to minimize any toxicity. So what I did, instead of having 3,000 10 times, I gave her 200 centigrade for 20 times. And she tolerated really well. After 3 months of the treatment, all her lesions almost gone from the brain. And I told her, you know, you might continue with the improvement even after like 3 months from this treatment. And she was completely asymptomatic, all her pain gone. She has no heaviness behind her eyes, and her memory has nothing been lost yet so far. I couldn't spare her hippocampus because even her hippocampus was full of meds. So for that reason, I couldn't spare it. But what I did, I just manipulate with the fraction of treatments. Instead of 10, I give her 20 fractions. This is a case of 72 years old gentleman who has a history 14 years ago with the lung cancer. He has a COVID. It was very complicated in the vent. And then during the CAT scan, they found 2 new lesions in the right lung. One of them is about really with the PET scan. Both of them are lighting up with the vivid. And he doesn't want surgery. Even he's not a candidate for surgery because of his lung function. So I requested to put fiducial marks on the lesion, the big size and the small one. Since, you know, it's very close to the spine, we can track it with the exospine instead, you know, having fiducial marks. Even, you know, interventional radiology told me it's very hard to put fiducial marks to the small area. So he had 5,000 centigrade 5 times for each one. And I repeat the images after 6 months, and you can tell the 2 lesions completely gone. There's no active disease in this area. There's discoloration, you know, based on the PET scan because of the reaction to the treatment. How do I know this is reaction to the treatment? Because the reaction, you see it is matching our isodose line of the treatments. So that's why it's not like a progression, it's just a reaction to the treatment. But the brightness and the vivid of the PET scan almost all gone, actually 100%. This is another case for lung cancer SBRT, but we don't use fiducial, we don't use the spine. It's in the middle of the left lung. The patient refusing any biopsy, refusing any fiducial marks placement. She said, if you're able to treat me this way, it's okay. So the machine was able to follow the density of the tumor and having, you know, the treatment only to those lesions. And I can see it actually in our monitor, how the CyberKnife head following the density. You can see the density in the X-ray. That's with the continuous treatment. So with the breathing, the patient breathing normally, and the machine following this density with the head, you know, to give the treatments. I had her CAT scan after, and it's just a scarring tissue left. And I'm waiting actually for her PET scan next month. This is a lady, she's an opera singer, and she's from South Africa. She told me they found a big meningioma in my suprasellar area, and I need to go to Belgrade because I have a concert. I need to sing. I told her, you know what, if you come tomorrow, I can treat it, because the neurosurgeon, they said, we cannot touch you because this is very risky area to have surgery for that. So she traveled from South Africa to Dubai. And then in the next day, I simulated her. I made the mask for her. The following 5 days, she had the treatment. The next day she finished the treatment, she traveled to Belgrade to do the hair concert because she's an opera singer. So I called her, how are you doing? She said, I'm perfectly normal, because she presented with a change in her vision, with the headache, and she was completely normal. But I put her in a high dose of a steroid just to prevent any kind of swelling during her travel. This is an example about the trigeminal neuralgia. I just want to show you how small area we're treating the roots of the nerve. It's like 4 by 4 millimeter. And we give high dose to that small area to relieve for the pain. This patient had the treatment. After 3 weeks, he was free of the pain. This another case too. See how small area, we're treating in the root of the trigeminal. This is another case for brain mets. After 2 months, it's completely gone. This is from non-small lung cancer. No surgery, nothing, no debulking, nothing. It's just radiation treatment. This is a recurrence of oligodendroglioma, and we give 2100 centigrade to that small area, and after 2 months, the whole lesion gone as well. And that's, some samples, I mentioned how, the treatments be very precise, very active, and very, we have really good response to the treatment so far. I'm following these patients, once a while, because you cannot see the results, in the next week. You cannot see it in the third week. You have to wait at least like 3 months to 4 months. Sometimes you have to wait 1 year to see the results, especially when you're dealing with the benign tumors. Any question?
Thank you very much, Professor. I can really tell, indeed, advancement in radiotherapy. Very quickly, we'll have a short tea break. But before then, those that want certificate for participation, please kindly make sure your emails are written correctly. We'll be sending them to the emails. Please go and check and make sure it is correctly written. Secondly, 2 buses will be available from 6 p.m. One will be going to the hotel. Another may be going directly to the venue of the dinner. For those that still want to go and change, dinner will be at 7:45 p.m. There'll be transportation to the dinner. Meanwhile, please, we'll kindly just go out, get our tea break, and come back immediately. Just pick it and come in here to have a tea break. We'll be starting this continuation as soon as now. Thank you very much.
Hello. We're about to start the next session, please. Dr. Agbubuega, if you're ready, we are ready. Dr. Agbubuega, if you're ready, we are ready. $20 minutes.
Good afternoon, everybody. So this evening, I'll be presenting role of CDK4, CDK6 inhibitors in breast cancer. Okay, thank you. So my disclosure, that's Novartis, and that's the outline. Global Count 2020 estimates global cancer burden that's risen, and breast cancer represents 1 in 4 cancer diagnosed in women, commonest cancer diagnosed globally. The age standardized incidence in 2018 was 37.9 out of 100,000, and Nigeria was a leading country with burden of 26,310 cases, followed by Egypt. The unmet needs of the current treatment option in advanced breast cancer. We've seen that despite the number of treatment options for patients with advanced breast cancer, unmet needs still remain pertaining to disease control. Then we want a situation that we can prolong the interval to intensive cytotoxic therapy and treatment-related complications. Then we want a situation where there's greater need for less burdensome treatment regimen to patients and their caregiver. There should be reduced healthcare costs. And also there's positive of treatment study of advanced breast cancer in premenopausal women. The treatment guideline, following immunohistochemistry, there's ER, PR, or A2 status that is checked. And this with various combinations gives Lumina A, Lumina B, triple positive or triple negative breast cancer. The treatment decision is based on endocrine-based therapy. It could be either using endocrine-based therapy, anti-HER2-based therapy, chemotherapy, radiotherapy, or targeted therapy. The treatment guideline by European Surgical School of Oncology and ESMO. In premenopausal women, the goal is to have ovarian suppression, then you move them to the same treatment. Sorry, premenopausal women with hormone receptor positive and HER2 negative status. The goal is to have ovarian suppression, then follow them with the same treatment as that postmenopausal women. That's endocrine therapy. So either use tamoxifen is the only available endocrine option, and followed by, which is actually considered a less effective option other than the other endocrine therapy. So a CDK4 or 6 inhibitor combined with an AI or fulvestrant is the first or second line for de novo or recurrent advanced breast cancer. And this is usually combined with LHRH agonist. For postmenopausal patients, the preferred first-line endocrine therapy is either AI, tamoxifen, or fulvestrant. And this depends on the type, the duration, and the time elapsed since the adjuvant therapy. So CDK4/6 inhibitor can be combined with AI or fulvestrant in first or second line de novo or recurrent advanced breast cancer. And this is in cases of primary or secondary resistance in the initial endocrine therapy. Alpelisib with fulvestrant is also an option if this patient progress on CDK4/6 inhibitor. So summary of the treatment guideline. Breast cancer guideline as produced by the ESMO and the NCCN. There's recommended ovarian suppression for premenopausal women, followed by same treatment as for postmenopausal women. For postmenopausal women, there's a combination of CDK4/6 inhibitor with an AI of fulvestrant. Is a treatment option in first line. NCCN guideline also recommend either tamoxifen or AI in an adjuvant setting, combined with ovarian suppression in premenopausal women. Also, endocrine therapy for postmenopausal women. Targeted therapy such as CDK4/6 inhibitor in the first line, mTOR inhibitor or as second line, and alpelisib as third line. So the overall survivor is the gold standard endpoint for any oncology clinical trial to measure the efficacy. And overall survivor is determined as the time from randomization until death from any cause and is measured in the intent to treat population. Overall survivor is considered the most reliable cancer endpoint, and when studies can be conducted to adequately assess survivor, is usually the preferred endpoint. The current clinical guideline recommended is also to assess the health-related quality of life. Apart from with a reduced advanced breast cancer, however, is associated with reduced quality of life. So introduction to CDK4/6 inhibitor. The mechanism of action, CDK4 plays a vital role in breast cancer progression. It's been noted to be responsible for luminal epithelial proliferation in breast cancer, and it's also been shown to be required for tumor formation. So any agent that can block CD4 targets is actually going to be very effective, especially in advanced breast cancer. Okay, so that's ribociclib blocking CDK4/6 targets. CDK4 and 6 inhibitor in advanced breast cancer by ribociclib. Ribociclib is a kinase inhibitor indicated in combination with AI in the treatment of pre or perimenopausal women. That is by Mona Lisa 7 study, and postmenopausal women, Mona Lisa 3 trial in women with hormone receptor positive and HER2 negative advanced or metastatic breast cancer as the initial endocrine-based therapy. And Mona Lisa 3 trial is the combination of ribociclib with fulvestrant in postmenopausal women with hormone receptor positive, HER2 negative, advanced or metastatic breast cancer, either as first line or also in second line. So the question is, are all CDK4/6 inhibitors the same? Looking at this structure, we can see that there's difference in these molecules. Ribociclib, palbociclib, abemaciclib. So with this difference in the structure, definitely will not be surprised if there's difference in the action and side effects. So all CDKs are not the same. The 3 approved CDK4/6 inhibitors, they work in a similar way to inhibit the CDK4 to achieve the efficacy in advanced breast cancer. However, there's difference in their selectivity for CDK4 versus other CDKs, which sets them apart. Looking at this, ribociclib and palbociclib seems to work the same way, but there's a huge difference with abemaciclib. Abemaciclib shows a high level of off-target inhibition beyond the CDK4 and 6, and that it has a relatively high potency for CDK9 compared to ribociclib and palbociclib. This selective difference, CDK4 inhibition is efficacious in breast cancer cell line. CDK6 inhibition leads to the hematological side effect, that's the neutropenia, and CDK9 inhibition leads to the GI side effects, and this is majorly seen in abemaciclib. The clinical relevance, ribociclib and palbociclib has higher neutropenia compared to GI toxicity, whereas abemaciclib has higher GI toxicity because of the CDK9 inhibition. So the targets, the relative inhibition of CDK4 estimated to be a dose-limiting adverse event as a result of CDK4 or CDK9 inhibition. But this varies, is similar in ribociclib and palbociclib and varies in abemaciclib. So summary of the ribociclib data. Mona Lisa 2 trial is a phase 3 ribociclib plus letrozole in hormone receptor positive, HER2 negative advanced breast cancer. It was conducted in postmenopausal women with this hormone receptor positive, HER2 negative advanced breast cancer. No prior therapy for advanced disease, and they were put in 2 arms. First arm had ribociclib at 600 milligrams per day, 3 weeks on and 1 week off, plus letrozole at 2.5 milligrams per day. And the other arm has placebo plus the letrozole. The primary endpoint is the progression-free survival. The secondary endpoint is overall survival, which is key. Then overall response rate, quality of life, safety. And the final analysis, there's a 33% risk reduction in the ribociclib arm compared to the placebo arm. So here also, looking at the progression-free survival, for the ribociclib arm, it gives 25.3 months compared to the placebo, which is 16 months. Mona Lisa 7 is conducted, this is the biggest and the only study for now, conducted in pre- and perimenopausal women who are hormone receptor positive, HER2 negative, advanced breast cancer. In this trial, women have not had any prior endocrine therapy for this advanced case, and they've had only 1 or less line of chemotherapy for their advanced disease. 2 arms, the first arm had ribociclib at 600 milligrams per day, 3 weeks on and 1 week off, plus tamoxifen and goserelin. And the other arm has placebo plus tamoxifen and goserelin. The primary endpoint is progression-free survival. The secondary endpoints were overall survival, overall response, clinical benefit rate, the safety, and patient reported outcome. So Mona Lisa 7 is the only dedicated study and the largest trial in premenopausal women evaluating a CDK4/6 inhibitor in hormone receptor positive, HER2 negative advanced breast cancer. The primary endpoint, which is the primary progression-free survival, the median PFS in ribociclib arm was 23.8 months, and in the placebo arm was 13 months. The secondary endpoint, which is the overall survival, it gives a 29% relative reduction in risk of death in the ribociclib arm compared to the placebo arm. Mona Lisa 3 trial is a phase 3 placebo control study of ribociclib plus fulvestrant, conducted in women, postmenopausal women, and men with hormone receptor positive, HER2 negative, advanced breast cancer, who has had one or less line of prior endocrine therapy for the advanced disease. The two arms, the first arm had ribociclib at 600 milligrams per day orally, 3 weeks on and 1 week off, plus fulvestrant at 500 milligrams, while the second arm had placebo and fulvestrant. The primary endpoint was the progression-free survival. Secondary endpoints were overall survival, overall response rate, clinical benefit rate, time to response, duration of response, time to definitive deterioration of ECOG performance score, patient-reported outcome, the safety, and the pharmacokinetics. And then this also gives 33% risk reduction in the ribociclib arm compared to the placebo arm. The primary endpoints, which is the progression-free survival, in the ribociclib arm, it was 20.6 months, and in the placebo arm was 12.8 months. Overall survival, which is secondary endpoints, in the ribociclib arms, as at 36 months, in the ribociclib arm was 67% of patients were still there, and whereas 57.8 in the placebo, 58.2 in the placebo arm. By 42 months, 57.8 in the ribociclib arm and 45.9 in the placebo arm. The Mona Lisa 3 exploratory endpoints, which is overall survival significance, it shows that ribociclib plus fulvestrant continue to demonstrate a clinically relevant, more than 1 year overall survival benefits. Mona Lisa 3 efficacy, the median progression-free survival with ribociclib was 33.6 months in first line, compared to the placebo, which was 19.2. But if used in second line following early relapse, the PFS was 14.6 months in the ribociclib arm and 9.1 months in the placebo arm. So it shows that ribociclib prolonged overall survival benefits, regardless of whether it was used as first or second line setting. So across the Mona Lisa 3 and Mona Lisa 7 studies, these were the 2 studies that were conducted in postmenopausal women. The first was using combination of ribociclib plus letrozole, and the Mona Lisa 7 was ribociclib plus fulvestrant. It gives a time to first chemotherapy was longer with ribociclib plus placebo. Also, in patients with liver metastasis, they also benefited from treatment with ribociclib. Liver metastasis under Mona Lisa 3 gives a 37% relative risk reduction. In Mona Lisa 7, it gives a 47% relative risk reduction. Talking about safety profile of ribociclib, the major AEs, adverse events of all grade, were hematological adverse events. First on the list was neutropenia in ribociclib plus letrozole. Also in placebo plus letrozole. Here we can see any grade under ribociclib to be 74.3 compared to 5.2 on placebo. The non-hematological AEs include nausea, infection, and then towards the end, increased ALT, increased AST. In the ribociclib plus letrozole arm, patients experience grade 2 QTF, and then patients also experience grade 3 QTF, that's on the ECG, and no dose reductions were required. The quality of life studies. Across the Mona Lisa trials, the addition of ribociclib to the endocrine therapy maintained or improved the overall quality of life. In Mona Lisa 2 on treatment, the health-related quality of life scores were consistently maintained and were similar between arms. In Mona Lisa 3, patients receiving ribociclib plus fulvestrant also maintained health-related quality of life, and the same thing also in Mona Lisa 7. Across this, ribociclib-based combination also induced a rapid and sustained reduction in pain. It was as early as 8 weeks, and it was sustained up to cycle 28. Progression-free survivals was also extended with ribociclib. A longer PFS2 was observed when patients receiving ribociclib plus fulvestrant compared to placebo. This demonstrates that patients had improved benefits even beyond disease progression. High ESMO magnitude. This triangle is ESMO magnitude of clinical benefit scale score. It also reflects a positive benefit of treatment with ribociclib. The highest is 4 and 5. With score 5, ribociclib plus endocrine therapy achieved score 5. Ribociclib plus fulvestrant achieved score 4, and ribociclib plus letrozole achieved score 3. So this is a validated and reproducible scale aiming to facilitate improved decision-making regarding the use of anti-cancer therapy. So these are my references. So in summary, we are seeing the benefits of CDK4 and 6 inhibition in advanced breast cancer patients, both premenopausal, that are hormone receptor positive, HER2 negative, either premenopausal and postmenopausal. Thank you.
Thank you very much, Dr. Adegboyega. Like I said, we'll be taking questions later, not now. Thank you. Dr. Benedict Ekaidem, now to come and take oncofertility resource poor settings, barriers and opportunities. We'll take him up next from Federal Medical Center, Jabi, Abuja. Thank you.
Good evening, everyone. It's an incredible honor to be here to speak this evening. And I want to begin by congratulating the Association of Radiation and Clinical Oncologists for your successful annual general meeting and scientific conference. And I walked in and saw the theme, and I thought the theme couldn't have been more apt, really. Redefining cancer care in Nigeria. And I'm here to speak on something that really, really touches on that, redefining cancer care. Oftentimes, cancer is seen as always, the death end of things. But with this presentation, we have some light at the end of the tunnel. I'll be presenting an onco-fertility. My name is Benedict Ekaidem. I work as an obstetrician gynecologist with interest in infertility and IVF at Federal Medical Center. Onco-fertility, like, okay, before I think I have nothing to declare, and I'll go through my presentation with this outline. I'm going to introduce, we'll look a bit at the evolution of onco-fertility. We'll look at the burden of cancer, and I'm not sure I want to belabor that. I'm sure you've heard, you all here work in cancer, so you know so much about that. And then we'll look at the current practical aspects of onco-fertility. We'll probably cite a few examples, practical experience-wise, and then look at what the barriers currently facing us in this part of the world are, and the opportunities that we should try to leverage on. Oncofertility is an emerging field that indeed has gained global attention in recent years. It actually focuses on what used to be, ignored before now. Oftentimes, when someone gets hit with a cancer diagnosis, the focus is always, how do I knock off the cancer cells? And how do I try to get these patients to live? And I must also congratulate all of you here as oncologists for the fantastic work you're doing, because you have succeeded in actually improving the figures, as it's reported worldwide, that we now have cancer sufferers, survive, much longer. And so when that happens, quality of life actually becomes an issue. And when we talk quality of life, people begin to look at whether they want to have children or not. And like we know, most of the things that happened is probably not in this environment. But I'm sure we all know that cancer does not discriminate. Cancer affects all of us. So we would try to put a challenge that every one of us, every person involved in cancer care should be awake to all those barriers and probably the opportunities, that's present for possible preservation of fertility in cancer patients. The term actually, oncofertility, was coined by Teresa Woodruff. She's an American at the Oncofertility Consortium. But however, before now, it's not like there was no practice of oncofertility. There was some practice of oncofertility, but it was on an individual and ad hoc basis. It actually was when there was the signing of the National Cancer Act in 1971, that led to the series of funds that were released, to the National Cancer Institute, and coordinated research and medical advances, that followed that led to what we now see and know as an oncofertility. So, like I said earlier, you begin to have treatments, even with children, so that survival from cancers began to increase. And once that happens, then, fertility and quality of life becomes important. The Oncofertility Consortium, as it is, almost about the most popular now in the United States, has expanded globally to almost 43 countries. But interestingly, in this part of the world, not so much is being done, by way of collaboration. What people do, fertility clinics do, is individually, you have some fertility clinics who practice some levels of oncofertility, but there's no concerted and coordinated effort towards consciously looking at fertility options in patients that have had cancer treatment. I don't want to belabor you with these. I know you all know the figures, but it's important that we know that the burden is still high. Breast cancers, lung cancers are almost like the commonest worldwide, as well as colorectal cancers. But one interesting thing that has been reported is that there is now a very high survival rate for for these cancers, and at least 50% has been reported for breast and colorectal cancers. So what does that mean? That means that if you have somebody with a breast cancer diagnosis, most likely, most of them will live, for a good number of years. And if they live for a good number of years, why not? They start thinking about, how can I get pregnant? How can I have children? So, and meaning that every oncologist in this hall should always be thinking, because it may not just be about treatment of the cancers alone. Again, in children, an estimated 400,000 children and adolescents of 0 to 19 years develop cancer. And like we know, most of the common cancers are hematological, leukemias, brain lymphomas, and solid tumors. It's been recorded that is the success is even better in children in pediatric cancers. So much so that about 80% of children with cancers actually get cured. What does this mean? It means if a child gets cured, the child is going to live longer. And of course, I mean, gets to adulthood and will have to want to have a child. So we all know that prevention of cancers is what everybody tries to preach. But I'm sure we're also very convinced that no matter how this is preached, that cancer still happens. But it's very good that it's been documented and in literature that early diagnosis, prompt treatment has improved survival, like I said. And I don't want to belabor you with the fact that the options typically would be chemotherapy, surgery, or radiotherapy. Now, one thing we must say here is that in the bid to try to do this, the rapidly dividing cells of the gonads, which are the key cells that actually will lead to procreation, gets knocked off in the process. So what you have in terms of gains from survival of cancer comes at a huge cost to what happens, as far as gonadal function and the endocrine function is concerned. Presently, when we talk of oncofertility, there are certain established treatment models that people adopt. And as a practitioner personally, there are certain patients, I have some experience in treating patients with these options. But I'd like to break them down into what we do for whether males or for female cancers. So for men, if you have for males and pubertal boys, post-pubertal, really no problems there. Typically, we're going to extract the sperms. And of course, these days, it's very easy to cryopreserve sperm vitrification. It's excellent. And post-thaw, always you're going to have some good sperms to work with, usually by in vitro fertilization. So, but problem happens when you have these boys that are pre-pubertal. Most of what is documented is still at the experimental stage as of now. There is the possibility of cryopreservation of testicular tissue, meaning you biopsy testicular tissue and you cryopreserve. There's been some successes recorded, but it's still very much at the experimental stage. For the women, typically, again, once they are in the adulthood, 16 years and above, what typically you do is to go through controlled ovarian stimulation and be able to do oocyte retrieval. And if the woman is in a relationship and has a partner, because embryo cryopreservation is more successful than oocyte cryopreservation, we usually would prefer to do embryo cryopreservation. But in a situation where you have single women, oocyte cryopreservation is also very, very efficient these days. So that is offered and it's easy. Now, there is a situation where typically that it happens in most cancers, there's always a problem with time. There's no time. So if we think that treatment can be delayed for up to 2 weeks, yes, we always consider what method that we have said earlier, which is controlled ovarian stimulation. But in the process, it's been documented by evidence that when you also give gonadotropin releasing hormone agonist to these patients, that it tends to also improve the yield and also confer ovarian protection before you give your chemotherapeutic regimens. For women who have hormone-sensitive cancers, the use of aromatase inhibitors like anastrozole, letrozole has been shown to be very, very protective as it prevents rise in estrogen levels. So for pre-pubertal girls that are not eligible for hormonal stimulation, ovarian tissue cryopreservation and reimplantation later has actually been explored. Yes, pregnancy and live birth has been reported, but it's still considered experimental because the numbers are still few. It's there's uncertainty to a large extent that if we if we biopsy the ovaries and then cryopreserve, that sometimes if the cancer had affected the ovary, you may be reimplanting the cancer cells onto the patient at a later date. But there are some novel techniques that have been looked at, which scientific research is still ongoing. One is the in vitro development of sperm from cryopreserved testicular tissue. Like I said earlier, this is pretty much still experimental, not much success, no success in humans, but successes have been recorded in mice. Then in vitro maturation of ovarian follicles from cryopreserved ovarian tissue is also been reported to be successful in humans. Also, gametogenesis from pluripotent stem cells, from mesenchymal stem cells, meaning you convert mesenchymal stem cells, not gonadal stem cells, by some manipulation into gonadal stem cells. This has actually been successful in rodents and is a way that can solve the problem of loss of gonadal function, but is still at the experimental stage. Now, the scientific world is also beginning to look at, since the problem is in the damage that comes from chemotherapy and radiotherapy, the scientific world is also looking at the use of certain options like sphingosine 1-phosphate and imatinib, to be able to reduce gonadal damage. But this is still under investigation. The same thing too with transplanting the uterus, which of course technical safety and ethical issues has been highlighted, as well as the risk of malignancy, since one usually would need to put patients on immunosuppressant drugs. So generally speaking, oncofertility is much established in high resource settings, but not much is done in this part of the world. And we, in this part of the world, can overemphasize the problems that have emanated from the same things we keep talking about: poor resources, access to expertise, cost, to issues of cultural, social dimensions. All of these has hampered the adoption and widespread implementation in this part of the world. The Oncofertility Consortium in the US is one that started out and has actually spread across the whole world, and it's been able to bring professionals across disciplines together, to be able to look at patients, care of cancer patients in a more holistic manner, and not just looking at the oncologist treating the cancer. Maybe the gynecologist does his own work and every other specialist does his own work, but to begin to have collaborations, so that the care of cancer patients is very holistic. And these are the kinds of things that we in this environment should begin to think about, At every point that you have a cancer patient in front of you, ask yourself one question: is this cancer patient within the reproductive age group or the pediatric age group, whereby there would be concerns for future fertility? Yes, there are clearly barriers, and these barriers are things that we see on a daily, and we'll probably just go through a few of them, but not to say that we should look at those barriers as what should stop the progress from achieving success in oncofertility. One of the barriers to the oncofertility care in this environment, obviously, is at the patient level. Usually, like you have a diagnosis, there's always time is short. The oncologist wants to make a decision and start treatment. Prognosis is poor, and all of that. All these are things that can limit. Sometimes the patient is less than 18 years, and decisions will have to be made by parents. Cost of treatment, cost of care in oncofertility, cryopreservation is quite high and can be prohibitive. So there are also barriers at the level of the provider, where we have relative paucity in facility manpower for treatment in oncofertility, and we have health system barriers, as well as societal level barriers. Societal level barriers obviously will be what is very common in the environment. Typically, we have disparities in referral for fertility preservation, and this is reported across educational level, cancer type, age, marital status, race, and ethnicity. In our own environment, cultural factors dominate. Religion is always a factor. People don't want things that look innovative for some certain reasons. So these are all barriers to us making any meaningful progress in this environment as far as oncofertility is concerned. But it's not all about barriers. Really, at this conference, we should begin to look at what gains we can make from what we have as an institution. And I do know that in Nigeria, there have been some efforts by certain persons to come together and try to see what can be done. One of it is the Oncofertility Specialist Association in Nigeria. But I'm not sure how much progress has been. I've personally tried to reach, persons in the association. I've gone to the website, tried to reach, so not much is really being done. I'm particularly putting this challenge to the oncologist. Why? Because I feel that the oncologists tend to see the cancer patients first. And I think the oncologists can actually drive the process. Oncologists who see the cancer patients first can decide. I am here and very proud about a colleague of mine who is in this hall, who I actually work with. And every time she sees a cancer patient, she refers the patients to me. So, and I want to encourage every oncologist in this hall that you are usually the first person meeting the cancer patient. You can initiate the process. A lot more can be done. We can all come together and begin to give oncology practice a different outlook. There are opportunities, definitely. There are so many fertility centers across Nigeria right now. The same way, I also have some decent number of cancer care centers. All that is needed is for the team of oncologists, team of fertility people to begin to come together, collaborations, and collaborate on all fronts and see how the care of patients can be holistic and always look at the quality of life and fertility and not just cancer. After all, you have done very well in treating patients that patients now live, and should actually also enjoy some better quality of life. So this is BT coordination. And in conclusion, I would say that there is a global increase in survival rates following cancer treatment. And need for improvement in quality of life has led to the emergence of oncofertility, making it an essential part of comprehensive cancer treatment plan in children and reproductive age group. The lack of awareness, poverty, cultural beliefs, and high out-of-pocket cost of cancer treatment are some of the barriers to oncofertility in our environment. Healthcare professionals in low-income countries like ours should not be discouraged. Rather, should be encouraged by the fact that there are available tools for us to make progress in oncofertility. And it takes everyone to be involved in cancer care. And really, everyone in this hall seeing a cancer patient should think oncofertility and quality of life. Thank you very much.
Thank you very much, Dr. Kaidem.
Please, can we give a round of applause? Dr. Benedict Ekaidem actually prepared this lecture for us within 4 days. We contacted him just 4 days ago, and he was able to come with this brilliant lecture. Thank you so much for supporting Association of Radiation and Clinical Oncologists of Nigeria. We are truly grateful that you found time to come and do this. He is the head of Department of Obstetrics and Gynecology at the Federal Medical Center here in Jabi. He holds a master's degree in reproductive medicine from the University of South Wales. Thank you again, and I think it's important that I mention this, So another round of applause for this gentleman. And I think you can continue. There's just, I think I was told one question only. One question before we invite Dr. Any question? Yes. Question from University College Hospital, Ibadan, head of department. No name. From your village.
Yeah, sorry, mine is a comment, but anyone that has question can still ask the question. So I have to thank the presenter for a very job well done. This has actually been a concern for most of us who have been seeing our patients. The Nigerian group that you talk about, I was in their platform, but I don't seem to know what is happening, and then those who are leading, and then also knowing whatever they are doing. So my question is, although there are challenges, but we have to start something. Is there anything that we can start with to your own knowledge or availability facility, even if to do something, have all those things, so that later we can now look for ways to look for things, to look for the legislation and then improve from it. Because we need to start something, no matter how small, even if it's a partial facility that we can do, and then maybe connect or collaborate with others somewhere, so that we can be able to at least start. Because the way I see it is maybe 1, 2, or 3 people that can start this thing before others will see the need. If we allow it for the larger population or larger group, nothing may seem to be done, because there'll be arguments left and right, why things wouldn't work, why it will work. But some few people need to take a step and then start it, even partially, then we can progress and take off from there. Thank you.
Thank you very much. Now, is there anything we can do? Oh, yes, there's so much we can do. Like I said, there is some form of association, in place. And I do know that there have been people who have tried from mostly the reproductive medicine side of things. Okay, but I would say that from a personal experience, that the fact that we have so many fertility centers across Nigeria today, the fact that they render quality service, and most of them offer cryopreservation techniques, very decent ones. So meaning they can freeze gametes, they can freeze embryos, they can recover them after years. It means we can do so much. I think all that is required is for us to leave this place and begin to think of collaboration first and foremost at the institutional levels. Some of us work in hospitals, we have colleagues, to begin to look at collaboration at that level. And then at the larger level, the association, perhaps, of radiation and clinical oncologists can find a way, together with maybe Society for Obstetrician and Gynecologists of Nigeria. At that level, there has to be multidisciplinary collaborations. And associations, in my view, should be able to come together, and leaderships of those associations can do much more when conferences are held like this. And that's why I'm very pleased that the association thought about this. So first thing is to have this talk going on. Let everybody talk oncofertility first, like it's being done here. And then at your institutional levels, you begin to collaborate, and then take it to the levels where we can have associations come together. Of course, naturally, taking it to policy level and government will be actually the final, icing of it. So I think we should all leave here challenged. There's so much each of us can do individually and as a group. Thank you very much.
I want to thank you very much for that presentation. Please, for lack of time, if you have any question, the presenters, some of them are still around, kindly just go out, reach out to them on a one-on-one basis and ask your questions. Thank you very much. We will be having the last presenter now, After which Dr. Bello will be invited to wrap up this session.
Thank you very much once again, Dr. Ekaidem, for the very interesting presentation. The last presenter for today will be Dr. Foluke Saramuye, and she'll be talking about redefining cancer care, the overlooked member of the caregiver. Welcome.
Good evening, everyone. Actually, this is an impromptu presentation. I wouldn't be talking on what Dr. Popola said. I'm actually filling in the slot for the presenter that ought to be talking here, but I'm actually glad for this. I'm sadly pleased that we have the opportunity to do this. So I'll be talking about developing empathy in oncology healthcare professionals. So I just want to talk about psycho-oncology first before I go into my main topic. Psycho-oncology is an oncology subspecialty that focuses on the psychosocial and spiritual well-being of cancer patients so as to ensure treatment adherence, effective coping, and improved quality of care. Psycho-oncology has been in existence since the 1970s. It was founded by Professor Jimmy Holland in the United States. And over the years, so many psychologists, psychiatrists, physicians have been trained. And one of them happens to be the trained psycho-oncologist through Professor Jimmy Holland is Professor Choma Azuzu, who is actually the founder of Psycho-Oncology Society of Nigeria. So this society was created in 2006 with the objectives of offering psychosocial care services to cancer patients and their caregivers, organizing trainings to build capacity of oncology clinicians to provide psychosocial care, to conduct behavioral research that could improve clinical care and act as patient advocates. So the society was inaugurated in 2011, which at University College Hospital Radiation Oncology Department. And over the years, we've had workshops, we've had conferences. We had our last, our 11th national conference in June. And in collaboration with the Radiation Oncology Department of University Ibadan, we have an MSc program in psycho-oncology. If anybody is interested in pursuing a career or the career in psycho-oncology, please see me after this presentation. I've been told I have just 10 minutes. I know everybody's fatigued and we're all ready to go home or to the dinner. So what is empathy? I wish there were more healthcare professionals here and to listen to this book. I believe we'll have the slides and it will be sent to people's emails. How is it different from sympathy? Empathy is the power of exploring, perceiving, and imagining what another person is going through. It involves observation, understanding, acceptance of somebody else's situation. This can occur without liking, forgiving, or agreeing with the person. It is not judgmental. While sympathy just involves feeling sorry for the person, and trying to put yourself in the person's shoes, but it involves a lot of, it's subjective, it's not objective. It involves a lot of analyzing, judging, and trying to understand. So the key differences between empathy and sympathy is that sympathy requires giving unasked questions. When somebody is going through something and person is trying to explain, you interrupt and then you begin to give advice. While empathy involves active listening. Active listening is that you're listening to what the person is saying without bias, not trying to interpret, but trying to understand objectively what the person is saying. Sympathy says, I know how you feel. Empathy says, I feel how you feel. Sympathy involves a lot of judgment, while empathy does not involve a lot of judgment. I would move on quickly. So why is clinical empathy important important for healthcare professionals, especially healthcare professionals involved in oncology care? We all know how debilitating generally NCDs harm, and how cancer is perceived in our environment. As a healthcare professional, one of the things that is one of the tools or skills needed is empathy. That how much more when it comes to NCDs, chronic diseases like cancer. So emotional empathy is the ability to sense how the other person is feeling and often expressed non-verbally and unconsciously. While cognitive empathy is the conscious appraisal of another person's emotional state through focusing and thinking about the situation. In other words, clinical empathy is the skill of recognizing another person's emotional state, feelings, and perspective and situation, communicating, understanding, and checking its accuracy, and responding to the unique needs of the patient to promote better clinical outcome. So it's important to say this, that clinical empathy is a communication skill. It can be taught, it can be learned. We often say that maybe sometimes my feel it's not my innate nature to be emotional, to be caring and all of that, but this is a tool. It's one of the communication tools that can be taught and can be learned. And that is why clinical empathy is divided into affective. I talked about emotional empathy, and then let me quickly go back. The two types of empathy. We have the affective empathy, and then we have the cognitive empathy. If you don't have affective empathy, it usually comes with people who are naturally, caring, loving, and emotional. But you can actually have cognitive empathy, which means you're thinking empathically towards that person. It's a conscious effort. It's a tool that can be learned. So why is clinical empathy important in providing oncology services? There are evidence-based scientific studies that shows its significance. Effective empathy communication enhances the therapeutic effectiveness of a doctor-patient relationship. Empathic communication has been associated with improved patient satisfaction and adherence to treatment recommendations. We've listened to several discussions and presentations today, and we can't take the fact that the reason why I gathered is because of, we can be to that 5 minutes more, is because of patients. So it is important that the patient-doctor relationship is good. So oncology healthcare professionals may actually be improving their own satisfaction and well-being. There's an inverse relationship between empathy and burnout. Some studies have shown that doctors or healthcare professionals who actually provide empathic care actually suffer less burnout compared to those who are less empathic to their patients or clients. So before we respond empathically to any patient, we must cease to have an empathic opportunity. I will just quickly run through, because I have just 5 minutes. What are the skills for developing empathic practice? You must watch the patient's facial expression, the body language, the tone of the patient, and then the patient's words. So we have the verbal skills and then the non-verbal skills. The verbal skills involves acknowledging or reflecting. It means like a feedback. When a patient sits and tells you that, okay, I had this lump 3 years ago. I actually went to see a doctor, then I went to see an herbalist and all those things. Reflection is that when you're feeding back the patient, you will say, I understand you said, I went to see a doctor 3 months ago. I noticed this lump 1 month ago. Validating and respecting the reason is almost intertwined. For example, a patient tells you that, I know it's when I take paracetamol. Paracetamol is what is causing this vomiting. Yours is not to analyze. Your one is just to respect the reason you feel paracetamol makes you vomit. Okay, I've heard that, I understand that, and you move on. So why nonverbal skills talks about your facial expression, your eye contact. A patient comes to the clinic, you see the patient is talking to you, expressing how they feel, and you're busy writing, you're not even looking up, you're having no eye contact with the patient, you're not pausing to hear what the patient is saying, you're not nodding, and then there's no vocalizing like, oh, I see. Things like that are non-verbal empathic skills. Touch and open gestures are socio-culturally sensitive. You have to take permission. There's some situations or some cultures that will not allow you to touch, the opposite gender. So you want to be very careful when you're practicing nonverbal skills, especially when it comes to open gestures and to touch. You could take permission that, is it okay, madam, or is it okay, sir, to just touch you, especially when some patients start crying in your consulting rooms. So I put this because of the COVID-19 pandemic, that maintaining empathy in remote consultations, where a lot of consultations were done via telephone calls and all that. So you want to have active listening because your person is not in front of you. So you want to hear clearly and distinctly what the person is saying. Then you're having your verbal expression, the tone of your voice, 2 minutes more. So you're not rushing the patient as you're listening to the patient. So what are the common challenges we find in communicating empathy to our patient? Time pressure. You have about 40 case notes in front of you. You don't have to asking, how do you feel? What are you doing? So that is the place of inviting. We talked about that cancer care is holistic here right now. It is, we need MDTs. If you cannot give the psychological attention to the patient or the counseling attention the patient needs, what you can do is that in your team, you should have a psychologist, a psycho-oncologist that understands how to relate to patients. So, or some people feel like if I start talking, I open a can of worms. I don't know what to say. I might say the wrong thing. So all that are some of the challenges in terms of communication. So I'll just move on. There also have been a role play, as there was time where there'll be a scenario between a doctor or an healthcare professional and the patient. The first case would be the healthcare professional would be nice, would actually practice all those nice empathic skills. And then the second scenario would be an healthcare professional and the patient who didn't practice the healthcare, who didn't practice empathic skills. So I was going to ask the audience that what were the things you noticed that the first health professional didn't do right or didn't do well? So what do you do to maintain your clinical empathic skills? Self-care. You can't give what you don't have. If you're stressed, you're burnt out, you're upset, you're angry, you can't come to the hospital to give care to the patient. That's just the simple truth. So we also, healthcare professionals need to take care of themselves very well so that you can, out of your abundance of what you have, your kindness and your love, you can also actually reflect that. The role of awareness, the practicing verbal communication of cognitive empathy. I talked about that some of us don't have the innate nature to be nice, to be kind, but there's cognitive empathy, not affective empathy. Now, where you purposely practice that. This is healthcare. It is one of my duties is to provide care in an empathic way to my patient. So I must consciously purposely develop the skill because I want a better clinical outcome. Some of the slides I shared that treatment adherence is actually has been shown. I mean, patients who actually had a better care or empathy from their doctors, and then asking for feedback from your colleagues too. If you're interested, how did I do today? Do you think I didn't do well? Was I nasty at the hospital? Did I behave well to this patient? Can also help you maintain your clinical empathy skills. So I leave you with this quote from a German pathologist that medicine is a social science in its very bone marrow. No physiologist or practitioner ought to ever forget that medicine unites in itself all the knowledge of the laws which apply to the body and to the mind. The body and the mind is very important. Thank you very much.
Thank you very much, Dr. Sarimi. At this point, we're going to invite the LOC chairman in the person of Dr. Bello Abubakar to come and wrap up the session. Mr. Chairman, sir, you're welcome.
Just before the wrap up, I would like to sincerely thank Dr. Sarami for bringing up that amazing presentation within 2 hours. My initial lecturer actually had surgery today, and that's why she couldn't participate, and we had to look for the member of the Psycho-Oncology Association, and luckily we have in the person of Dr. Sarami, who is also our financial secretary. So again, thank you. Another round of applause for her. So, distinguished ladies and gentlemen, my dear participants, I would like to sincerely thank each and everyone that has found time to be with us in the last 2 to 3 days. We've had an amazing pre-conference. that was sponsored by JNCI, and the people that participated was simply overwhelming. We were expecting about 70 people. We got 180 people. And I think that was a plus. There was also an immediate lecture on extracranial radiation therapy, science and craft. That was over 1 hour. We gave him 45 minutes, but he ended up talking to us for 1.5 hours. I think that was quite amazing. And in the last 2 days, we have listened to real science. We've heard the beauty of radiation oncology, how the narrative is changing, both in radiotherapy, in medical oncology, in therapeutics, in theranostics, and so on and so forth. I have learned a lot, and I want to believe that each and every one of us here has also learned something. So at this juncture, I want to sincerely thank each and every participant that has found time, especially our foreign participants that came thousands of kilometers away to listen to us, to help us to participate in our scientific conference. We are really, really grateful to all of you. We cannot thank you enough, but we hope that the collaboration will continue going forward. And we will want to thank you again and wish you safe journey back home. We cannot conclude this without thanking our sponsors and partners. They literally made it happen. Without their support, probably we would not have had this amazing conference. So we want to sincerely thank all our sponsors, both foreign and local sponsors. We have had very pleasant interaction with them and amazing supports that we were able to organize this, I want to believe, international standard conference. We want to thank also our event managers. Nick, are you somewhere here? Is Nick here? Xavier Communications that came to the rescue, because there are so many things as clinicians that we did not know about, digital age, technologies, fusion of images, and so on and so forth. They provided also the internet that was seamless, and we were able to have seamless presentations from India, from Middle East, and from other parts of the world. So we want to thank Xavier Communication for a job well done, even though we are paying, but we will ask for some discounts. Last but not the least, I want to sincerely thank the local organizing committee. They made this happen. It was not my job. Mine was just to be the slave driver, give instructions, and they were ready to learn. They were ready to do it. So please, thank you, thank you. Can we have the podium? Can we have the LOC? Where is my research assistant? Khadijat is here, who within few days was able to compose the agenda with few supports. She's a researcher in translational oncology, actually. Come. The LOC, please. Where are you? Basirat, the secretary, who I'm sure everybody knows now. Where's the LOC now? Come on. Okay, they are coming. Yeah. Dr. Tahir is here. Where's Dr. Tahir? Dr. Umar is here. Dr. Nwachuku and Dr. Shagaya are busy arranging the dinner, and I'm sure you will see them. The dinner, I hope you guys have not eaten. If you have, go and purge yourself. I assure you to be one of the finest you have attended. So the amazing LOC that made it happen. Thank you, thank you, thank you. And Anosike, yes, yes, yes. What of the people at the Chungwe and the rest? Okay. So please, can we have one more last applause for the LOC for making ACON 2022 a success? I think they have delivered. If you are happy about it, the credit goes to me. But if you are unhappy, the credit goes to them. So thank you. Yes, we made it happen. They made it happen. So thank you very much. Thank you indeed. Remember that there is an amazing dinner at Bolton Hotel. No. Bolton Hotel, Wuses on 7, on Kigoma Street, number 31, because I was living at number 28, so I know. So Bolton Park and Event Venue or Bolton White Hotel, Wuses on 7. We will have a bus. We will have a bus that will be transporting people here from 7. What time? Okay, they are here now and they are waiting. So they will go. They will do a couple of going and coming. So if you are not ready, you want to go and wear your dancing shoes, please feel free, go and do it. Those that are staying in hotels that are known to us, we will go and pick them up. Please, if you are staying in another hotel, just we have shared the location. If you are not on the Akon app and you need the location, just meet any one of us and they will be very happy to share the location for you. The dinner is from 7:30. Please don't miss it because I don't want anybody crying, please. Honestly, this is something that we have prepared. You will be happy. On that, I know, but I don't know about the conference, but the dinner, ladies and gentlemen, that's why I have not been eating for 2 days. Thank you, guys. Thank you. Okay, we would like to invite the president of ACON also to join us, the LOC.
Ladies and gentlemen, we had to pull this thing out from his hand. Dr. Bello Mohammed Abubakar is an amazing man. He is a true leader. He is fantastic, he's unbelievable. I did not think I would come across a man like this. He showed unbelievable leadership. He was strong, he's compassionate. We are all here. You are all here. My colleagues, this man deserves some gossip. Let us give him 3.
Sir.
Now I'm blushing, believe me, but I'm a black man. See the color blue. One other important aspect that will not escape all of us is the real launch of the Lancet Oncology here. That is history, believe me. That is history that is being launched under the auspice of the ASCON Scientific Committee. That document is not only for Nigeria, it's for Sub-Saharan Africa. And I know the commissioners that participated. I know the effort they made to produce that document. And that's why I was making noise that I was so proud I was IOTIC president at the time. We should be proud that that has been launched during the ACON conference. So kudos to Madam President for making it happen. We didn't participate, but she made it happen, and she was doing it teleguided from Enugu. So thank you again. And I think that is something that's really amazing. Only a woman can do that. Yes. So guys, this Madam President will urge you to close the meeting so that we can all go and have dinner.
Gentlemen, we thank you all for to have stayed till this very last end. Before I continue, I just want to add 3 bossas to the LOC chairman. Bossa, bossa, bossa. And then 5 more to the entire LOC team. Bossa. Indeed, they have been wonderful. We are all aware of the political and economic climates that we are facing ourselves with now, but it did not deter them. They continued on putting everything, and we are all the hard work and dedication today. It is indeed very commendable. Thank you, Dr. Bello. Thank you to the LOC team. If I knew all your names one by one, I would have mentioned it. Thank you so, so very much. And to everyone that has stayed till the very end, thank you. And of course, to my exco, those that are still around, the others are still trying to put 1 or 2 things together. We want to say thank you for your commitment, for your solidarity to ensure that this happened. As Dr. Bello said, the launch of the Lancet Oncology Commission report is a win for each and every one of us as Aconites. And we must not be shy in promoting that launch, the oncology reports, to our colleagues, to our peers, to everybody that is involved in the oncology ecosystem. To that end, if you need more copies, because we're very fortunate, the Lancet they intended to send 200 copies to us. But because we are Nigeria and the giant of Africa, the courier made a mistake and they sent 400 copies. But that, of course, is to our advantage. So please feel free, take as many copies as you want, not for yourselves, but to disseminate it at your various centers. Thank you very much. Thank you to the LOC. Thank you to everybody else. And from there on, we look forward to ACON 2023. God bless you all. Thank you. Did I say where? Have people ratified this?